2025 CD20 positive, and after seeing his daughters that she received chemotherapy with transplant and she passed away, he declined the treatment and declined the treatment. The key point is they both showed the BAL positive, CD22 positive, and further research required to establish familial associations. The next case, about father and son. The father, 84-year-old, in 2016, he diagnosed a non-secretory multiple myeloma and he treated with a VRD-based regime. Later on, lenalidomide maintenance was added around 2 years. Later, he became transfusion-dependent anemia and darbepoetin support was given. But unfortunately, he expired within five years after diagnosis due to the age and many comorbidities. In 2025, the son presented with the same complaints and he diagnosed as a small marginal zone lymphoma BNHL, and it was started bendamustine BR-based regime. The key point is that illustrates occurrence of the different hematological malignancies in the same families may reflect some genetic predispositions or environment or lifestyle risk factors. Not typically direct inheritance, but maybe some what's called. The next case about father and son. The father, 74-year-old, he came and he diagnosed as CMPA in 2016, and he's an hydroxyurea and still alive. Son, 49-year-old male. In 2025, he came and he diagnosed as CMLCP, and TKI inhibitor started on imatinib since April 2025. The key point, the father CMPN does not directly cause son CML, likely represents coincidence, predispositions, or shared environmental experience. Next is the father and son. Son, 28-year-old, diagnosed with the APML IR in 2023, completed treatment and currently under the follow-up. The father, 60 years old, he diagnosed with a small sigmoid colon cancer in 2024. Initially, he received the treatment and presented to the oncology in July 25 with rectovesical fistula. Underwent surgery, but sadly passed away within a few months. Colon cancer is often associated with hereditary APC gene mutations and lifestyle risks. So, son APML was caused by an acquired PML alpha translocations. These are distinct cancers with different causes, no direct link. There's a research required. Next case about CML. The elder brother, 44-year-old male, diagnosed with a CML CP 1 year ago, and he's on imatinib. He's achieved MMR. Younger brother, 39-year-old male, he developed similar symptoms, and the family was thinking that it might be the same CML, but we are not thinking. Then again he diagnosed as CML CP after 1 month, and again he was also started on TKI imatinib based therapy. The key point that two first degree relatives with CML is very rare, but still there's a possibility, suggests possible genetic predispositions or shared some common environmental factors, not directly inherited disease. Next is a very interesting case that we recently found, that husband and wife. The husband, he came with back pain, fractures, fatigability, anemia, and with multiple comorbidities including diabetes, hypertension, CVA, and we sent SPEP and multiple comprehensive myeloma, and finally he diagnosed as IgG kappa multiple myeloma in 2023, ISS3. They started on botizomi plus dexa based therapy, and later on we added the triple therapy by adding lenalidomide. Finally, he died due to the poor general conditions, age factor, and recurrent UTI. Finally, he developed pneumonia, and due to the aspiration pneumonia, finally he expired within 6 months of the treatment. Unfortunately, wife also came with his son with the son came to the OPD, and he was expecting that it might be the son and family was expecting that it might be the multiple myeloma, but we as a doctor was not thinking, because we never seen the cases like that husband and wife both present the same, but they were thinking because mother symptoms was similar to the father. She also presented same complaint with back pain, easy fatiguity, anemia. And starting, we just gave some calcium or vitamin D and we sent her. We were not thinking multiple myeloma. Then later again he came and he went some other centers, and then SPEP sent, and it came out to be 2 gram per deciliter, and it diagnosed as what's called sesmolding myeloma. Now she is under follow-up, and they are also found that AG reversal, and then they sent the SPEP, and it came out to be the smoldering myeloma. Now she is on Lendex and follow-up. The key point that this is a very rare and documented phenomenon, but exposed with plasma cell dyscrasia. Possible explanation that either is a chance or shared exposure or genetic predispositions. The key takeaway that couples risk from shared lifestyles or environment, not contagion. Family like genetic or environmental both matters. Multiple myeloma in couples, rare, is very rare, but likely there will be chances that they share common like environmental, or maybe there's a chances. Based on the cancer, CML, CMPN or APML, mainly acquired mutations. Cancer results from the complex interplay of the genetic predisposition, environmental exposure and lifestyle factors. Studying cancer in the families and couples provide valuable insights into risk patterns. Such research can guide better preventions, early detections and personalized care strategy. Thank you so much for listening.
Hello. So, nice presentation of couplets where you demonstrated, various malignancies and all the etiologies are open. So, how will you proceed further? You have so much of, hypothesis. So, any further planning? How will you approach these cases?
Yes, sir. As we are working as a small center where very few cases we generally used to see. So this is like our experience from the Paras hospital. We need the bigger sample, and we need some further research to establish that there's some environmental or like environmental factors, or there's a chance. We need to further research about this.
It's not a small center.
No?
What you have done to establish the familial association? Have you evaluated in terms of any germline mutation or anything?
Sir, not yet, sir. No, sir.
Hello. Can I? Hello.
Yeah, nice content. One question: what message do you want to convey to the community?
Basically, there are some driver mutation which leads to leukemogenesis, or even in multiple myeloma, the disease starts with some driver mutation. There are some genetic association which are well known, and we can evaluate those through the NGS workup you can do, and you can get some either germline mutation in the family or any somatic mutation that has occurred, and due to same environmental condition, probably the last case has developed, husband and wife both have developed myeloma. Yes, sir.
The next resident is Dr. Ritav Rakshit from AIMS Patna. Please join us on the dais.
Good morning to the august gathering over here. Today I'm going to present my paper on this topic of the rising prevalence of variants of hemoglobin E in the HbA2 window. This was done in our center at AIMS Patna. The co-author for my topic is Dr. Surbhi ma'am, who is an additional associate professor. Now, as we know, thalassemia is a monogenic disorder which is characterized by a defective synthesis of the beta globin gene. The global burden of disease analysis tells us that 2,74,000 cases of thalassemia are present in Southeast Asia alone, which account for around 1.5 lakh of dailies across the globe. For detection, we have mostly been using the cation exchange, the HPLC method, which is the commonly used technique. And in India, the most common structural variant which eludes in the HbA2 window is a hemoglobin E variant over here. And in the bubble plot, if we see that Southeast Asia forms a very major and a most important component in the global burden of disease analysis. Now, something about the hemoglobin E disease, that's a beta chain variant which is common in the Southeast Asia. The RAKTAVIGYAN SNT emission project of the ICMR multicentric data set told us that the HbE carrier rate and the beta thalassemia carrier rate prevalence is around 4.4 and 3.9% respectively. And the prevalence of HbE is most often seen in the northeastern region of the country, mostly in 22% in Kolkata, 60% in some parts of regional Bengal, and around 50 to 80% in Assam. But what is most important, whenever we are seeing the HbE mutation, is the phenotypic presentation of hemoglobin E with beta thalassemia, which has a highly variable range from those who never require blood transfusion to those who are dependent on it for survival. From the period of June 2020 to 2025, we have evaluated more than 2,000 HPLC records, and we have identified around 115 patients, out of which there were 55 who were presented with compound heterozygous of HbE with beta thal, and around 60 patients who were HbE trait. This comes us to a prevalence rate of around 2.75% and a 3% respectively, which is very much closer to the data rate to the data set that was done by Mohanty et al. Now, when we have compared these two values, first of all, the hematological analysis. If we see the age of presentation for HbE beta thal is of a younger age, coming out to be a mean of around 12.2 years, but for HbE trait, it came out to be around 25.7. And the other parameters like hemoglobin, RBC count, MCV, MCH, MCHC, all of them were to be lower compared with respect to HbE trait. And next, if we see the red cell distribution width, that was higher, which leads to us a more amount of marked anisopoikilocytosis when we see in the peripheral blood smear for compound heterozygous and HbE trait. In the HPLC, when we see in the HbA0 and the HbA2 values, we see that the HbA2 and the HbF, they are higher with respect to HbE trait, and HbA0 is lower with respect to the HbE trait, and all of the values came out to be significant. Whenever the markers of erythropoiesis is seen in the bone marrow, then we have seen the corrected reticulocyte count and the reticulocyte count, which came out to be more in case of compound heterozygous HbE trait. And the NRBCs on this case in the peripheral smear came out to be more in case of compound heterozygous than HbE trait. Now let's have a discussion about the clinical findings of what did we find. On evaluating the clinical profile, all the HbE traits were mostly asymptomatic except for 3 cases in which we did find that in stress situations, patients were presenting with generalized weakness and abdominal pain. In case of compound heterozygous form, we found that there were recurrent episodes of jaundice and splenomegaly in 16 out of 55 patients, anemia without organomegaly in 10 out of 55 patients, and others were diagnosed during screening. So what is important over here is the transfusion dependency. If I have taken a criteria of around 8 transfusions in a period of 1 year, that I've seen that there are 25 compound heterozygotes which were dependent on transfusion, and the remaining were non-dependent. What characteristic finding we did also find that there were 8 such cases which were previously transfusion dependent, and now they have not requiring a regular transfusion. So the reason behind such a variance of hemoglobin E trait along with beta thalassemia is poorly understood, and there is less literature on it, but some say that there may be some genetic polymorphisms like XMN1 genetic polymorphism, or even some additional alpha gene mutations that can be present, or maybe BCL11A gene can be present. So as I have to say it on a comprehensive basis, we should always, this adds to the data set of in the state of Bihar, what is the importance of this kind of hemoglobin E with respect to the population which is in the northeastern India. The prevalence of the compound heterozygous HBE beta thalassemia is high, which is definitely a cause of concern for public health. The heterozygous HBE, although is asymptomatic, but may pass on this trait to other future generations which can now present with HBE with beta thal, which will be again depending on the rate of transfusion, will first of all be a burden for the society depending upon the economic cost, as well as a burden for the patient who will have to regularly take transfusion in the coming future. Now, effective screening programs, first of all at the ANC clinic and community health centers, depending on the HPLC screening, or maybe on the basis of seeing a blood smear and decoding the values, where we can see microcytosis in both the cases, but we'll have to see the microcytosis will be more predominant, or there'll be marked anisopoikilocytosis in case of a compound heterozygous HBE with beta thal. Also, now in the upcoming future, we should do an advanced molecular testing to identify these genetic polymorphisms so that we can add to the literature, and maybe whenever there's a patient who's presenting with splenomegaly, and if you're doing a splenectomy for those patients, we can add additional treatment of hydroxycarbamide or some other treatment can be given, so in the future that these patients will not be relapsing from the disease, or even in the future if we know the genetic polymorphisms, then we can go for a bone marrow transplant for these patients and completely eradicate the disease from them. These are some of the references I have used, and thank you.
Nice presentation, Dr. Ritav. Is there any role of alpha thalassemia when it is co-occurred with beta thalassemia? Means when the two conditions are co-occurred, then what is the presentation?
Ma'am, in case of an alpha thalassemia will co-occur with, then it can be depending on the transfusion dependency, like in a higher rate of transfusion dependency, or we can get deleterious mutations. Like in case of, in my case, wherever we are considering on HBE with beta thal, there are some silent mutations of alpha thalassemia which can be co-inherited in such patients. If there are around 4 alpha chains, like if it is around 10 to 15% of previous studies says that 10 to 15% of patients have occurred without alpha 4 deletion, and therefore there will be a reduced synthesis of hemoglobin, and therefore transfusion dependency will be required for those patients if alpha thalassemia.
Okay.
Okay, nice presentation. Okay, you found that patient is suffering from either homozygous or heterozygous E disease on HPLC.
Yes, sir.
Does we require further investigation on those patients?
Yes, sir. We need to do genetic advanced molecular testing, or before advanced molecular testing, first of all, we need to do a capillary zone electrophoresis, and then you have to see that if that HBE that is found on an HPLC, because sometimes HPLC will be having a co-elution of HBA2 and HBE together. In that case, you go for a capillary zone electrophoresis. We have to distinguish between the two bands of HBE and HBA2, and then if further, then we can go for advanced molecular testing to look for any other genetic polymorphisms if it is present, to predict transfusion requirement in the future, or if it might be passed on to the future generations to predict in such scenarios.
Thank you, Dr. Ritav. What method you will use if you planning some molecular subtyping of beta gene mutation or for heterogeneity of this population? So what method you will use?
We'll use an ARMS PCR testing mostly.
Okay.
And then first of all, regular RT-PCR can be done, and if forward, we can do an ARMS PCR testing to identify these genetic mutations.
So can you tell which mutation you are expecting to get in the beta thalassemia heterozygous? Which mutation you are expected in your population having E beta?
We can get
What is the
XMN
common?
Most common in case of Indian scenario is intervening sequence 1, G2C, in case of beta thalassemia.
But that is in North Indian population, not in Northeast population. Northeast E beta, what is the common beta gene mutation that is in their beta heterozygous part?
Also, we can get XMN1 polymorphisms and sometimes also 619 base pair deletion.
Okay.
Just one comment. If you have beta thalassemia already,
Yes,
and
sir.
you also have co-occurrence of alpha, so the severity will be coming down. It will not increase because the disbalance of the chains is balanced. Okay. Thank you.
Thanks.
The next presenter is Dr. Sarita Kumari, scientist at Mahavir Cancer Sansthan, Patna. Please join us on the dais.
Good morning, all of you present over here. My topic is actually, this is the total work done which I am doing in Mahavir Cancer Sansthan. So from this topic I have chosen. My topic is getting ready for flow cytometry approach in stem cell enumeration in the era of bone marrow transplant, co-experience of a tertiary care center. So first of all, this is the question why and how CD34 a positive stem cell, because it should provide a rapid, reliable and reproducible assay. And as we know that we all follow the ISAG protocol, International Society of Hematotherapy and Graft Engineering. This ISAG protocol is based on 1996 ISAG guidelines and modified in 1998 as a single platform ISAG protocol and a guidance document published in 2012 on behalf of UK and US. This protocol says that safety, first safety, specimen collection, specimen labeling, quality control, antibodies and reagents, cell viability, performing tests in duplicate, negative control, CD34 positive, CD45 positive, cell enumeration and international guideline standards for CD34 stem cell, hematopoietic stem cell and progenitor cell analysis. So origin of stem cell, as we all know that bone marrow, cord blood and peripheral blood. First of all, for the transplant sample, first we check the pre-harvest value, and it should be greater than or equal to 20 cells per microliter. And for post-harvest value for the peripheral blood, aim to achieve depends upon the recipient's weight, but our aim is to achieve was 2.5 to 5 million CD34 positive cells per kilogram body weight, and those can be calculated by total number of stem cells that can be counted on flow cytometry into product volume divided by weight of patient. So why flow cytometry? Because it's a very simple, high sensitivity, accuracy, reproducibility, speed. And ISAG protocol says that, as you all know, the protocol in written, it's a single written, single platform, stain, lyse and no wash method we are using. Incorporated viability dye, 7AD dye we are using. And in our center, we use stem cell kit and IM count, and always run stem cell control troll we are using. Sequential gating strategy used for the stem cell counting. This is the ISAG protocol. By this protocol, we follow our data analysis by site expert software. First of all, we choose the viability and non-viable cells in the first plot by using 7AD dye, and after that by using CD45 gating, we select all the viable cells, and after that sequential gating used, and CD34 positive cells were chosen. After that, by the sequential gating of total CD34 positive in the third plot, we use the CD45 dim positive cells, and after that we choose in the sixth plot, we choose the CD45 positive and CD34 positive cells, and the cells can be counted by what number of bead can be acquired. This table showing how much data we have taken till date. From 2023 February, we started stem cell harvesting sample by flow cytometry. Till date, we have done sample 60 cases we have done, 20 from our center and 20 outside from our center. And we also enroll in EQUAS program for ILC inter-laboratory comparison program in 2024 to 25 from Tata Memorial Center, Mumbai, and all our results are satisfactory. In this ILCP program, Tata Memorial Center sent us their sample, and we acquire and analyze data and send it to the TMH, and after that they given our result. So all the results are satisfactory. We have this year we also enroll for ILCP program in 2025-26, and this is the reference SAGE guidelines. Thank you.
Thank you, Dr. Sarita. It was a good presentation. Suppose SEPEN ADD is in shortage, it's not available. What alternative method you will use to do the stem cell viability testing?
For the cell viability, we can do alternative method, but instantly we can't do, because all the setup we already standardized. So we can't change. So first we plan what I have to do. So because in the flow cytometry, when we standardize all the things, then we can't change in a one day. We can change after 6 months or that can be planned.
Any other stem cell enumeration protocol you know other than ESAGE protocol?
Yeah, I know, but this time I'm not remembering actually.
Okay.
Yeah, nice work in this part of the area in Bihar. You are doing a stem cell enumeration. It's a very good approach in the this part of the country. Thank you very much.
Thank you, sir.
Our next presenter is Dr. Sandhya S. from AIIMS Patna. Please join us on the dais.
Yes. A very good morning to one and all present here. I am Dr. Sandhya, junior resident from Department of Pathology, AIIMS Patna. I've come to present our original study titled as Clinico-Pathological Profile of Multiple Myeloma in Younger Patients, a Retrospective Analysis. As we all know, plasma cell neoplasm encompasses a group of disorders characterized by monoclonal expansion of plasma cells. And one such entity is multiple myeloma, which is the disease considered to be the disease of the old because of its average age of incidence between the range of age 60 to 70 years. And according to Globocon 2025, multiple myeloma has around 1.35% incidence amongst the other diseases, putting it into the list of one of the rare diseases. But what is more rarer is the incidence of this multiple myeloma in younger population, that is less than 45 years, around only 2% of the entire multiple myeloma incidence. So this fascinating fact had led us to perform this study, which helped in formulating the aim of the study to determine the clinical features and hematological profile of multiple myeloma in young adults. So it is a retrospective single center study which was conducted in a tertiary care hospital in northeastern India. And for this study, we had selected all the patients who were diagnosed to have plasma cell dyscrasia on bone marrow examination. We had collected the cases for a study duration of 8 years from 2018 to 2025. And to our shocking surprise, we were able to skim out a whooping 35 people who were diagnosed to have multiple myeloma in less than 45 years. and relevant serological and the radiological data of these patients were then respectively collected from their medical records. So the results of the study are as follows. Over the past 8 years, around 200 patients were diagnosed with multiple myeloma, out of which 18% was less than 45 years, and predominantly they belong to the male gender. So when we looked into the clinical presentation of these patients from the pie chart, I think it's very evident that around 80% of the patients presented with renal dysfunction and anemia, of which even 18% of these anemic patients presented with severe anemia with HB less than 8, followed by multiple bony lytic lesions or compression fractures on radiological evaluation, and around 30% presented with hypercalcemia. So younger age group presenting with these, one of the myeloma defining events, we wanted to rule out multiple myeloma or at least rule out plasmablastic or plasmacytic lymphoma types. So we performed the screening test in which Bence-Jones proteinuria was detected in around 60% of the patients only, and serum protein electrophoresis was done in all the 35 cases, which showed M band in the gamma region. And this is the consolidated table showing us the results of this study, that is the hematological profile, wherein we are able to see the mean hemoglobin range was less, that is around 8 gram per deciliter. And myeloma second to tuberculosis is one of those diseases which has a very high ESR level. So similarly in our study as well, we got an average range of 63.5 mm, and on average bone marrow aspiration evaluation, 38% plasma cells were obtained on average, and on serological profiling, serum creatinine was increased with an average of 2.28 milligram per deciliter. But however, serum calcium and serum LDH, which acts as one of the prognostic indicator, was quite normal amongst all the age group. Then beta-2 microglobulin, again a prognostic indicator, was seen with increase with an average of 3.8 milligram per liter. So to determine the clonality of these patients, we were fortunate enough to perform serum immunofixation assay in our institute, and from the bar chart, it is again evident that predominant population presented with IgG lambda light chain restriction, followed by IgA lambda light chain restriction. And on bone marrow aspiration evaluation, almost 30% of them had presented with plasmablastic morphology, yet again another poor prognostic factor. Followed by which we also evaluated the bone marrow biopsies, which showed a diffuse pattern of involvement like any other myeloma in old patients. So we also tried to risk stratify the patients based on the international staging system. And again, to our surprise, we were able to see that the predominant population of young adults fell directly into ISS stage 3. So we didn't want to end our study here seeing the results, so we ended up following up these 35 patients as well, in which we were able to find that 19 out of 35 patients were directly started on standard VDT regimen, which included tablet bortezomib, dexamethasone, and thalidomide. But however, of these 19 patients, 3 of them developed refractory myeloma. So their dose was were increased, leveled up to a higher end with KPD regimen. And remaining 17 patients, of which 3 patients died and 13 were lost to follow-up, and only 1 patient showed only very good partial response. So we can also see the Kaplan-Meier survival curve of this data with 95% confidence interval, where at the timeline of 0 we can see event 1, which indicates 100% survival, which has a static phase till 2021, where we had our first event, that is a death at the age of 34 years, and following which and yet another static phase till 2024, where we had our next couple of events. And it ended up at 0.85%, indicating that the average prognosis to be 85%. So as we all know, India being the most populous country, and this population is summed up by maximum of younger generation, that is less than 45 years young adult. So from the bar chart that I would like to quote again, we are able to see that with a cutoff of 45 years, there are 35 patients. But what if we increase the cutoff little to 55 years as recommended by International Myeloma Working Group, where they say age less than 55 years along with the ISS staging and cytogenetic mutation, that it comes under low risk. But if we take the cutoff of 55 years, it is summing up to around 100 patients of the 200 patients that we received in a tertiary care center. So do we still call myeloma to be a disease of the old? I think it's a topic for discussion. And according to Tangwe et al., who had done a study on a mass population for a longer duration, say around 25 years they have performed, in which they were able to see that predominant young adult had a low risk, that is ISS staging 1. But we in contradictory got ISS stage 3. So this discrepancy can be explained by regional variation, which again puts this topic on spotlight to conduct more such clinical trials and follow-up studies to determine the multiple myeloma and their clinical presentation and follow-up on younger adults, or should we consider this as a separate entity like we are considering other neoplasm like pediatric CML? And the most important limitation of our study was that there is a revised international staging system which mainly includes the cytogenetics study, but however due to financial constraints we could not perform cytogenetics for these patients. So to conclude that this amount of material or the resource that is available to determine the multiple myeloma in younger patients is quite rare. To be more honest enough, there's only a single large study that has been performed in the western part of India in the past 3 years. And the following management of this population is yet again even more rare. So with the limited studies and reviewing of literature, we were able to identify that the most preferred option of treatment for young adults is autologous stem cell transplant. Yet again, the prognosis and the response to therapy is still on process. Though we say young people, better immunity, better prognosis and response to therapy, but there's always a fear of secondary malignancy, and the patient will have to survive with the drug-induced organ-related side effects forever. These are the references for our study. I would extend my thanks and gratitude to the Department of Pathology, AIIMS Patna, for providing me with this opportunity, and also a great thank you to all of you for your patient listening. Thank you.
Thank you, Dr. Sandhya. You have mentioned one patient with IgM lambda. Are you sure it's a multiple myeloma, not a Waldenstrom? You mean to say IgM myeloma?
Yes, sir.
It's a very rare entity.
Yes, 90% of Waldenstrom present with IgM, but however 10% can also be IgG. So IgM...
No. My question is, you have mentioned one patient with IgM lambda as a multiple myeloma, means IgM myeloma,
yes,
which is a very rare entity.
Yes.
So usually IgM positive patients are Waldenstrom rather than myeloma. And another question is, if N is total number of patients is 19 and 13 are lost to follow-up, can you make Kaplan-Meier?
No, sir. That is yet again a limitation. Because also the beta-2 microglobulin study that, because like any other retrospective analysis, our study also was lacking in the entire clinicopathological data. So this beta-2 microglobulin, which we had taken as staging, was done only in 18 out of 35 patients. So that we definitely confront as an limitation of our study, sir.
Just one point, like in results, you just mentioned one pie chart where you have mentioned anemia, bone pain and all that. So that is not the right way to mention all this, because you are mentioning 70%, 75%, 30%, and still you are making a pie chart, which should be all 100%. So you can make bar chart better than a pie chart for that.
Sure, sir. Thank you, sir.
As you are a junior resident in pathology, my question is, what are the recent WHO update in plasma cell neoplasm?
So recent WHO updates, they have added newer entities. Like they have clinically, like they've signified on the entity MGRS, which is monoclonal gammopathy of renal significance, considering not just based on the morphology but also on the serological data of the patient. Then apart from that, the staging of multiple myeloma, sir, they have added from not just to the serum levels, that is albumin and beta-2 microglobulin, they have added the cytogenetics, which are the driver mutations, that is the high risk mutations, into ISS stage 1, 2, 3. And
as you have said MGRS, what entity it is?
So monoclonal gammopathy of renal significance is still a considered as pre-malignant lesion, but a different entity from that of MGUS, wherein MGRS will determine the serum proteinuria for more than 3.5 gram per 24 hours urine, and a patient who's not responding to therapy, and I think this much, sir. Also another update with plasma cell leukemia, sir, they have reduced the cutoff from 10% to 5%.
Is there any in-organ damage in MGRS?
So there is renal involvement, yes, sir.
Anything else?
Kidney damage. Not that I could recollect right now, sir.
Nice presentation, Dr. Sandhya. What are the poor cytogenetic risk factors in multiple myeloma?
Include translocation 414, 1416, deletion of 17p, and a gain of function of 1q, ma'am.
Okay, thank you.
Thank you.
Our next presenter is Dr. Mukesh Kumar Singh from Paras, Patna. Please welcome him on the dais.
Good morning, everyone. Myself, Dr. Mukesh Kumar Singh. Thank you so much to Dr. Avinash sir for giving me this opportunity to share my experience about ATG and BMT. And also thank you so much to Dr. Ketan Nathani sir and Dr. Mofizur Rahman sir for guiding me to present this case. Today I'm gonna present the case about aplastic anemia. I think yesterday we had discussion about aplastic anemia. So today I'm just going to share experience that which one is best, whether ATG or BMT. This is my experience from the Paras Hospital HMRI Patna. So directly coming to the point that if the age of the patient is less than 40, then directly go to the HSCT, directly go to the transplant. Okay, if we have the HLA identical sibling donor, then we should go to the transplant directly. If suppose that age is more than 40 years, so best is ATG plus cyclosporine, best therapy plus minus eltombopac we can give. If suppose that there is no response, or if suppose that there is no matched sibling donor, so you can go to the ATG plus CSA best therapy. The material which we took from the Paras Hospital, this is actually the retrospective studies. We took the sample from the 2017 till 2025. Patient less than 40 years with full matched sibling donor underwent BMT. Those who are less than 40, so we directly went to the transplant, and more than 40 years, no matched donor available, and then the ATG was given. This is our data. We took 18 patients. We did 18 patients who went to the transplant. The age is given there. The total patient 18, and the age we took from the 5 years to 50 years, and the very severe to severe ratio, the severe to very severe ratio is 11:7. The time between diagnosis to BMT, those generally 1 month to 5 years, but mostly we did BMT within 1 year of the diagnosis. Sorry. Yes. The time between BMT and the range is 1 to 5 years. The conditioning regimen is flu-swi ATG. The median CD34 cell dose is 6 into 10 to the power 6 per kg, and GBD prophylaxis CSA plus MTX. The ATG, for ATG we gave total 25 patients. The median age was 40 years old. Majority of the patient had the severe disease. We gave the age therapy. We prefer the ATG 40 mg per kg per day for 4 days, plus capsule cyclosporin 5 mg per kg per day, plus and tablet eltombopac 150 mg per day. But some studies say that also have tried some lower dose, but we have given only 40 mg per kg. And injection methylprednisolone steroid was given for the serum sickness. Comparing the both ATG, for we gave 25 patient to ATG and 18 patient for BMT. The median age range was 12 to 72 years and median is 50 years for the ATG, and for BMT 7 to 50 years and median age was 25 years. The male to female ratio for the ATG 22:5 and for BMT 12:6 over. Very severe to severe 11:14 for the ATG and BMT 11:7. The approx cost treatment for 3 months for the ATG around 5 lakhs and for BMT it cost around 15 lakhs. You can see the outcome here. So for after the BMT around 55% patient went to the CR and around 40% for the ATG went to the CR, and for BMT around 18% patients they are still alive with the GBAT and some medications, and after giving ATG around 12% they are in the partial response PR, and for you can see the graph there that around more than 50% patient with the ATG they relapsed, and only around 8 to 9% patient with the BMT they relapsed after the BMT, and around 30% after giving the ATG they expired, and around 18% patient after receiving the BMT they are expired. So this is the data till now, the last follow up till now 2072 till now. The conclusion: if matched sibling donor is available, then directly we should go for the BMT. That should be the our treatment of choice. If suppose that matched sibling donor is not available, we can give S therapy should be given. This is our limitation. Actually, this is our retrospective studies, and it was conducted at Paras Hospital, Patna. So it's like a small sample size and the single center studies. So solution is that we need to do more prospective studies, and we need to conduct this data on the bigger sample size so we can further correlate. Thank you so much. This is our BMT team at Paras HMRI Patna.
Thank you, Dr. Mukesh. Suppose a patient, like in your series also, there is a patient of 10 years with IBMFS panel positive. He has no matched sibling donor. Will you go for ASH or you will plan something else?
Come again, sir.
10-year patients with IBMS panel positive for some mutation, and will you go for ASH or you will plan something else?
If suppose that we don't have a matched sibling donor, we should go to the ASH-based therapy.
So will ASH will response in patient having IBMS panel positive with ASH? I don't think so. You have to go for alternative donor transplant.
In results, you just showed that the CR rates with transplant is around 50%, and CR rates of ACE treatment, that is ATG, cyclosporin and L-trombopag, is around 40%, and PR rates were around 20%. While what we see in our clinical practice is that it is just a reverse. So with ATG cyclosporin, most of the responses are partial, and few responses, maybe up to 20% to the max at 6 months or 1 year, is CR. So how will you explain this finding in your study? What were the cutoffs to define CR while analyzing the data?
Right now, actually, I cannot recollect the data.
So the current data in the era of ACE treatment, we take CR as hemoglobin of 10,
yes, sir.
ANC more than 1000, and platelet count more than 1 lakh. So if you get this with the response with the treatment, you call it CR. Earlier it was very stringent, no? Hemoglobin more than 13 for male, ANC more than 1500, platelet more than 1.5 lakh. So now the CR rates comparison to the previous criteria, now the CR rates are better, but it's not still not that better that it is 40% with whatever treatment we are giving, especially the ATG cyclosporine.
Sir, sir, with the
Yeah.
during the ATG therapy, so most of the patients, sir, we have given ACE. Only four patients that received ATG and cyclo, whereas 21 patients have received ACE therapy. So our CR rate is good because of the ACE therapy, sir.
No, we also give ACE only, but this is too much. I think maybe for your patient profile it is there, but I think you have to look it back again, because you are saying partial response is only 20%. Overall response is still 60%. It's not going to 70-80%. So overall 60% response rate we see with ATG cyclosporine also.
Yes, sir.
Okay, so that we have to just revisit maybe.
Okay, sir.
Okay, thank you.
Thank you, sir.
Thank you, respected chairpersons, for your valuable time and effort. For the next session, I would like to invite Dr. Avinash Kumar sir to introduce the chairpersons.
So good morning everyone, and thank you all residents for presenting their papers. Next is awaited presentation on multiple myeloma by our teacher, our inspiration, Dr. M.B. Agarwal sir. And to chair this session, I would like to invite our teacher, Professor Padma Shri Dr. J.K. Singh sir. Sir is Director, SS Hospital and Research Center, Patna. Next is Dr. Ajay Sinha sir. Sir is Professor and Head Department of Medicine at Nalanda Medical College Hospital, Patna. Then Dr. Rajiv Ranjan sir. Sir is Senior Consultant, Department of Medicine at Patna. And Dr. S.P. Verma, he is HOD, Department of Hematology. Oh, you are going? Okay, okay. So I would like to invite Dr. Sanjeev, who is Additional Professor, Department of Hematology at SCPJ Lucknow. Thank you.
Good morning to all of you. This topic is very, very important topic, and the deliberation will done by not other than Dr. M.B. Agarwal himself. He's a great teacher of hematology, having more than 3 decades of teaching experience in Mumbai University and other institutions. He's a great orator, author, editor, and founder of different society and department of hematology at various institutions. He has written several books and more than 150 articles in different journals. Now he'll be talking on multiple myeloma, and he's a towering personality, I must say, and he doesn't need any more introduction, because not only in India, he's a globally renowned person. So with this introduction, I will request Dr. Agarwal to start his presentation, please.
Thank you for that kind introduction. It was wonderful spending some time with you yesterday. My first visit to Patna was courtesy you 20 years ago, and on the same subject, multiple myeloma. That time I spoke on myeloma kidney, and thanks for that invitation. And these recurrent visits to Patna have been possible because of this gentleman who just began the show today. Avinash Kumar Singh has been instrumental in organizing these annual events which we have been witnessing and enjoying participating in these. As a student, we read the books, and the opening statement of myeloma was that myeloma is an incurable blood cancer. I would like to change that statement, that myeloma can be cured even in ancient days in about 2% of patients, and in 2025 in about 20% of patients. And if you invite me in 2047, I will say maybe 50% of patients. And if you invite me in 3000, I may say it is 100% of patients. So who is the enemy? Enemy is this cell, the plasma cell. What happens in myeloma? You have asymptomatic phase of MGUS and smoldering, and finally you will end up with a relapsed refractory disease for which you don't have an answer in 80% of patients. Let me present my first cured patient to you. 2009, Lisa Ray got multiple myeloma. 2012, she declared herself as cured and married Jason Daly. Unfortunately, she relapsed the same year. However, she fought like a wounded tigress, went on to deliver twin daughters in 2018. These twin daughters, Sufi and Solel, are now 7 years old. Lisa Ray now has migrated. She's an NRI in London. She remains in remission of maintenance for last 3 years. She was invited as a guest to the Pravasi Bharatiya Divas this year, 2025, to Odisha. 16 years, old story, 3 years of all the treatment, no relapse. May I use the word cure? Good news, yes, probably the world will accept that she has biological or functional or some kind of cure. This cure was not possible for many stalwarts, some prime ministers and some chief ministers of this country. Unfortunate, maybe the biology of the disease, maybe they didn't get the best of the treatment, whatever the reason may be. And of course, when the age is against you and you get a myeloma at the age of 99, it's difficult to cure. We have people who are struggling and trying their best to get cured, and one person over here is Mrs. Care. Cure, cure, and cure, and we're waiting for this cure. And these are the stalwarts who probably are showing us the way by which this disease can be cured. The father of myeloma on the left upper corner, Dr. Kyle, from a most important center in the world for all the research in myeloma, the Mayo Clinic, Rochester, Minnesota, who gave you the term MGUS, who gave you the term smoldering myeloma, he gave you the term the symptomatic myeloma, and even today he spends 2 hours on every Saturday in that institute. And then you got these 7 marathon from India who have been shining the torch in the field of myeloma in the world. So we aspire that this cancer should get cured, and we won't stop till it really gets cured. From a fatal disease one day, it became a chronic disease and now potentially curable. The road to the cure is quite twisted and it is multifold, but probably you have to follow one path at a time. Now let me tell you 4 aspects of myeloma treatment and prevention and cure. 1, the treatment has to be risk adapted. It cannot be a homogeneous treatment, a student-like statement for every patient. 2, the treatment for the relapsed myeloma exists and is effective, and we have to learn this. 3, MRD assessment in the field of myeloma is a real success story, and every patient, it's our duty to assess the MRD and modify our treatment and probably terminate our treatment based on MRD. And lastly, in cancer, you nip in the bud. Here is a disease where we were taught that if you have got a MGUS or smoldering myeloma, keep away, don't treat. Wrong medicine, wrong teaching. You need to nip in the bud. So risk-adapted therapy. Risk-adapted therapy moves around quadruplet induction and nothing less than that. Early transplant, which is now questioned. Consolidation needed for some patients, and maintenance, which may also be questioned. How do you do the risk assessment? There are patient-related factors on the left top, there are disease-related factors on the right top, and there are treatment-related factors at the bottom. Let's go over the disease-related factors. The clinical features, albumin beta-2 microglobulin, LDH, extramedullary disease, plasma cell leukemia, all well known. Genomics, very well known. Cytogenetics, FISH. Then the clinical course, the response to the treatment, MRD assessment, and patients relapsing early. All put together tell you that the risk of the patient is low, average, or high. There are newer methods to assess the risk, which includes NGS, whole genomic sequencing, gene expression profiling, immunophenotyping from the peripheral blood, from the circulating plasma cells, site of circulating DNA, and mass spectrometry. We know that the myeloma can be standard risk, it can be high risk, and it can be ultra high risk, what is called double risk. We'll not go into the details, but all that is shown here, which is now an undergraduate or a postgraduate chapter. We move on to the patient-related factors. Myeloma is a disease of elderly. Many patients are unfit and frail. Some patient is fit, you give the treatment, he becomes vulnerable, and you give him more treatment, he becomes frail. On the other side, the patient is frail to begin with, and you give him treatment, he becomes vulnerable and can become even fit. Whom you thought cannot be transplanted on day 1 becomes fit to get the transplant after 6 months. Age of the patient cannot be changed, and with age come many, many factors which modify your outcome and the treatment. Aged people are at higher risk of infection, VTE, neuropathy, treatment failure. Elderly patients have increased comorbidities. There are challenges of diagnosis, there is tolerability problem with various therapeutics, and there is a poor or brittle performance status. Let's come to the third part, the treatment-related factor, which is something in your and my hand, and why not to do that? So our armamentarium has improved. Gone are the days that you trusted the alkylating agents and the prednisolone as the treatment, which we did in our residency with an average survival of just about 3 years. We moved from there to autologous transplant, we moved to proteasome inhibitors, we moved to IMIDs, and today it's a story of immunotherapy, immunotherapy, immunotherapy. We've got monoclonals, we've got bispecifics, we've got CAR-T, we're moving to trispecifics, we're moving to double CAR-Ts, and so on. So we have moved a long way in last 25 years, which is shown over here. In each category, you've got no more than one drug as put up on the right side. This drug list is unending. There's no disease on the earth which has been treated with more than 25 US FDA approved agents in less than 25 years than this cancer. So you can imagine what has happened to this cancer, which is supposed to be just 1% of all the cancer and 10% of the blood cancers. We have learned a long way how to use the drugs judiciously. For example, bortezomib to be given once a week and only subcutaneously. Carfilzomib to be given once a week and not on 2 consecutive days. Thalidomide not to exceed more than 100 mg. Lenalidomide reduced dose for a patient who's got renal failure. Pomalidomide 2 mg. Daratumumab not to use any pre-medication from cycle 2 and to give only subcutaneously, and so on. The treatment varies. You need to follow one patient, one treatment. In Africa, they use the word the 5 big, and the 5 big are shown at the right bottom. Our 5 big are Borte, Carfil, Len, Pom, and Dara. Each patient must receive these drugs, and if he has not received and dies earlier than this, it's unfortunate. There is no place for singlet in the treatment of myeloma. Your minimum doublet, preferably triplet, and as I mentioned today, the quad for everybody. Triplets, 3 times the giggle, 3 times the chaos, 0 time to sit down. What was used in past was VRD, VTD, CyberD, KRD. What is done today is DARA added to all of them. And there should be a reason why you cannot use DARA for every patient in a practice, finance apart. So quadruplet is the treatment of the day. Who needs DARA? All patients who relapse. All newly diagnosed patients with poor performance status, comorbidities, or age because they cannot be transplanted. All newly diagnosed patients who are high risk. All standard risk newly diagnosed patients who are transplant eligible because that will make them achieve an MRD in the highest number of patients. High risk smoldering myeloma patients. High risk MGUS also, which may be a controversial, and all other plasma dyscrasia like AL amyloidosis, light chain deposition disease, POEMS, etc. So the question should be who does not need DARA rather than who needs DARA. Look at these bars, and I want to show you the orange bar, the MRD negativity. Your goal has to be a sustained MRD negativity in 100% of your patients. And that is your goal. How do you avoid or give less than quadruple treatment to your patients? DARA-based treatment gives you MRD negativity in 3 out of 4 patients, where the standard of care gives you less than 1 out of 2 patients. High-risk myeloma is a tragic disease. Quadruplet is the minimum treatment, and the drug to be used there is DARA with KPD and not VRD. And with this, you can achieve 100% overall response and 71% MRD negativity in high-risk myeloma. So this treatment should not be deprived. Not only that, the UK has shown us the MUK9 study where 5 drugs are used in induction, 2 drugs are used for transplant, consolidation is done with 4 drugs, second consolidation is done with 3 drugs, and maintenance is done with 2 drugs. This was before the immunotherapy came. Here walks in the bispecifics in the CAR-T, and probably all these double hit, triple hit myeloma should be treated with bispecific CAR-T upfront. As I said, age is a non-modifiable factor, and myeloma patients with age are going to come to you. These aged people, you get scared of treating them, and you give a very kind of humble treatment or 2 steps back, 1 step forward, that kind of approach. Single drug, double drug, by the time you write 3 drugs, your hand is shaking. Here are the results, the triplet is better than doublet, and here are the results, the DARA-based protocol is better than non-DARA-based. So elderly people, less than 3 drugs, non-DARA is an inferior treatment which you are offering to them, and that's the conclusion drawn in Blood Advances published this year. From the risk-adapted treatment to early transplant. Though I have written here early transplant, and that is the standard of care worldwide, that is the standard of care in India. It's one-time treatment, although expensive, but saves you from a lot of cost in future. But in second part of this early transplant discussion, I'm going to ask question to myself. Do we need transplant for patients of autologous, do we need autologous transplant for patients of myeloma in 2025? My objection to this is alkylating drugs are oncogenic. And when you're doing a autologous transplant, you are using an alkylating agent in the highest tolerable dose. So inviting a second cancer. It was fine when you didn't have an alternative. That was 40 years ago. Is it fine today when you've got types and types and types of immunotherapy at your disposal? So okay, come back to the standard. Quadruplet therapy followed by autologous transplant gives you outstanding results in newly diagnosed multiple myeloma, gives you MRD in the maximum extent possible, so why not? Upfront or deferred autologous transplant for newly diagnosed myeloma patient in the era of triplet and quadruplet increases the minimal residual disease percentage. The role of high-dose myeloma with autologous, is it a time for a paradigm shift? And that shift is no autologous transplants. Are autologous transplants still required? Is the question raised by Garnett et al. Autologous transplant lead to second cancer in myeloma is Blood Advances. Impact of second primary malignancy for autologous transplant analysis presented here. So friends, high-dose melphalan, important for people who can't afford or have an access to immunotherapy, but in the era of immunotherapy is questioned because of this occurrence of MDS, AML, and other second cancer. Move to the third part of it, the consolidation. Consolidation should be probably nothing to discuss. If your patient has not achieved MRD at the end of autologous transplant, he should be consolidated till you get into the MRD. Then comes the maintenance. Are there advantages of maintenance therapy? Yes. It reduces the risk of relapse. It probably improves the survival. It increases, but the risk of second cancer is small and only in patients who have undergone autologous transplant. Len is to be blamed or the autologous transplant melphalan is to be blamed is anybody's question. And lastly, it's an approved treatment for patients who have received autologous transplant. Should it be done with one drug like Len, which we do, or should it be with bortezomib added, or should it be with a monoclonal added, or should it be based on monoclonal? We don't have an answer to this. So what we know, that yes, it gives progression-free survival advantage. There's a question whether it gives you overall survival. Side effects are 3. Maintenance therapy is myelosuppressive. Maintenance therapy causes second cancer. Maintenance therapy decreases the quality of life. And of course, it adds to the cost. So if you don't want to give maintenance therapy, this is the way to go and explain to your patient and the other doctors. What we don't know about maintenance therapy is still bigger. Do all the patients need maintenance therapy? I don't have an answer. Which is the best drug? I don't know. Single or double agent? No data. What is the ideal dose if the patient relapses and you're giving maintenance? No information. How to prevent development of resistant clone? No idea. What should be the duration of therapy? Indefinite, 3 years, 2 years, we do not know. Can maintenance be stopped for patients who are persistently sustained MRD negative? We don't have an answer. So many gray areas for all the young researchers to work on. And we'll have an answer when we come to Patna next year. This is an important, very, very important article. Sustained bone marrow and imaging, that is PET scan, negativity for 3 years, probably stop your treatment. What does that mean? That maybe this is equal to cure. We began our talk, can myeloma be cured? Here we are talking about that, yes, some stage you can stop the treatment for many patients because many of them you are giving unnecessarily long treatment. Treatment of relapsed myeloma is the second part of this. Treatment of relapsed myeloma is based on, one, the drugs which we have never used upfront. If you are left with those 5 giants or some other drugs. Otherwise, most of the time it will revolve around the bispecifics, the CAR-T, and maybe an allotransplant. So if you have not used a drug on the right side, then probably they should be used. Look at the drugs you have used in the middle, and then probably select the drugs over there. Again, a triplet is superior to doublet. There are hundreds of studies showing you that, running into 2 slides. So never use a doublet even for the relapsed patients. And at this stage, you have to have this chart on your table. Look at the drugs that have been used and to which the patient is resistant. Look at the status of the patient. How is the kidney? What is the age? What are the cytopenia? What are the nerves like? And whether the cardiovascular status. And then don't have to memorize. Just look at it and pick up your drugs. These are days of AI, machine learning. Don't struggle with your brain. Let all this be in front of you. There's one drug that we didn't talk about, venetoclax. Venetoclax is wonderful for acute myeloblastic leukemia and chronic lymphocytic leukemia. Good number of patients of myeloma have 11-14 translocation, especially if there's a plasma cell leukemia or amyloidosis. But this drug is useless as far as myeloma is concerned. Don't waste your money and time on this. Selinexor, another useless drug for multiple myeloma. All these came out of frustration when we didn't have immunotherapy. Stem cell transplantation for a relapsed patient. Well, we questioned whether it should be done for the upfront patients. So the question will remain for the relapsed patient as well. But if you're not doing upfront transplant, please collect the stem cell and keep it, because this may be the treatment for a relapsed patient who may not be able to afford the immunotherapy of modern time. Allogenic transplant is the best way to kill the person. Non-relapse mortality is 40%. Now, you don't want to offer 40% death rate for a patient of myeloma for whom you have various things coming up, and these are those things which are coming up. The cell mode agents, the bispecifics, the CAR-T, and the ADC. Cell mode, yes, probably a story for tomorrow, but let's talk about immunotherapy. Plasma cell has multiple antigens on its surface, and each one of them is being researched, and 5 of them have entered the clinics. So you've got either an antibody or a CAR-T against one of these. And this immunotherapy is the talk of the town all over the world. The bispecifics, a number of them available in the world. And the one we have in this country itself is teclistamab, which is now being used left and right by you and me. To use teclistamab, you need another important drug in your disposal, and that is tocilizumab. The moment you give teclistamab or a bispecific, you create an inflammatory storm. And this is an anti-leukin antibody which prevents this CRS-like reaction. Another important thing that happens with bispecifics is BCMA is the target, and BCMA is present on normal plasma cell. So knock down the production of globulin, knock down the production of IgG, and you're prone to infections. Your patient will die of infection, so you need IV gamma globulin replacement therapy. So when you are considering teclistamab or a bispecific, hand in hand goes tocilizumab, hand in hand goes IV gamma globulin, which must be done. Well, when you've got too many drugs to play with, there is a problem. And here is an embarrassment of multiple myeloma bispecifics. 3 of them were approved already till yesterday, and 1 got approved just in this July. So 4 bispecifics. Now a student of myeloma has to understand which is good, which is bad, what is the side effect profile, what is the cost profile, how to sequence them, how to use them. That's a job. And another immunotherapy, the CAR-T knocking your door. CAR-T, how it is done is shown over here, not the subject of the day. This is what a CAR-T looks like. And during CAR-T, you have various phases of chemotherapy as well, etc., etc. CAR-T has its own problem. And therefore, there is a challenge. Dr. Avinash Singh has to do CAR-T in AIMS and Paras, etc., and he has to take it to the community. He has to see that all small hospitals in Bihar can do CAR-T. So taking the academics to the community with bispecifics and CAR-T is another huge job. Dr. Sanyal is listening very carefully. You have to do the same job in Mumbai as well, so that everybody can do CAR-T in Mumbai. Data from indigenous CAR-T, and we are proud of it, that a company has done the work and produced our own CAR-T. These are days of the big man, Narendra ji, the Modi jis. So everything has to be made in India. So this is made in India CAR-T, data manufactured in Bangalore, presented, FDA getting approved. December you will have your own CAR-T at the cheapest possible rate, and that's the data. Remember, MRD negativity in 75%, complete response in 87.5%, cytokine release neurotoxicity 0%. You can't have a better CAR-T than this. So we'll be exporting our CAR-T to US. Indigenous anti-BSMA CAR-T from India, that's the name, that's the percentage of response, and that's the success rate. So CAR-T versus bispecifics, which one to do first, which one to do next? You're in the community, use bispecific on the shelf, available. You can do it in the smallest of the places. You want to do CAR-T in the community? Yes. The Pandits will teach you on how to do this. So sequencing the immunotherapy is an important thing. So road to cure is CAR-T, bispecifics, allotransplant, a bad name. I come to very important aspect which the whole world is looking at. Myeloma and MRD. You can't get away, you can't take a step backwards. So MRD is there to stay. Each cancer you have to assess the MRD because that's the first step towards the cure. And in myeloma, sustained MRD is the way to go. And how do you assess that? Next generation flow or next generation sequencing. Spectrometry. It's unfortunate that in India, there's not a single center. There's not a single center doing spectrometry for myeloma patients. It's there in the microbiology departments, but there's no software to do it for the myeloma. So all those who are doing research in myeloma, stimulate your hospitals to invest into spectrometry, because that is the way to follow the MRD. And then the PET scan, which are there in hundreds. That's the kind of thing that you ultimately want to achieve, the MRD negativity, which is the passage to cure. Next generation flow, next generation sequencing, next generation flow is already available. It does not require baseline flow data. Next generation sequencing requires baseline data. You may not be able to do it. And then the PET scan versus MRI, and this is mass spectrometry, the way to pick up the lowest amount of monoclonal protein in the circulation. Mass spectrometry is the way to go to monitor the myeloma success, and that is the way to know the success of maintenance therapy and stoppage of maintenance therapy. And I repeat that slide. Sustained MRD negativity for 3 years with PET negative means probably cure, stop your treatment, but the test should be as sensitive as next generation flow, the next generation sequencing, or the mass spectrometry. And that is what it is. Modern myeloma treatment, sustained MRD negativity equal to cure. The last part of my talk, to nip in the bud. CA breast, you are doing mammography by tons and advising mammography by tons to all the women. CA colon, you are advising colonoscopy, colonoscopy, colonoscopy. What about this disease? Once there is myeloma, you say it is difficult to cure. And if it is MGUS, you say don't do anything. You say smoldering myeloma, don't do anything. Wrong teaching, wrong approach. You have to nip in the bud. So if there is a problem, there has to be a solution. So you have to go to the epidemiology. You have to look at the genetic evolution. You have to act early. Just a question of that you are in 2025, so you're not talking about it. In 2035, you will talk about it. So what is nipping in the bud? So looking at the epidemiology and the evolution of the disease starts here, MGUS. Then it goes to the smoldering, then to myeloma, then the extramedullary. In extramedullary, you say all are going to die. Myeloma, you say majority are going to die. Smoldering, you say don't do anything. Then you say high-risk smoldering, okay, let's do something. And MGUS, you say just wait and watch. Definition of all these are well known to everybody. What happens at the genetic level has to be understood, because there is where you are going to act. Unless you act that, if the genetic evolution will take place, the myeloma will develop. The first step in this direction is this study. First study of its type done in Iceland. What is called I-Stop multiple myeloma. An aim to stop myeloma from happening. Iceland screening, treating and preventing multiple myeloma. 80,000 Iceland natives or citizens gave their blood sample to be screened for MBANT. So it's the largest single country-based study ever conducted in the field of cancer, and I think it's the first step in the direction that you got to act early. Because if you do not know the prevalence, then what do you do? So this is what the prevalence is. 5% of the population above the age of 40 has got MGUS. Did you know this? Till this study, we did not know this. 5,000 newly cases of myeloma are diagnosed in UK per year. And the beginning is this, 5% of population over the 40 have MGUS. Not only that, 0.5% of the population above the age of 40 have smoldering myeloma. So if this is the incidence, then are we behind the CA breast and CA colon? If we want to do something there to prevent it, then why not here? And we have the risk factors: male, sex, elderly people, the highest number of smoldering myeloma. So act early. And act early, is it effective? Or should we just keep observing? The answer comes from Black Swan research project, in which an early aggressive treatment was offered in Aquila trial. And the result of Aquila trial, where daratumumab monotherapy was given to patients of high-risk smoldering myeloma to see whether you can prevent development of myeloma, and that's the result. When you gave a monotherapy with dara to high-risk smoldering myeloma, 63% of patients, you had the progression-free survival, as against observation arm, where it was only 40%. So act early works. When you had melphalan as the treatment, probably okay, that don't do anything. But when you got dara and immunotherapy as the treatment, probably the thinking has to change. I summarize and conclude my talk. Success is a journey. And what I've spoken to you is what I have seen in 55 years of my life. And probably the Pandits have seen it for hundreds of years. And the youngsters sitting over here, 20, are going to see it for next 60 years. We have ticked already many boxes. And some boxes remain which we need to tick. We need to rub this word incurable and convert it into curable. It may be functional cure, it may be true cure, it may be normal relative survival. Chronic myeloid leukemia, when I was a student, 3 years. Follicular lymphoma, we used to say non-curable. Chronic lymphocytic leukemia, we used to say non-curable. All these diseases, we said early days don't do anything. Today we have started doing something. Applies to myeloma. Now, who can be cured today and who cannot be cured today is in the second and the fourth column over here. I'm going to read out this column for you. If you have a patient who belongs to this, you speak positive. Tell the person that I have the methodology to cure you. And yes, if you have a patient in this column, be very truthful. You tell him that I don't have the tools to cure you, but I will improve your quality of life and make you live for maximum possible time. So who can be cured? This is over here. Those patients are about less than 10% of the total patients. These are the patients who have achieved sustained MRD negativity by one of the method, including the PET scan, including NGS or NGF. These are fit patients. These are standard risk ISS 1 or 2. These are patients who have been treated at the early stage when CRAB or SLIM were just diagnosed, or at the stage of high-risk smoldering myeloma. These are patients who have received tandem transplants or at least one transplant, or even allotransplant, or probably CAR-T and BITE. These are patients who are like to achieve one line of treatment and get into a MRD negativity. These are patients who have sustained that MRD negativity and have an excellent quality of life. This is the group that probably you can open your mouth and say that probably you can be cured. While opposite is over there. I may not read this in the interest of time, but when you've got advanced disease, high-risk disease, don't achieve MRD negativity, then those are the patients who probably at this stage cannot be cured. So that's the biology of the disease. MGUS, smoldering, you have a prevention opportunity. Other patients, early intervention. And then MRD negativity, not to show that you achieved MRD negativity, but to say, I'm in a position to stop the treatment. So cure has got multiple facets and we need to work all together to achieve this. Many a little makes a mickle. We are inching towards this goal. There is unfinished agenda. Should we diagnose patients at the precursor stage and intervene? Should we recognize the heterogeneity of the disease and individualize the treatment? In the era of immunotherapy with bispecific and CAR-T, is the maintenance therapy still required? Utilizing MRD for guiding the treatment, mainly for de-escalating and stopping the treatment, is the standard of the care. Incorporating immunotherapy earlier and earlier and earlier. Can CAR-T be given at the stage of high-risk smoldering myeloma to cure the person? If not today, it may be tomorrow. Is still there a role for chemotherapy for relapsed patients? I think chemotherapy is now getting a bad name. Optimal timing for this bispecific and CAR-T, how early? How to sequence this 4 bispecifics, 2 CAR-Ts and many more CAR-Ts on the horizon, and should transplant be totally abandoned? Well, I think we are kamyab and we will be more and more kamyab. Thank you very much.
Stalwart like Dr. M.B. Agrawal. I need a loud clapping from my audience side for this. Very few illuminating talks are there like that, sir, really. But a question from a physician of Patna with MD medicine degree, not a hematologist. For branding a cure in Indian patients like our patients, do we need Lisa Ray and Kiran Kher? Or can an average patient be cured or labeled as cured or branded as cured? Is it possible?
Narendra Modi ji, Jindabad. If he is our Prime Minister for next 40 years, why not? And if you and me are there for 40 years, why not?
Thank you, sir.
Thank you, sir, for delivering progress in the field of myeloma. But the problem is working in internal medicine, taking grand route. The myeloma patient asks during round, sir, cure हो जाएगा, तभी हमको बाहर भेजिए. Refer तब कीजिए, cure हो जाएगा. But after listening after your talk, I can say to 20% of people, yes, it is possible. But what should be the answer for the next 80% of the patient? As a physician of medicine.
उनको आपको वही बोलना है जो हम बाकी के patients को कहते हैं. Progress is going on. Results will be there. We have got 20 tools to keep your quality of life and duration of life extended, and maybe every year a more and more positive tool will be added to the treatment. Never be negative. He never knows he may live longer than all his family members who do not have a cancer today.
Thank you, sir.
For physicians, I will suggest a simple solution to detect myeloma early. Every 40 plus anemia, screen with serum electrophoresis. Every fracture, easy fracture more than 40 years, screen for myeloma. Every patient having high creatinine more than 1.5, screen with serum electrophoresis. A simple early use of serum electrophoresis, you will get myeloma early. If you screen every patient with 40 plus with electrophoresis, you will get some myeloma.
So I want to point out that that young girl presented a paper on myeloma just before me, and she showed cases of myeloma at the stage at which they are picked up today. I think the onus lies on the physicians to suspect the myeloma, and that's what you pointed out. Anemia is an ocean. Simple thing, MCV normal with anemia is not an ocean. That's your starting point. Anemia is an ocean, but anemia with ESR of 80 is not an ocean. So that's your starting point. Anemia with creatinine of 1.5 is your starting. Anemia with globulin of 4 is your starting. So whenever you have an iron deficiency anemia, it has a specific simple CBC. While this is a CBC which is different. MCV normal, ESR high, globulin slightly raised, creatinine slightly raised, backache, backache, backache. Don't miss these patients.
So most of the time we have diagnosed multiple myeloma based on the single symptom, persisting bone pain with tiredness or fatigue more.
Absolutely. Fantastic. Fatigue, unexplained, myeloma. Backache, unexplained, myeloma. Kidney. 90% of patients to me in my hospital are referred by the kidney unit. And I tell the orthopedic, what are you doing sleeping? Why are you not referring patients? You are not picking them up. Neurologist, I say, what are you doing with your neuropathies? You are not picking up patients. While kidney people, not a single patient is there who comes to them and does not undergo serum-free light chain assay. The lab is bombarded with SFLC. Every patient with raised creatinine, normal size kidney, they do FLC as the first test. And the referrals which I have, in a year I have 300 references from the kidney department alone, while 5 from orthopedic, 1 from neurology.
One message from your side, all the clinicians must have a wide index of suspicion.
Absolutely,
to
absolutely.
Catch hold of this very menace.
We should have physicians like you all over.
Thank you, sir. Session is closed.
Thank you so much, sir, for the inspiring cases and the cure and advanced therapy in multiple myeloma. I would request chairpersons and a speaker to take a photograph for the memory. Thank you so much, sir. Now we have our next session on how to report bone marrow aspiration, what every pathologist should know. And for this, we have chairpersons. I would like to invite Dr. Sorry. Sorry for the mistake. I would like to announce again our next session is how to report peripheral blood smear, what every pathologist should know. For chairpersons, I would like to invite Dr. Salil Kumar Misra, Senior Consultant, Modern Lab, Patna. Please join us, sir, on the dais. Next, Dr. K.C. Nathni, Senior Consultant, Pathologist, Maurya Lab, Patna. Please come on the dais, sir. Dr. P. Sarad, Senior Consultant, Pathologist, Maurya Lab, Patna. Can we have on the dais, sir? And also, we will have our parallel discussion on clinical hematology in Hall B. Who are interested, please go and attend the sessions. I request our chairperson to introduce us to the speaker. Good morning, sir, and very warm welcome.
I invite Dr. Devdutt Basu, Professor of Pathology at Mahatma Gandhi Medical College and Research Institute, Pondicherry, to come on dais and present his paper.
Yeah, I'm on the
Dr.
dais.
Devdutt Basu.
Good morning, everyone. Could I have a pointer, please? I don't see it here. दिख नहीं रहा। ठीक है, मैं शुरू कर। All right, I think I'll start. If I can get, otherwise I'll use the. It's not there, sir. Okay. नहीं, चलो ठीक है. Okay, good morning, everyone, and this talk is, though it says what every pathologist should know, I think it's what every one of us, clinician and pathologist, must know. That's what I'll go. Peripheral blood smear examination opens the window to the world of clinical medicine. What are the indications of doing a peripheral smear? There are two basic indications, one that is initiated by the clinicians and one that is initiated in the laboratory. With the advent of automated cell counters, the number of peripheral smears has come down drastically, and that's justifiable. But when we are beginning as a trainee in pathology, all those at the initial stages, every slide that you see is an indication. If you find a slide lying in the corridor, pick it up and have a look. That's how you will learn how to look at the morphology. The clinician-generated indications, this is adapted from Baba Bain, is anything with a refractory or severe anemia, unknown. Anemia or jaundice, raising the doubt of a hemolytic anemia, raising the doubts of a sickle cell disease, petechiae or other mucocutaneous bleeds suggestive of thrombocytopenia and its causes, unexplained or severe infection suggesting neutropenia. If you're thinking of a chronic lymphoproliferative disorder or a myeloproliferative disorder, features are those of DIC, recent onset of renal failure, particularly in a child, suspicion of infection. So these are something that a clinician wants a peripheral smear at the upfront investigation. In the lab, the abnormal counts that comes, there are consensus. Each lab should have its own kind of a protocol that, okay, if these are the values, we will look at the peripheral smear. Or your cell counter flags. The cell counters give you a flag of that this particular case needs a peripheral smear. It's always good to correlate the clinical history, histograms, and automated CBC. That usually solves all the cases, and it's generally how it is. What a pathologist must know, the technical aspects and the diagnostic aspects. So I'll be covering this in two parts. So the complete blood count and peripheral smear examination needs a good sample, your machine, with all the parameters and a well-made smear and a retic count. So with this armamentarium, we move ahead. It's good to look at the gross smear, and that gives you a lot of clues. If that is normal, what is this? It's an anemic sample. This one? Erythrocytosis, yes. This one? It's leukocytosis. This one? Increased proteins in the background. This one? A purple colored smear. It's a heparinized sample. This one, it's a bad sample, no greasy sample, so don't look at it. It's important to know about the sampling, know about your EDTA tube, right amount, right vein. I will not go into the details of that time. Send to the lab on time. Within 4 to 6 hours, an EDTA sample should be sent. And there are certain situations where you have to make a direct finger prick smear. Don't use the EDTA sample. And that's when you're suspecting a platelet function disorder. The child is bleeding, your platelet counts are normal. Look at the smear to look for platelets. When you get this, what do you think? That's a sample that has been taken up from the central line. That's a heparinized sample. Ignore it. The counts have come as severe pancytopenia. And on the peripheral smear, you see this. What is this? A clots. There are clots in the smear. So again, a chance for rejection. Don't look at it very carefully. Know about the storage artifacts. If you keep your sample stored in EDTA for more than 8 hours, especially at room temperature in hot summer months, you can get crenated RBCs, you can get, the MCV can be falsely raised, neutrophils can be pycnotic, lymphocytes may show vacuoles, and platelets will swell up. Smear making is an art. So again, there are tips for good smear making. All of us must learn how to make smears and not leave it just to the technicians. Clean slide, smooth edged spreader, single size drop. The angle is important, 30 to 45 degrees, and one decisive stroke. There are lots of smearing artifacts that can happen. One on the left side is the normal one, and rest of it is all badly made smears. You will have problem when you're interpreting the slide with such smears. Know that each smear has a tail. And the tail should be a feathered tail and not a long tail. And that's the problem. You have a routine CBC, your counts are like this, 13.5, TLC 16,000, platelet 255. Beginner, a rookie resident is seeing the slide, feels the TLC and platelets are not tallying. He jumps straight into high power and still finds no platelets. His senior comes up and tells, hey, look at the tail. That's important for us to look at the tail where the WBCs and the platelets may get spread. Always look at the edges and slide of a smear. It's good to have a good colored smear. You know, we love the colors, right? So what is the ideal pH of a buffer of the Leishman stain? 6.8, right. Your slide should be properly stained. Remember that I had Asian paint, Mera Wala pink, that is my blue. It should neither be too pink nor too blue. If it's too pink, it is acidic. If it's too blue, it's basic, and you will have problems with your morphology. Understand the problems with overstained and understained smears. Also remember about the stain deposits and contaminants. What does this change? There's a water artifact, either too much humidity in the air, or there is water in your methanol, or the staining is going on and your tap is open. So the water is flowing onto the slide, and this is what you will get. So features of a well-stained smear is on the color. Just appreciate all the colors that you know, and that is how it will look good. And so an ideal pH is evenly distributed, appropriately thick, well-stained, without artifacts. Must know about the zone of morphology, neither too thin nor too thick. If you're looking at the thin slide, everything will look like spherocytes. If you're looking at the thick end, everything will look like a ruler formation. And multiple myeloma you may inadvertently diagnose. What to do on a scanner? There are two ways of... Where's the screen gone? Stopped? Yeah, there are two ways on the scanner, the battlement method or longitudinal step method. The way you want is the way you develop. On a scanner view, you can pick up agglutination, you can pick up rouleau formation, you can pick up clumps of platelets, and you can pick up microfilaria. A low power view is just to get a good area. There's nothing really that you really look at a low power, excepting to identify your monolayered cells, tailing, and clumps. High power view gives most of the things. You can pick up whatever you want, sickle cells or schistocytes, hypersegmentation. Do your differential count in the high power and look at the platelets. Reserve your oil immersion for finer details. Bite cells, toxic change, or rods, past positivity, hairy cells, platelet abnormalities, and parasites. The next part on morphology, what we should know, I'll, for convenience sake, talk of it differentiating RBCs, WBCs, and platelets. Must know your normal scatter plots and your histogram. So suppose this was a 14-year-old girl with lassitude and tiredness and poor performance in school. You have a microcytic hypochromic, right? You can appreciate it from the CBC. Your RBC scat will give you. And you look at the smear, and you know you're dealing with a microcytic hypochromic. What next? Look for ferritin. If you don't have ferritin, you can presumptively diagnose it as iron deficiency anemia. This is another microcytic hypochromic in a 22-year-old girl, chronic anemia, low MCV, mild jaundice. You know that this is not iron deficiency anemia. Then isopoikilocytosis. Do a retic count, look at the golf ball, and you diagnose your alpha thalassemia, HBH, based on your HB electrophoresis, etc. 26-year-old lady pregnant, 6 grams hemoglobin, normocytic normochromic. If you look at the histogram, you know you're dealing with dual deficiency or anemia on treatment. This is what you will get. What about this? Microcytic hypochromic, and you see spherocyte-like cells. This means it's a recently transfused. This is recently transfused. Don't call them spherocytes. When your MCV is high, you have to first identify whether it's true macrocyte or is it a reticulocyte response that is causing an high MCV. So that's important. When it's a true macrocyte, look for hypersegmentation and oral macrocytes, oval macrocytes. Another case with a high MCV, but look at the MCV and MCH and MCHC. The rule of 3 is flouted, grossly abnormal indices. You look at the gross sample and you will find clots. And that's you're going to diagnose a cold hemagglutinin disease. If you observe more 65-year man with osteolytic lesions, Roulet formation, you know where it is. But as Dr. M.B. Agarwal in the morning said, a person presenting with renal failure and you're finding Roulet formation, look for plasma cells. You'll make your diagnosis. Each of the poikilocytes tell you a story. A young girl with jaundice, you know it's sickle cell anemia. Same, sickle cells are there, but what else is there in the background? Something else you're getting? Howell-Jolly bodies. That means this person's sickle cell disease has hyposplenism. Maybe autosplenectomy has set in. Clinical presentation with severe infections. This smear, when you see so much of disarray, acanthocytes, target cells, Howell-Jolly bodies, what surgery has this patient undergone? He's had a splenectomy. Right? Post-splenectomy changes, learn to appreciate it. Howell-Jolly bodies are important. Important in the follow-up of post-splenectomy, refractory ITP, etc. You must look for Howell-Jolly bodies. Target cells tell you a story. This is a Sardar boy, recurrent jaundice. You do your HPLC and you diagnose HBD disease. Target cells tell you a story so appreciate it. It could be thalassemia, it could be sickle cell, it could be hemoglobin C or post-splenectomy. Smear helps you provide a differential diagnosis, like spherocytes. If it's a child with splenomegaly and jaundice, you know you're dealing with a hereditary spherocytosis. Investigate accordingly. If it's, on the other hand, a woman, known case of SLE and presence with spherocytes, you're probably dealing with an autoimmune hemolytic anemia, right? In a newborn, the same picture will tell you that you're dealing with a hemolytic disease of newborn. So when you see spherocytes, do a Coombs test. If it's positive or negative. If it's positive, rule out a drug or transfusion history. Then investigate for autoimmune hemolytic anemia, warm versus cold, primary versus secondary. If it's negative, diagnose hereditary spherocytosis. A 78-year male with massive spleen. You have teardrop cells, you have a leukoerythroblastic blood picture, and you can diagnose your myelofibrosis. Same scene can also be seen in metastasis. Right? Whether it's an adult with adenocarcinoma or a child with neuroblastoma. So leukoerythroblastic blood picture tells you its own story. Cause of anemia and jaundice or anemia and bleeding, jaundice and bleeding, and you see schistocytes. So that's another very ominous finding on a peripheral smear. A 58-year-old man brought with seizures and confusion, hypertensive. Counts are low, creat is high, and you see schistocytes, you diagnose TTP. Similarly, a woman, pregnant woman at the labor, bleeding from every orifice, you know you're diagnosing DIC. A child with hemoglobinuria, you know you're diagnosing HUS. Currently, schistocytes with fragmented cells is an ominous significance. You know, you can grade them, and even 1+ is important. Schistocytes, thrombocytopenia, nuclear RBCs, it's diagnostic of MAHA. There are other causes of thrombotic angiopathy which you must keep in mind. So if you have clinical and smear suggestive of schistocytes, look for a vascular trauma. If it is recent bypass surgery, mechanical valves, that could be the cause. If there is no such history, rule out infections, travel, and rash, because many a times rickettsial infections can cause. Otherwise, thrombotic microangiopathy. Pregnancy or diarrhea or neurological symptoms or drug and cancer. Each of them is a cause for thrombotic microangiopathy. If it's diarrhea in a child, rule out HUS. If it's an adult, Adams 13, even if you don't have the facilities, you can diagnose TTP. A 23-year-old girl with ingestion of insecticide, severely jaundiced, and you see bite cells, bite and blister cells. They are also a significant finding. You do a Heinz body, simple test to do, and you diagnose your G6PD deficiency. PS often helps you confirm a suspected diagnosis. This was a girl, 20-year-old. Parents were second cousins. She had neurological symptoms, tics and grimacing and dystonia. Her CBC was always normal. A PS was never done. We did a PS, and there it is. You diagnose neuroacanthocytosis. Are these acanthocytes or echinocytes or what? These are artifacts. Learn to appreciate storage artifacts. It at times indicates a specific diagnosis. There was this 71-year-old lady. She was the sister of our professor of neurology. She had come to attend a wedding in the family. She just came for a routine checkup, and we found this. Elliptocytes. Then we screened the family. There were 5 siblings, all of them elderly, 60s, 70s. It was a family of hereditary elliptocytosis, and they had never been diagnosed all their life. In contrast, this 12-year-old boy, absolutely symptomatic, jaundice, transfusion dependent. A peripheral smear gave the story of stomatocytosis, Southeast Asian stomatocytosis. In homozygous, it's a very bad disease to have. Heterozygotes are often asymptomatic. 24-year-old man, recurrent jaundice, splenomegaly. This was a case, the slide was so bad that I didn't bother to really, even myself, I was not very keen on looking at it. When my resident said, sir, I had seen this. In oil immersion, she had picked up basophilic stippling, and we were able to diagnose a pyrimidine 5' nucleotidase deficiency. Okay, so peripheral smear can give you specific diagnosis. A male who's come back from a trek with fever, clinically suspected leptospirosis, you pick up malaria. So that's the beauty of a peripheral smear. Well done. There are other clues to malaria, looking for monocytes, pigments, and your cell counter. Malaria can be picked up if you look at, notice the bifid, WBCs, neutrophils, pseudoeosinophilia. All these are clues to vivax malaria. Microfilaria can be picked up, Babesia can be picked up, Borrelia can be picked up on the smear. WBCs add color to the peripheral smears, and what information does this give you? Drumstick. So it's a female. If you don't have the history, you can pick that up. Of course, the entire spectrum of toxic change should be understood and well, because this indicates an ongoing pyogenic infection is going on. It can often be confused with GCSF therapy, the very coarse granules that you get. 8-year-old child with recurrent chest infections, Chediak Higashi. Very coarse, brown-colored, violet-colored granules. All your viral infections can be picked up well on a peripheral smear, right? 11-month-old child, vacuoles in the WBCs. Tell you that you're probably dealing with a storage disorder. Blasts, definitely, rods, an important clue to the lineage of the thing. Another, in a girl, this was recent one. It is an emergency, one of the very critical diagnoses that you make during emergency. A girl with bleeding all over, pancytopenia, and you find atypical promyelocytes. So that's a very, very important diagnosis that you make, because it permits you a rapid provisional diagnosis in hematological emergencies, diagnosing APML. Morphology gives clue to the molecular diagnosis. NPM1 mutations show this cup-shaped things. Elderly male with cytopenia, you see an occasional blast. You also see pseudopelgarhue. Your MDS is getting diagnosed based on the peripheral smear. Burkitt, typical basophilic cytoplasm nucleus. T-cell leukemia lymphoma, adult T-cell, even Sézary cell can be picked up on the PS. CML, your cell counter and your peripheral blood, and CML is used at diagnosis, and follow-up is entirely on your peripheral blood. You can pick up progression of the disease. 68-year-old male, generalized lymphadenopathy, you're dealing with a CLL, chronic lymphoproliferative. Go ahead and do the flow and diagnose it correctly. Same patient, but his hemoglobin is only 4. CLL with autoimmune hemolytic anemia. So all that can be picked up. They all look alike, but there are subtle changes. On the left is a SLVL, center is a follicular lymphoma with cleaved, and on the upper right is the hairy cell leukemias. Look at the scatter plot. Even whether it's an acute febrile illness like a dengue, it has a typical figure of 8 appearance of the lymphocytes, and all your acute leukemias, chronic leukemias have abnormal scatter plots, and that gives you a clue to looking at the smear correctly. Platelets, it's a rough guide, but it's a good way to roughly get the total amount of platelets that are there. 1 platelet per oil immersion equals to about 10,000. So those who are beginning, keep that in mind. Antenatal platelet of 70,000, and you hardly see platelets. When you look closely, you find that there are large gray colored platelets. So you have a gray platelet syndrome. This one, giant platelet with Dohle-like inclusion in the neutrophils. You're dealing with a Meheglin, right, good. It is also often, peripheral smear is used to detect complications. This was an hemoglobin E beta thal. She was pregnant, and her hemoglobin dropped in period of time during her gestation, pregnancy from 10 to 7. And the cause? She had developed folate deficiency. So peripheral smear was the first guide that told us that this patient is developing megaloblastic anemia. Child of thalassemia presented with fever, and there was a severe drop. We thought probably going into crisis, detected malarial parasite. The case of CLL 2 years later, prolymphocytes can be picked up. Another important use of a peripheral smear is to validate and check the counter values. There was this 30-year-old lady whose repeatedly platelet counts were coming as 30 to 40K. Look at the platelet histogram. The upper discriminator is not touching the base. You know there are giant platelets. There are clumps of platelets. So EDTA-induced pseudothrombocytopenia. A case of hemoglobin H disease. The platelets was on impedance 11 lakhs. And look at again the platelet curve. It is kind of all over. Here the microcytic RBCs were misinterpreted as platelets. So that's where you have to use a peripheral smear to validate your count. Same thing happens at times in DIC or MAHA. The schistocytes can be mistaken, and the platelet count is never accurate on the cell counter, especially the ones that do on impedance. Case of thalassemia, hemoglobin of 2 and TLC of 1 lakh. First thought was maybe he's developed some leukemia. It was basically the older versions where nuclear RBCs are counted as WBC. So all these things are necessary when you're looking at a slide to validate your counts. Beware of artifacts. This is an interesting case. A newborn baby, routine sample came with a platelet count of 18 lakhs. The resident brought the slide to me, and this is what I saw. I was grappling, wondering, what is this? Is it some kind of membrane spherocytosis? When few minutes later, another resident brought another sample of a newborn baby with a platelet of 13.8 lakhs. And it was not just 2 samples, multiple, 5 or 6 samples came. All of it came from the neonatal ICU. As we went back and traced, all the samples had been kept prior to sending to the lab on the hot air oven. The samples had been kept, the EDTA tubes had been kept on the hot air oven. So thermal artifact induced changes. So keep that in mind always. What are these? Peripheral smear showing? Anyone? Nothing but endothelial cells. Okay, that can come and mimic, you might think of carcinocythemia or some such thing that is there. These are squamous. Squamous cells can come up. What is this? A cotton thread. What is this? That's a fungus, and that's the real one. So don't get confused. Acute febrile illness. This was an interesting case which we happened to discuss yesterday in that thalassemia group. A resident again rang me up in the middle of the night saying, I have diagnosed trypanosomiasis. Sir, we have got a case of trypanosomiasis. We looked at it carefully. The patient did not have any travel history. These are nothing but proplatelets. These are platelets, at times because of smearing or because of some pathology in the marrow become abnormal, and that's the real one. So keep it in mind. What is this? Malaria, ring, simple, right? No problems. What is this? Howell jolly bodies, not Heinz, Howell jolly bodies. Sorry, I heard you. Okay. And what is this? That's a platelet sitting on an RBC. So keep all these little artifacts into account when you're looking at the slides. So what might a blood film help us do? It can help us diagnose a disease, support a provisional diagnosis, provide a differential diagnosis, monitor disease and give information on complications and side effects, and validate and explain the cell counter values when they are abnormal. But it can also tell us something that as of now, no automated instrument can tell us. Hypersegmentation, target cells, stippling of the RBCs, platelet satellitism, microfile area, and finer details of blasts. So that's the last slide. A drop of blood tells a story. We must be able to distinguish whether the story is a fact or a fiction, and that's what all pathologists must know. Thank you very much. I'd be happy to, any questions or comments or anything.
So what is your message to a clinician? I am a physician. So
Yes.
should we go for smear in all?
No, sir, that's how I started it. Of course, it is not practical to do a smear in all cases, right? So if you have an indication where you need to know the smear, my first slide was on that. When you definitely think a smear, please let us know. Rest, leave it to the pathologist to look at the cell counters and make smears. When we were young, we used to see all the smears that came because that time automation was not there. But now, most labs do have reliable automated cell counter findings. So a pathologist must know how to interpret that and make smears from the 100, whatever cases that come. Roughly in my lab, it's about 10% of samples are made into a smear. Rest of them, we rely on the cell counter. But if any time you think, as a clinician, that yes, I need to know a peripheral smear finding, let us know and we'll do it.
So what we do, whenever we have doubt, we usually go for the CVC. But whenever we have some doubt, whether there is a bicytopenia,
Yes.
there is associated some feature, jaundice.
Yes, definitely.
So then we go for.
Yes, sir. The first, so if you have a clinical suspicion of an unexplained anemia, unexplained cytopenias, cytosis, even leukocytosis, or you are suspecting, especially hemolytic, a peripheral smear has very important role in that. A child comes to you with features of a sickle crisis, pain, bone pain, chest pain, peripheral smear is warranted. Or a child patient has a mucocutaneous bleeds and you want to know the platelet related. So those are definite indications where you will ask for a peripheral smear and the pathologist has to look at the peripheral smear.
Thank you, sir.
This is my opinion that almost all smears should be seen by a doctor. If you have a little less workforce, increase that. But see all these smears. It's very, very important. I've seen people missing, at times really missing, the diagnosis. The patient is going from here, there, and they are misdiagnosed. If the count is 10,000, people never suspect it's a case of leukemia.
No, sir, that is what that's definitely, there has to be a very strong index of suspicion. If it is 10,000 and your cell counter's scatter plot is being abnormal, you must make a smear. Or your clinician tells you this is unexplained, the patient is severely anemic, you make a smear.
For me, I see all these smears. I make it a point, no matter how much time it takes.
Yes, that's.
And I ask all my fellow pathologists to just see it once, have a glance. Have a glance. You might not miss the diagnosis.
Definitely, your point is well taken. No, point is absolutely well taken, but in a very high load setting, you have to rely on your CBC. So it is important for a pathologist to also know the CBC findings.
Your workload.
In 800 plus outdoor, it's 800 plus outdoor in medicine ward. It's difficult to go to ask.
My way of looking at it is you rely on your cell counter findings. You train your residents and train everyone, including the technician, because the cell counter gives you very good information. So if you can interpret that many a times, and especially if your counts, etc., are within normal, you could rely on the cell counter. That's how I look at it.
Okay.
We have to, but it is very important, as you say, as a beginner, as I said in the first slide, as a beginner, must appreciate and see as many slides as you can see. Unless you know the normal, you will never be able to pick up the abnormal. So you must be able to identify what is normal on a peripheral smear, and then you will be able to do.
Sir, I too, good morning sir, I too have a query. Actually, sometimes we observe that hypersegmentation is there and MCV is just borderline or
Yes,
it's
definitely,
not very clear.
definitely.
And hemoglobin is normal or sometimes even in higher side of normal range. Then, I mean, in those conditions, what to consider or how to report?
Yeah, if you are convinced about your hypersegmentation, it could be. It is one of the first signs of megaloblastic anemia. Hypersegmented neutrophils arise even before your MCV goes up.
And
So
hemoglobin is normal.
yes,
Even
so
then.
you would think, get a B12 or folate done in that patient. If you're convinced about your hypersegmentation that it is there, get a B12. It's a good finding on the peripheral smear, provided you are convinced. The problem nowadays that happens is at the slightest trace of anemia, everyone gets a shotgun therapy, so B12, folate, iron, everything is done and even treated before it actually reaches your table. So those are the things. But if you are definitely sure that it is a hypersegmentation, take the history, and if you think, advise a folate or B12 levels. B12 especially, it's so rampant in the country.
Okay, thank you, sir.
Yes. Yes, yes. Hypersegmentation is also a feature of iron deficiency. I mean, I have my study also. We have done a project. Yes, it's a feature of iron deficiency anemia. Also, we are seeing regular hypersegmentation in MDS.
Sorry to
it's quite
interrupt. Actually, we are getting late, so we can have next discussion.
Yeah.
And we can have it in discussion during.
Sure.
Tea.
Sure.
Thank you
very much.
Many thanks, Dr. Dev Dutt.
Thank you so much, sir, for the interactive and enthusiastic session. I would request chairperson to join with a speaker for the photograph. Thank you so much, sir. Now we have seen the interpretation of the peripheral blood smear. Let's move on to the how to interpret bone marrow biopsy reports. Now we have our next session on how to report bone marrow aspiration, what every pathologist should know, for which we have chairperson. I would like to invite Dr. Sangam Sukla, Director, Sukla Path Lab and Research Center, Patna. Please, sir, join us on the dais. And Dr. Sanjeet, Professor and HOD, Department of Pathology, AIMS Devgarh. Can we have you, sir, on our dais? I would request our chairperson to introduce us to the speaker.
Good morning, everyone. I would like to have our beloved speaker, Dr. Deepak Mishra. Sir is Director and Senior Consultant at the Department of Laboratory Science in TMC, Kolkata. Sir has got more than 25 years of teaching experience at Armed Forces and other medical institutions. We welcome you, sir. The floor is yours, sir. Please.
Very good morning to this fantastic audience. I will fail in my duty if I do not thank Avinash, who has been doing this year on year. RAKTAVIGYAN, the word which I really adore. Fantastic word he has selected, and he is doing it every year, and this is the 7th edition of the program. The topic that he has given me is to speak on bone marrow aspirate studies, what a pathologist should know. You just heard a talk on multiple myeloma, the management, the cure by Professor Agarwal, and Professor Dev Dutt Basu has given you a fantastic atlas of cytomorphometry in hematology. So he is a very astute morphologist, and he has given you a fantastic overview of what all you can see in a peripheral smear. So my talk will be a little different, and I will give you a background as to why I would like to take it differently. So when I started my career as a pathologist, and I became examiner in MD and all that, so without naming the institution, I was selecting the slides to be given to candidates. And the chairman of the examiner said, "Sir, bone marrow biopsy mat दीजिएगा, हमारा इधर bone marrow biopsy होता नहीं है." So I was a little surprised, but I didn't say anything, but I took out the biopsies and gave only the aspirates along with the peripheral smear, some peripheral smears. So then I asked, then how do you diagnose the plastic anemia, hypoplastic anemias? So I was a little surprised that a medical college where you are teaching postgraduate students, not doing a bone marrow biopsy, not exposing them to bone marrow biopsy is not good. So a lot of things will go into this talk as to why it is important. I find postgraduate students also here, and most important is that I find many clinicians being present in the audience. You see, bone marrow in many institutions are done differently. In some institutions, the pathologists, the residents go and do the marrow, and in some institutions, the clinical trainees like MD medicine students that do the marrow. So differently it is done. So my talk will be to prime you as to how you should approach doing a marrow, what is a good marrow, and what all you should look in a marrow to give a comprehensive report. Dr. Devdutt Basu has shown you the pictures, and he has categorically said the technology is advancing and you are having very smart counters these days. So when you see the peripheral smear, you already have the counts with you, and you just validate the count. And sometimes the machines will flag you what is there in it. You just have to confirm. So now I will go a step forward. Now you have digital technology, you have digital pathology, digital hematology. So in an algorithmic fashion, you know that AI, machine learning, deep learning are penetrating into every sphere of medicine. So in my hospital, which has a digital hematology platform, so we have an algorithm that if you have blasts which are lesser than 5% will enter into the digital hematology platform and will validate whether they are really blasts. And if blasts are there, it will take the picture of the blasts, you can see it on the screen, and it will tell you about 5% blasts in the peripheral blood. So gradually we are evolving in technology. Depending on the resources that you have, you can add these technologies to your laboratories so that the clinicians are happy and they get a comprehensive, reproducible results. But human eye cannot be replaced, as you have seen so many pictures in peripheral blood. So many times you have to validate it by looking. You have cystocytes. Today the digital platform will give you the number of cystocytes per 100 WBCs, the number of rings, malarial rings, and it will give you a parasitic index. So we are moving towards a highly technology-driven environment. Bone marrow biopsy or bone marrow aspirate are techniques which yet hasn't been automated, but today you have digital platforms which can also look at the bone marrow aspirate smears. So you have Salavision, you have Scopio, you have West Medica. Large number of companies are now having platforms which can not only digitize peripheral blood cytometry, and also it can do bone marrow cytometry. So after all, why do you want that you should look at the marrow? Because in many clinical conditions, you need to know the functioning of hematopoiesis. So it is a technique by which you must look at the hematopoietic mechanism, because which is mostly present in the marrow. You can look at the reticuloendothelial system. So because the lymphoid and the lymphoid genesis happens in the marrow and also the peripheral lymph node organs and thymus. So it is important that you must look at them. And if you see the beginning of hemopoiesis right from the yolk sac to the liver, and finally by about 4 months your bone marrow is the predominant site of blood cell production. So the bone marrow produces a large number of hematopoietic cells on a daily basis, and it has the capacity to increase its capacity up to 5 to 10 times depending on the stress situations. So bone marrow is a very, very versatile organ and very important for the production of blood cells. So indications of bone marrow examination I did not highlight to save some time. Hematological disorders, non-hematological disorders, you have red cell, white cell and platelet disorders. You have disorders of myelosuppression. You have conditions in which you would like to monitor the response to treatment. On the other side, when it is non-hematological, which many clinicians would like to do marrow, the first condition is pyrexia of unknown origin. You always look at it, and you do a lot of ancillary tests along with it when you remove the bone marrow aspirate. Infections like tuberculosis, leishmania, cryptococcosis, histoplasmosis, all are conditions in which a bone marrow is done. Storage disorders is very important. You have a large hepatosplenomegaly, patient has dysmorphic features, clinical suspicion is of a storage disorder, whether it is Gaucher's or Niemann-Pick's or any other mucopolysaccharidosis, you can have bone marrow examined. And lastly, metastatic disorders. Many times the solid tumors can have metastasis into the bone, and you can see it in the bone marrow. So then somebody may ask why you want to do biopsy. Why not just aspirate? As I said, many institutes of late were not doing biopsies, but gradually the institutes have started doing both, because in the same sitting it is always better that you do the aspirate as well as the biopsy. Aspirates will always give you a better cytological detail because you are making a smear, just like fine needle aspiration cytology. You can employ large number of other special stains or cytochemical stains on these aspirates. It is useful in the diagnosis and characterization of leukemias. You can know the iron status in the marrow, in iron deficiencies, and you can put it into ancillary techniques like flow cytometry from the marrow aspirate, cytogenetics from the marrow aspirate, molecular genetics from the marrow aspirate. All these things are to be done currently to give comprehensive diagnosis. And if you compare the procedure, aspiration is much less painful than the biopsy. But as I said, that aspirate and biopsy should be done together. So this pain factor is not an important deterrent to do a biopsy. So when you do a biopsy, you get the exact cellularity of the bone marrow. So bone marrow cellularity cannot be commented upon the aspirate because of many factors. They are technical factors, they are operator factors. The person who is doing it, it's also very important that he is well trained to do a aspirate and a biopsy. Topographical information. So when you look at the biopsy, you get when you eyeball the biopsy, you get to know what is the degree of cellularity, where is the tumor deposit, or where are the cells which are more concentrated, what is the status of the blood vessels, what are the status of the fat disposition, how is the stroma, everything you can get a look at it. So there are many disorders in which the involvement of the marrow is quite patchy or heterogeneous. Multiple myeloma is one of them. Metastatic deposits are another. Some place mesometastasis, others may be normal. Similarly, myeloma also the same. Lymphomas also could be the same. And many times when you do in a highly packed marrow, many times the aspirate is pretty dry. So biopsy is important, and when you see biopsy in these situations, you'll find that the bone marrow is so tightly packed, you haven't aspirated anything. So both the techniques, both the procedures should be done at the same time for a better diagnosis. You employ large number of needles. I'll just enumerate them, and the commonest needle that is currently in use is a Jamshidi needle. Previously, we used to use Islam needle. These are the two needles which are very commonly used. Some can do only aspirate, some can do both aspirate and biopsy. So depending on the situation, you will be selecting them. Both Illinois and the Jamshidi can do biopsy as well as aspirate. So these are the pictures of the needles, and depending on what your institution is buying, you can use them. I think mostly people are using Jamshidi and Islam, and you have reusable needles, and you can use it after autoclaving. You can have disposable needles. You can use it once and then throw it. But being an under-resourced country, many times you have seen we have been sterilizing with Sidex. You overnight put the needles in Sidex. You have 10-15 needles, and then you rotate it, and after 5-6 procedures you change it, because the bevel becomes blunt and the bone marrow procedure becomes quite painful. So all these things are important in a clinic, that you do processes which are less painful to the patient. So this is the sites at which you can do it. This is the posterior superior iliac spine as well as the anterior superior iliac spine. Mostly it is done from the PSIS, where you get a good yield of aspirate as well as you can do a good biopsy. So I will not go into the details because most of you must be doing it. I will skip this, but in case you are not able to do it from the PSIS, you can do it from the sternum. You can do it from the spinous processes of the vertebrae, and you can do it also from the ribs. And in pediatric patients, many times you can do it from the tibial tuberosity. This is the kit that you should have when you are doing a marrow procedure, which should have the needles, which should have the syringes, and which should have the tubes, and then only you must start. In our center, the clinicians do it because we have DRNB residents in medical oncology, in clinical hematology. So they do the process, but we do send a phlebotomist to do the smear, because by the time they do the process, put the bone marrow onto the slide, and by the time they spread it, many times the blood clots. So to avoid that and to make the smears better, it is always better to have phlebotomists who should help in making the smears. And initially we are having poor quality smears, and after we said that the phlebotomist should do it, so now the smear quality has become much better in the past 12-13 years. Why we did it? Because my boss was Professor Maman Chandi, many of you must be knowing. So very often he used to come to the lab to see slides. So in one important case, when he saw the slide, the peripheral smear wasn't to his liking. The bone marrow aspirate was not to his liking, so he said, the fundamental to a good hematology department is to have good quality peripheral smears and good quality bone marrow aspirate smears. Not molecular genetics, not cytogenetics. So until unless you have these two things sorted, then only other things would develop. So I would like peripheral smear and bone marrow should be of the best quality. And even though we had good quality PBS, sometimes the bone marrow aspirates were not of good quality because of the staining or because of the spreading of the marrow particles. So we improved upon that. Procedure, I will not go into the chronological events, but usually you prepare about 5 to 6 good quality bone marrow aspirate smears, And you must take imprints when you are taking biopsy, because sometimes imprints are better than the aspirates. It gives an exact biopsy picture of the bone marrow biopsy. So imprints are extremely important. So 5 to 6 good aspirate smears and 2 to 3 good quality imprint smears must be done when you are doing the aspirate biopsy procedure. So when you put the biopsy needle, you must rotate it inside the PSIS, and that is very important. Many times you don't get good quality biopsies because you have put the needle into the same bone hole as you have done the aspirate. So all that you get is clotted blood and very few medullary spaces, which is not adequate for definitive opinion. So it is important that you should do the biopsy about a centimeter away from the aspirate hole, and you should anesthetize the periosteum properly. The previous kit showed that you have Gilocan 1% in that. So you infiltrate the periosteum, give a reasonable period of time so that the periosteum is anesthetized, and then put the needle. The only pain that the patient is going to have when you have the sucking pain, when you aspirate, putting the needle, putting the syringe, when you suck, that is the time when the patient will shriek a bit, otherwise not. Very apprehensive patients, pediatric patients, you must give ketamine anesthesia, which is a very short-acting anesthesia. The effect is about 20 to 30 minutes, and your process, your bone marrow procedure will be very smooth. So don't hesitate to give ketamine when you have apprehensive patients and you have pediatric patients, so that your aspirate and biopsy is good. So this is how the pictures are. You have PSIS identified, you have put the local anesthetic, and you have the needles, the aspirate needle and the biopsy needle in handy position, and then you can do the process. So the person should be given independent what you call as to do processes or the procedures after seeing at least 10 bone marrows, and then he should do first, or she should do under supervision, and then can do it independently. So indications and contraindications and complications of bone marrow aspirate processes, you all know that it can have in patients who are very osteoporotic, and in children, sternal aspirate should be avoided, because the sternal aspirate needle is very short and it may cross both sides and can injure the heart and other vital organs. The areas where skin infections are there, you should avoid it, and biopsies should be done after you have checked the coagulopathies, any abnormality in coagulation. So if PTAPT is abnormal, you must be careful. If it is partially abnormal, you can do the process, but you must put pressure on the site of the biopsy for a little longer, so that the oozing of blood should not be there. In the complications, many times you have hemorrhage, you have not looked at the coagulation profile. Continued pain at the procedure site may have a problem for some patients. Infection and perforation of major vessels are very rare complications, but they can be there. Sample collection is very important, because if you do not collect, you lose precious sample. You can't go back again and do the process. So usually you have the normal smear preparation. So after you have prepared the smear, you may have to collect sample for MRD. We just, Dr. Agarwal spoke about is measurable residual disease. So if you have to do measurable residual disease, it should be the first pull. Otherwise the marrow will get diluted. So first pull should go for MRD. So then next is for aspirate, and next is for cytogenetics and molecular genetics. So you must follow that order. Sometimes in PUOs you may have to do collection into culture tubes, so do that. And when you prepare the smears, there has to be an assistance, and the assistant should be a phlebotomist who is conversant with making good quality smears. And when you use this smear, the slide should be quite clean and grease free so that the particles can be spread well. I'll show you the pictures of good and bad quality smears. So bone marrow evaluation, when you do it, you must write your test requisition form well. Many times the clinicians will write bone marrow for study, nothing, just 3 words. The demography will be there, patient name and age, down below bone marrow for examination, and you will sign. I hope the clinicians are listening. Please fill up appropriate clinical history so that the interpretation will be appropriate. So in laboratory we call something as garbage in, garbage out. So don't do that. And along with the bone marrow, the same day's peripheral smear also should be taken and sent along with the bone marrow aspirates and biopsies. And all bone marrow aspirate, that's why I put it in red, all bone marrow aspirates and bone marrow biopsies should be reported with clinical history and alongside the examination of peripheral blood. So this is the different ways how you get the bone marrow aspirate. Some are good, some are bad, and some are ugly. Usually the ones that are quite particulate, like the one that you have here, this is a good particulate smear. This is pretty fat rich. Here you have scant particles. So particles, bone marrow particles are very important because the particles will give cellular trails which are examined. And here what you find, this is very richly particulate but not so well spread. So it is very common in such situations when the bone marrow is very, very cellular, hypercellular. You may get something like this. Too much of particles is also not good. So you will have the aspirate which are like this, which will be good for examination. So this is the ideal bone marrow aspirate smears. So this is one particle, and you can see that around the particle you have these cellular trails which are to be examined. So this will give you roughly at low power, because that is the power at which you will examine it first. So it will give you a impression of the cellularity and will show you the megakaryocytes all around, will show you the possible cluster of abnormal cells and the presence of macrophages. So you must first examine if you straight go to the high power, you are likely to miss out on many things. So it is better that you do it at low power, then you go to the next high power, and like that before reaching the oil you can have 4x, you can have 10x, you can have 20x, you can have 40x. And after that is 100x, which is at oil. So you must follow that particular chronology. Cellularity is very important. Cellularity, I have said that bone marrow aspirate.
As the time from the organizers is.
But time is over?
Yes, sir.
Oh.
Please.
Okay. So cellularity, you must remember that it is 100 minus age. So a 50-year-old individual will have 50% cellularity. That's the ballpark figure. But it always has a range, and this is what this graph shows. So hemodilution is a very important factor. Many times the bone marrow aspirates are hemodiluted, so it's not a good thing to examine. So you must avoid hemodilution, but sometimes you can't avoid it. You do get hemodilution, but then you have to wait for the biopsy to be examined. Many times the aspiration is difficult, many times the multiple draws you do, but every time there is a dry tap or hemodilution. So two things will happen, a blood tap or a dry tap. So both are not good. Megakaryocytes many times are not representative in the aspirate because they are quite large, and they are not aspirated in the needle. So you must look at them in the biopsy. So this is the megakaryocytic maturation. If you follow different megakaryocytes in the aspirate, you can know which are young, immature megakaryocytes and which are mature megakaryocytes depending on the nucleus. And the nucleus of a megakaryocyte is polypoidal because right from 4N to 128N you can have the chromosomes in a megakaryocyte, so you must appropriately look at it. This is the megakaryocytic maturation. This is the immature young megakaryocyte. This is a mature megakaryocyte. So megakaryocytic assessment, I have already told you, number and morphology has to be assessed, and there has to be a subjective feeling of the numbers when you look at the aspirate. Yes, I will just take another 5 minutes at the max. So lesser number of megakaryocytes are usually seen in the aspirate and more megakaryocytes are seen in the biopsy. So you must correlate. So you have staghorn megakaryocytes in essential thrombocythemia like this. You have micro megakaryocytes or dwarf megakaryocytes in chronic myeloid leukemia. And if you have a patient of ITP and you have done a marrow aspirate, this is how it looks. Megakaryocytic thrombocytopenia because of megakaryocytic hypoplasia. In myelodysplastic syndrome, for which we assess the megakaryocytes, you will have large number of atypical megakaryocytes, right from micro megakaryocytes to monolobate megakaryocytes to hyperlobate megakaryocytes. So they are all features of dysplasia. Histiocytic cells, macrophages will abound in the marrow in infections, and in sometimes when you have patients of hemophagocytic lymphohistiocytosis, HLH, you will find that these cells are many and they will have ingested large number of hemopoietic cells, something like this. This is all macrophages which are the ingested hemopoietic cells. So you have cytopenia. So HLS is a very common cause of cytopenia, and you have to do other stains. You have to stain it for perforin, you have to stain it for Granheim just for confirmation of HLH, and you have a diagnostic guideline for hemophagocytic lymphohistiocytosis. You have to do triglycerides, you have to do ferritin, and you have to do coagulation profiles and other things. C-blue histiocytosis is very common in hyperproliferative marrows, something like this. So it is not pathognomonic of anything, but you will find it in certain marrows. Similarly, you have storage cells where it will appear hypocellular, but all that you will find is round cells with small nuclei and some material which will be inside the cytoplasm. Particularly you can see it in Niemann-Pick's disease and in Gaucher's. So metastatic deposits are also seen in the marrow. You can mostly see it from prostate and breast and lung. When you have aspirates like this, sometimes in patients of cytopenia where there is involvement of small round cell tumors, you can have deposits of neuroblastoma like this. Already Dr. Basu has already shown you a rosette of neuroblastoma. You can have these cells, osteoclast and osteoblast, in large numbers in pediatric marrows, and sometimes in myelomas you can have large number of osteoclasts. So high power is very important, where you will do the myelogram. Myelogram will give you the myeloid erythroid ratio, and also it will give you the relative disposition of all the maturing forms. So it is important that you must look for a high ME ratio and low ME ratio, which can be because of the increase or decrease of either of them. And when you see a particle, you are looking at the trail of the particle, you can find cells which are arranged properly, and you will do the myelogram from this area, and you will do the myelogram also from this area, and will give a 200 to 500 cell differential. If it is hypercellular, 200. If it is normal cellular to hypercellular, 500 cells must be counted in a counter. So this is important. So this is the cellular trail. You see, this is the particle, and this is the area you have to concentrate for all your morphological study, and this is where you will do your myelogram. So normal bone marrow with trilineage hematopoiesis will look like this. This is in high power. Erythropoiesis can be looked at, where you can have megaloblasts like this, or you can have normoblastic maturation. So here you find that large number of cells which are quite large, and this erythropoietic features in MDS can be seen by the dysmorphology of the erythroids. You can have nuclear budding, intranuclear bridges, multinuclearity. Megaloblastoid change itself is a feature of dysplastic dyspoiesis. Karyorrhexis could be there, and cytoplasmic changes like pass positive, block positive granules, as well as you can have ring sideroblast. So this is how they look.
Sir, kindly summarize.
Yes, yes.
We are running.
So granulopoiesis, this is the way how granulocytes mature. Common abnormalities are seen that you can have increased or decreased granules in MDS as well as in myeloproliferative neoplasm. You can have maturation arrest in APML. You have only promyelocytes. Dysgranulopoiesis is seen not only in MDS but also in many autoimmune disorders. So you have to know the history properly and then accordingly interpret. Acute leukemia, of course, will look at you. So diagnosis should not be difficult. You see that these are the ring neutrophils in marrow, which are all dysplastic changes in the granulocytes. Lymphocytes are varying, present in varying numbers, right from 20 to 40% based on the age of the patient. Plasma cells are present up to 3% in the marrow myelograms, and they are important when you are thinking or suspecting a case of myeloma. So here you see increased plasma cells in a case of plasma cell neoplasm. Special stains are very important in the aspirates. You can do not only myeloperoxidase, Sudan black B, iron stain, and you can do PAS. So this is special stain for myeloperoxidase. Bone marrow iron store is very important. In iron deficiency, you can grade them from 0 to 6. This is how it looks. A ring sideroblast, you can see that the more than 2/3 of the circumference of the nucleus is covered by these granules. These are special stains done on the biopsy: reticulin, Congo red, Jedin stain, PAS, as well as you can have large number of immunohistochemical stains based on the bone marrow biopsy morphology. This is a completely hypoplastic bone marrow. So you have to estimate the cellularity based on the age. So this is a leukemic marrow where the cells are completely occupied. So I will myelodysplastic syndrome where you have del 5q. We have done a series 61 stain. Marrow infiltration. This is a.
Sir, as we are shortage of time. So
okay, so this one I would like to just show you. This is intrasinusoidal infiltrate in a gamma delta lymphoma. You can find that inside the blood vessels you have these infiltrating lymphocytes. This is metastatic tumor in adenocarcinoma. So the take-home message of this particular presentation is that the bone marrow aspiration and biopsy is integral to the investigation of hematological disorders, just not malignancy. Both aspiration and biopsy should be evaluated simultaneously. Peripheral blood examination is mandatory to be examined along with the bone marrow aspirate and biopsy, and it has to be correlated with the detailed clinical history. With that, this is the template of the report that normally is given, which has all the parameters mentioned. You just have to write, tick, and finally sign. So these are references I always show. Recently you had the Kargil Divas. I always show this slide. So last week was Kargil Divas. This is in Ladakh. Every time I show this. And you see how happy these people are even at that temperature and height. So I have two announcements. We are hosting the annual conference of the Cytometry Society, which is the flow cytometry annual conference in the month of October, November. Please look at the website and all those who are interested in flow cytometry should attend it. And next is we are also hosting the annual conference of the Molecular Pathology Conference, Molecular Pathology Society in the month of February. So please do attend. Thank you very much. I know I have overshot the time, but in case you have any pressing queries, I would love to answer them. So bone marrow is very, very important for the diagnosis of hematological disorders. So it is just like peripheral smear, it is equally important.
Thank you, sir. We will discuss if any question in the tea time, and we will have to close the session.
Good afternoon, everyone. Thank you, sir, for a very visually rich and comprehensive presentation. Can we please have you on the dais for a photography session? Meanwhile, we are not breaking for tea anymore due to paucity of time, and we'll keep ourselves on schedule. All the queries can be posted on RAKTAVIGYAN@gmail.com, and you can tag the speaker that you have a query for. Quickly moving forward to the next topic, laboratory approach to chronic myeloproliferative neoplasms. I would like to invite the chairpersons on the dais. Dr. Binita Sinha ma'am, HOD Department of Pathology, Paras HMRI Hospital, Patna. Dr. Tarun Kumar sir, Associate Professor, Department of Pathology, AIIMS, Patna. Dr. Dipti Panwar ma'am, Senior Consultant Pathologist, Narayana Cancer Center, Patna, and Dr. Shuchi Smita ma'am, Associate Professor, Department of Hematopathology, IGIMS, Patna. Can we please have you on the dais and introduce the speaker? Thank you.
Good morning, everyone. I would like to invite Dr. Astha Gupta ma'am. She is a senior consultant at Department of Laboratory Sciences at Salve Sanar International Hospital, Delhi. She has done her DM hematopathology from the AIIMS, New Delhi, and she was previously associated with TMH Mumbai, Sir Gangaram Hospital, and other institute. She will give her she will deliver this topic on the lab approach of CMPN. Ma'am.
Yeah. Thank you, chairpersons, for the kind introduction. And good afternoon. Is it good afternoon? Yes, good afternoon, everyone. At the outset, I'd like to thank Dr. Avinash sir and the organizing team for giving me this opportunity to share our experience on approach to myeloproliferative neoplasm. I am currently working at Fortis Hospital, heading the team of hematopathology here. And the objective in another 20 minutes is to go through how we have to do the lab approach for myeloproliferative neoplasm and what is the role of NGS in the current diagnosis of myeloproliferative neoplasm. So taking from the take-home message from Deepak sir's lecture that bone marrow aspirate and biopsy should be done together, and myeloproliferative neoplasms is one of those malignancies which you cannot diagnose without the bone marrow biopsy. And the second thing is, it is no more chronic myeloproliferative neoplasm. The WHO labels it as myeloproliferative neoplasm because this term itself tells that it is a chronic condition. So when to suspect a myeloproliferative neoplasm? Most commonly in clinical practice, the CBC report which it comes to the clinician by which the patient brings is the reason that MPN is being suspected, and either you find a elevated hemoglobin or TLC or platelet, and also in conditions with pancytopenia, MPN is being suspected. So if you see a CBC where the TLC is like 1,43,000 with near normal hemoglobin platelet, there is an increase in TLC, MPN will be suspected in this case. Definitely leukemias and other clinical conditions are also there, but if it is associated with a clinical finding of massive splenomegaly, yes, MPN is the first diagnosis that comes to mind. If there is a CBC with a platelet count of around 12 lakhs, MPN is the diagnosis that comes to mind. If there is a high hemoglobin of 19 with a high hematocrit, then MPN is the diagnosis that comes to mind. And all these features, again, a bone marrow aspirate biopsy form should never be without a history. A proper clinical history is very much required, because as I said that in pancytopenia, MPN becomes a suspicion, but pancytopenia can happen in acute leukemias, it can happen in MDS. So a correct and a proper detailed clinical history is important. And in MPNs, the common clinical features that are seen are fatigue, the night sweats, the B symptoms, splenomegaly, which goes to a degree of massive splenomegaly. Pruritus is usually seen in polycythemia vera, and thrombotic and hemorrhagic events are also seen. So a good clinical history will help us not only to diagnose MPN, but also it will help us to subtype the MPNs. So when we begin the workup of myeloproliferative neoplasm, our job in the lab is not only to diagnose myeloproliferative neoplasms, but also to exclude the secondary causes of MPNs. And after we have diagnosed the MPNs, we need to subtype the various types of MPNs, because the treatment is different and also the prognosis is different. So in current WHO, so the topic was MPN diagnosis in 2025. So the WHO, current WHO 2022 shows two major additions or changes in the classification of MPN. One is chronic eosinophilic leukemia, NOS has been changed to CEL, and there is a reason for that. And secondly, JMML has been added to MPN and removed from MDS MPN, because it was recognized that the dysplasia is not a common feature of JMML. That's why it has been now identified as a myeloproliferative neoplasm. And BCR-ABL has been removed from the terminology of CML, because we know that BCR-ABL is sine qua non for diagnosis of CML. So when we begin the investigation of MPN, the first thing that we do is the CBC and the peripheral smear examination. And as in the previous lecture, sir has demonstrated the importance of a good peripheral smear examination. Many a times, the molecular workup begins immediately after a peripheral smear examination, which says that it is CML and BCR-ABL is being done. So let me begin with this case where the TLC was 1,43,000 in a 40-year-old male who had hyperleukocytosis with splenomegaly, and the peripheral smear shows leukocytosis with left shift myelocyte metamyelocytes and increase in the basophils. A suspicion of CML not suspicion, the diagnosis of CML was given, and the clinician proceeded with the BCR-ABL testing, and this is a gel-based RT-PCR which is done for BCR-ABL, and it is always good to have a BCR-ABL testing which includes major, minor, and also the micro transcripts of BCR-ABL. So this is a prototype, and this is our patient. A positive and negative control will always be put in RT-PCR, and this is the band which is corresponding to B3A3, which is a P210 transcript for BCR-ABL, and the diagnosis of CML was made in this case. Now, often query which we get from the clinician is whether we should do quantitative BCR-ABL or qualitative BCR-ABL at the time of diagnosis. It doesn't matter which one you do. Quantitative is more sensitive, but the more important thing is that it should not only cover the major transcripts, but it should also cover the minor transcripts, and it will be good if it also covers the micro transcripts. So whichever methodology you use, but it should have a wide coverage, because at the time of diagnosis, our aim is to identify or detect BCR-ABL, not to actually quantitate it. However, the quantitative PCRs, they are becoming, because of their sensitivity, they are becoming more prevalent. And also, they have now incorporated many rare transcripts also for CML, and therefore they can be chosen. So this was a diagnosis of CML, and according to WHO, the CML diagnosis requires leukocytosis with identification of BCR-ABL by any methodology, either it is karyotyping, FISH, or molecular based. it is desirable to do a bone marrow in CML because at the time of diagnosis you want to demonstrate the phase of CML, you want to see what is the baseline fibrosis in CML, and also you want to see the additional chromosomal abnormalities. So if BCR-ABL is negative and a patient has B symptoms or massive splenomegaly, if there is pancytopenia, if there is leukoorthoblastic picture, these are the conditions where we straight away go ahead with the bone marrow examination followed by the karyotyping and the molecular studies. This is another case where a 50-year-old gentleman, he had a platelet count of 12 lakhs and a smear shows normocytic normochromic anemia with increase in platelets, and there is anisocytosis noted in the platelets showing large, medium size, small and all kinds of platelets in the peripheral smear. So in an approach to thrombocytosis, a laboratory must not always think that it is straight away MPN. You also have to exclude the reactive causes of thrombocytosis. A comprehensive clinical history including the drug history, if there is any history of splenectomy or if there is any history of underlying inflammatory conditions, it is very important to get this history to look for the secondary causes of thrombocytosis. And a peripheral smear examination is important where we confirm the thrombocytosis, as there can be a mimicker of microcytic hypochromic red cells or schistocytes. So you have to confirm thrombocytosis. And not only the platelets, you have to look at the RBCs and the TLC also in this case. If there is a microcytic hypochromic anemia and iron studies show iron deficiency anemia, it can be a secondary thrombocytosis because of iron deficiency anemia, right? So in that case, a CBC should be done after correction of iron deficiency anemia. You have to look for Howell-Jolly bodies and NRBCs, which will indicate splenectomy. TLC to look for reactive neutrophils, or if a TLC peripheral smear shows left shift, then even CML can present as isolated thrombocytosis upfront. So if nothing is there, the bone marrow is being done, and the bone marrow biopsy shows characteristic increase in megakaryocytes with their characteristic features, which I'll show, and a molecular study. So this is a picture from WHO where a bone marrow aspirate shows an increase in the megakaryocytes and a typical staghorn megakaryocyte because of this high hyperlobulated megakaryocyte. A bone marrow biopsy will be normocellular in ET. It will show all the components, and it will show an increase in megakaryocytes with clustering and showing these megakaryocytes with staghorn nuclei. So a diagnosis of ET was made. And in the WHO criteria, the one thing that they have changed is that there is no more persistence of high platelet count. They have removed any duration for which a persistent of platelet count has to be seen. However, the bone marrow picture, along with exclusion of other MPNs and with the demonstration of JAK2 CALR MPL mutation, is required for the diagnosis of ET. A minor criteria is presence of clonal markers or exclusion of reactive thrombocytosis. So WHO, I think, understands that every center may not have a facility of extensive molecular workup. That is why I think they have added that exclusion of reactive thrombocytosis with persistent thrombocytosis and a marrow picture can lead to a diagnosis of ET. So WHO has given the diagnostic criteria for all the MPNs in two categories of desirable and essential criterias, and in every disease, the bone marrow morphology remains the paradigm for the diagnosis, except for CML, where it is a desirable criteria. So the morphology is here to stay, and we need to understand how bone marrow looks in each type of MPN. So I have just brought some typical cases for polycythemia vera. High hemoglobin peripheral smear shows the red cell erythrocytosis, and a particle on the bone marrow aspirate is an indicator that it may be a hypercellular marrow. However, we must always remember that the cellularity must be commented only on bone marrow biopsy. In polycythemia vera, all the three lineages will increase, and it will lead to, so there will be increase in all the three lineages, and the megakaryocytes will show pleomorphism, which is more evident from bone marrow biopsy. This is a hypercellular marrow with increase in all myeloid, erythroid and megakaryocytic components. The megakaryocytes show pleomorphism. This is a prefibrotic PMF where the aspirate was diluted, hypercellular marrow with the characteristic clustering of the megakaryocytes showing atypia, hyperchromasia, and in prefibrotic MF, the reticulin stain is usually grade 0 to 1. On the contrary, the fibrotic kind of PMF shows streaming of cells with an increase in fibrosis that can be seen on reticulin, and a marked increase in megakaryocytes with ATP and polymorphism and hyperchromasia is a feature of fibrotic myelofibrosis. So this is just a table to compare the 4 common types of MPNs, that is ET, CML, PV and myelofibrosis. It is a conglomeration of all the clinical and the aspirate, CBC and biopsy features that help us to make the diagnosis. For example, ET is many times asymptomatic. CML presents very commonly with the splenomegaly. Thrombosis is a feature of ET or PV. Hemoglobin is normal in ET and CML but increased in PV, and anemia is a very common feature of myelofibrosis. In bone marrow, we see that ME ratio will be normal in ET. So this is a very important feature, whereas the ME ratio will be increased in CML, it will be normal or decreased in PV, and it will be increased in MF. Just for the pathologist over here, I want to highlight that whenever you see the aspirate, in CML also ME ratio will be high, and in MF also ME ratio will be high. But in CML, the erythroid cells are adequate in number. It is just a relative reduction in erythroid cells, and you can see the erythroid cells in the background. However, in MF, there is a true reduction in erythroid cells and a very high proliferation of myeloid cells, and that is why ME ratio is very high. And because of true reduction of erythroid cells, the hemoglobin in myelofibrosis is usually low. Myelofibrosis with normal hemoglobin is someone should be beware in making the diagnosis of myelofibrosis with a normal hemoglobin. And megakaryopoiesis is very well defined in all the 4 entities, and more you see the normals, you will be able to identify the abnormals. Coming to the other categories of myeloproliferative neoplasms, chronic eosinophilic leukemia is defined by presence of peripheral blood eosinophilia of more than 1500 per microliter. Evidence of clonality is very important, and abnormal bone marrow morphology, where you see eosinophils with abnormal granulation or hypogranularity, which will help us to differentiate them from the reactive causes of eosinophilia. Eosinophilia is one disease where an extensive laboratory and clinical workup is required, because it does not say only eosinophilia. We have to identify the underlying causes. Even AML can have eosinophilia, BALL can have eosinophilia, other myeloid neoplasms can have eosinophilia, CML can have eosinophilia. The reactive causes, there is a whole battery of causes, reactive causes for eosinophilia. So it is very important to do an extensive workup in cases of eosinophilia, and chronic eosinophilic leukemia will be made when others have been excluded and clonality has been demonstrated. But if you cannot demonstrate the clonality, or if there is no clonality, then hypereosinophilia syndrome is the diagnosis. So you get peripheral blood eosinophilia with evidence of organ damage, but you cannot demonstrate any other underlying cause. There is no clonality. It becomes hypereosinophilic syndrome. In chronic neutrophilic leukemia, peripheral smear examination, I'll just take 2 minutes more. Peripheral smear examination is very important, because the left shift percentage is very important. If it is less than 10%, you are going towards CNL. Dysgranulopoiesis is very important. A pathologist should always make a proper count or the DLC of peripheral smear to see what is the percentage of left shift, to see whether there is any dysgranulopoiesis or not. And an important mutation that has come up for CNL is CSF3R mutation. JMML has come up in MPNs, and all these 5 things are very important. Again, a lab's role is so important in making the diagnosis of MPN, because you have to do the countings, you have to look for dysplasia, you have to see whether the blasts are increased or not. So just one question which everyone again is today in today's world is asking, whether you want to do upfront PCR or NGS. Since the WHO says that if you don't get JAK2, CALR or MPL, you have to demonstrate the presence of clonal markers. These clonal markers can be identified by NGS. So if you have NGS, because the cost of NGS is coming down and even the rapidity, the TAT is coming down, if you have the availability or the facility for NGS, upfront NGS is the key to move forward, because you are not only getting the clonal markers, you are able to make the diagnosis, you are able to prognosticate your patients, you are able to get the VAF, you are also getting an information on the risk of transformation, and in CML the tyrosine kinase domain mutation is an important thing that can be identified by NGS. CHIP mutation, when you get on NGS, there should be a caution and you should look at the VAF and the whole picture before labeling it as MPN. So to summarize, while molecular diagnostics have enhanced our understanding and management of MPNs, a traditional morphological assessment, it remains indispensable as of now. The synergy of all, the clinical evaluation, the lab test, advanced molecular techniques, they are all important for a robust framework for diagnosing and managing myeloproliferative neoplasms. These are my references. Thank you for your kind attention. And this is our team at Fortis Hospital, where we get the opportunity to diagnose all these cases. Thank you.
Thank you, ma'am, for such a informative and lucid talk. Such a nice topic, because there are many changes in Hem5. Thanks a lot, ma'am.
I have a query that no doubt in the last 20-25 years we have seen so much evolution in the lab diagnosis of CMPNs. Do you receive requests from clinicians, or do you advocate testing of first degree relatives in a case of CMPN?
So no, we don't advocate the testing of relatives and MPNs in today's practice. We
Even
don't
in first degree
it.
relatives?
No, we don't recommend.
Okay, thank you so much.
Thank you.
With this, we close the session. Thank you so much.
Thank you so much, ma'am, for such an extensive, covering up such an extensive topic in a very short span. It indeed was very helpful for us budding pathologists. I would request the chairperson to join the speaker for a photograph. Thank you once again. So now we had begun the day with peripheral smear, bone marrow and laboratory approach. Now I think it's time for a case-based approach. So to steer up the session, I would request the esteemed panel of chairperson to join us on the dais for the session titled as Case-Based Approach to Pediatric Anemia. For chairing this session, I extend my warm welcome to Dr. Alka Singh Ma'am, Medical Superintendent, Professor and ex-HOD, Department of Pediatrics, NMCH, Patna. Following, I request Dr. Reena Sinha Ma'am, Associate Professor, Department of Pathology, NMCH, Patna, to join us on the dais, ma'am. I request Dr. Varun Kumar Sir, Senior Consultant Pediatrician, Patna, to join us on the dais as well, sir. I request the chairperson to introduce the speaker.
Good afternoon. So I'm sure this is going to be a very interesting session. Case-based approach to pediatric anemia, and the speaker is Dr. Sazia Gulshan. She is DM in clinical hematology from NRS Medical College and Hospital, Kolkata. And she has worked in various hospitals in Kolkata like Peerless, Fortis, AIIR and others. So over to you for this case-based approach.
Thank you, ma'am, for the kind introduction. At the outset, I'd like to thank Dr. Avinash sir for this opportunity and be a part of this wonderful session. So I'll be talking about how to approach anemia in children. And as we know, the hemoglobin concentration reduction in its, or the reduction in the RBC volume below the normal for the particular age, gender and ethnicity, and also on the altitude of living is defined as anemia. The WHO cutoffs for children from the 6 to 23 months age group has been modified to less than 10.5, with defining a severity of less than 7. Children of the 12 to 14 years age is the severe anemia is defined as less than 8, and less than 11.11 to 11.9 is your mild anemia. So, what does the Indian data say on normal hemoglobin? We have seen in comparison to WHO norms, the Indian data, they have the age matched hemoglobin levels are almost low by 1 to 2 grams. And the difference is most pronounced in the young children of 1 to 2 years age group, and also in the girls who are just above 10 years, maybe at puberty menorrhagia having. The global prevalence reveals a high incidence of 39.8% of, according to 2019 data, with an equivalent amounting to almost 269 million children. And it's highest in the under 5 age group, highest in the African region. However, India does not lag far behind, of almost 60%. And this is West Bengal data, where you have NFHS, according to NFHS data, you have around 69% in the under 5 age group. So how does the hemoglobin vary from birth till your throughout childhood? We see at birth the hemoglobin is almost around 18 to 19 in a polycythemic, the newborn, which gradually settles down over the next 6 weeks to 2 months, and then it finally attains an adult day about in the female from 12 to 18 years, you have the female around 11.4 to 14.7, and in the male you have 12.4 to 16.4 grams per DL. So what are the main keys that we need to reach a diagnosis of anemia? First and foremost, of course, we have the clinical assessment, then the detailed history, a thorough physical examination, and as has been already demonstrated by previous speakers, we need a complete blood count with a very important examination of the peripheral blood smear. Retic followed with a detailed RBC morphology, and if you define a pattern, if you can pick up a pattern, and then you proceed accordingly. Do children have some other pointers in comparison to adults? Yes, they will present with growth retardation, exercise intolerance, some behavioral changes. They may be irritable, just restless, they have breath holding spells at times, and also temper tantrums, which we may take it to be normal in that age group. These are the various that we'll talk about. So we'll begin our case-based approach. The first case is that of a 2-year-old boy who presented with complaints of pallor. He was noticed by mother for last 6 months. He also had craving for some soil, wall plasters, and occasional passage of worms with stool. We see on examination, we see nail changes, koilonychia, this pallor, moderate pallor, no icterus, slight lower age and height and age, and the systemic examination was normal. This is the peripheral smear. We see severe anisocytosis, microcytic hyperchromic RBCs. The hemoglobin was 6.4, RBC count 2.1, retic low, and WBC platelets are in the slightly higher range, 5.4. And so it was diagnosed as hyperproliferative anemia, severe microcytic hyperchromic anemia. The iron studies were sent for. It was diagnosed as iron deficiency. So this I've already talked about. We see on the peripheral smear microcytic anemia, red cells, microcytic hyperchromic with an enlarged central pallor, a great deal of anisopoikilocytosis, and of course if the ferritin is low, it is diagnostic coffee. Some people, some physicians will go ahead without doing iron studies, and if there is a positive response to the iron therapy, that will reassure your diagnosis of IDA. So these children, the sense of well-being begins at almost as early as 24 hours, followed by reticulocytosis at 72 hours, and at the end of a week there should be a hematocrit rise, and the rate of increase by 1% per day is taken as adequate, and if you see the rise of hemoglobin is less than a gram after 4 weeks, then the bells should start ringing. So this child was put on oral iron, and after 3 months there was persistent pallor. The hemoglobin was 7.8. So what are the things, are we missing something? Is the oral iron not responding? So these are some of the causes. First and foremost is the poor compliance, whether the patient is taking adequate dose, whether something else underlying that we are missing, the chronic blood loss is continuing. So this child, he tested positive for TTGA and was started on anti-TTGA antibody and was started on a gluten-free diet when he started improving. Now the mother of the same child, she got her elder son tested, who has only had mild pallor and no other clinical symptoms such, and his hemoglobin was around 9.6. RBC count, as you see, was slightly on the higher side, microcytic hyperchromic, and the rest of the parameters were normal. So what can be the next possibility? What will be the evaluation? So for our residents, the first and foremost, when you see an anemia, you see whether it is microcytic, MCV is normal, low, or increased. And then you do a reticulocyte count. If the retic is decreased, then you have iron deficiency, thalassemia trait, lead poisoning, and sideroblastic. And among the increased retics, you can have thalassemia, unstable hemoglobins, and others. So differentiating between iron deficiency and thalassemia trait, you have the thumb rule, the RBC count will be slightly higher. We do a rough count of dividing the hemoglobin by 3, and if the answer matches with the RBC count, it is more likely to be iron deficiency, and if it's slightly on the higher side, it is likely to be iron thalassemia trait. RDW much increased, and the ferritin will be low in iron deficiency, and thalassemia, it will not be so. So this was HPLC was done, and this the H2 was high, HbA2, and it was a beta thalassemia trait. The next case of 13-month-old child who presented with pallor for over 4 to 6 weeks. The mother complained he was not playing well, not feeding well. On examination, severe pallor with icterus and tachycardia. There was mild malar prominence, and there was hepatosplenomegaly. So this was a case of severe anemia with organomegaly, and what could be the possibilities? It can be a thalassemia syndrome, any storage disorders, a torch, even an infantile leukemia or severe hemolytic anemia. So he was evaluated and hemoglobin was very low, the count was high, and there was plenty of NRBCs on the peripheral smear, many target cells, however there were no atypical cells. So if you have a lot of our NRBCs, you have to correct the TLC, and then the TLC came out to be normal. The iron was high. So 1 unit he received, 1 unit of PRBC. What next? This we know already. So if in a case of severe anemia with hepatosplenomegaly, if there is bleeding, you can think of leukemia, storage, HLH, torch. If there are any other pointers like developmental delay or a microcephaly, in a torch infections, jaundice, we point towards hemolytic. And this child was diagnosed as thalassemia. The mother and the father's HPLC was also done, and we see that the child was E beta thalassemia, the father was HBE trait, and the mother was beta thalassemia trait. E beta thalassemia can present is a wide range from as TDT transfusion dependent to non-transfusion dependent with anemia of various severity. Some may not require regular transfusions, but will need them during the stress, acute stress conditions. This was a 1-year-old who was exclusively breastfed, a girl child, presenting with progressive pallor for 6 weeks and delayed milestones. There was acral hyperpigmentation, as you see, generalized hypotonia, dry lusterless look. Peripheral smear, you see there is hypersegmented neutrophils, macroovalocytes. There is pancytopenia, MCV is high. I'm sorry, this is not working. So, the MCV, when you see the MCV is high, you check whether retic is low or high. You rule out the the nutritional deficiencies, see the peripheral macroevaluocytes and hypersegmented neutrophils, and then go about for the diagnosis with the RBC folate is more diagnostic. Coming for the next case, this was a 7-year-old boy who presented with intermittent jaundice, 7 years, and there was a history of severe neonatal jaundice requiring exchange transfusion. Now he had mild splenomegaly. So this was a pointing towards a chronic extravascular hemolysis. The retic, corrected retic was 10%, and the MCHC, as you see, was high, and there were plenty of spherocytes on the peripheral smear. So if whether dealing with a transfusion, thalassemia or hereditary spherocytosis, the family history will be suggestive, spherocytes on peripheral smear, as you see. And the father was examined, and he had mild spleen and a mild icterus, and he had plenty of spherocytes on the peripheral smear. Osmotic fragility done was showed increased osmotic fragility. So this was a case of hereditary spherocytosis. Coming to the next case, this was an 11-year-old boy with a history of preterm birth, mild jaundice. So he presented the ER with acute passage of cola-colored urine, history of upper URTI, a week back, and he had mild jaundice, severe pallor, slightly palpable spleen. The blood bank was contacted for transfusion, and they reported back they were having problems with matching. So the hemoglobin was very low, retic high, MCV on the higher side, and the peripheral smear showed normocytic normochromic anemia with plenty of spherocytes and NRBCs, and there were plenty of, the LDH was very high. So this was a case of acute intravascular hemolysis. G6PD usually done during these cases can out to be normal during an acute hemolysis. A DAT was sent and it tested out to be positive. The next case is that of a baby who 32 weeks, was born at 32 weeks, 1.4 kgs, male birth, poor growth, and since birth the fall in hematocrit. However, there were no other pointers other than pallor. So this was a hyperproliferative anemia in a preterm neonate. So how do you approach that? You see whether the retic is low or increased. A low retic may indicate an anemia of prematurity. If the retic is high, then you go for DCT. If the DCT is positive, you think of ABO incompatibility, and the retic is negative, then you check for other peripheral smear, whether there's spherocytes, ovalocytes, and then so anemia of, this was a case of anemia of prematurity, so it is a diagnosis of exclusion. It is an accentuated form of the physiological anemia of infancy due to inadequate iron stores in the preterm baby, and oral A can be given. So this 9-year-old girl who presented with anemia for the last 4 months, she has had 7 transfusions till date with intermittent gum bleeding. On examination, she had pallor, petechiae, thumb abnormalities, severe cafeolate spot, and a short stature. So pancytopenia without an organomegaly. She had low TLC, your lymphocytes were on the higher side, a high MCV, and normocytic to macrocytic RBCs, and platelets were grossly reduced. So as we have already know, we need to rule out your aplastic anemia, whether it's acquired, inherited. You need to go for a bone marrow studies and rule other causes of pancytopenia, be it nutritional, autoimmunity, and any systemic infection if it is there. So this is how we approach a case where there is not isolated anemia and there is more than one cell line involved. So first you determine the anemia, whether the child has any other cell lines involved. Yes, pancytopenia, it can be leukemia, myelosuppressive drugs, aplastic, hyperstrenism or nutritional. I'll just take 2 more minutes, ma'am. And anemia with low platelets, it can point to a microangiopathic hemolytic anemia. So again, a review of the slide which will point you in the right direction. This 12-year-old boy who presented with severe anemia and body ache and hepatosplenomegaly, The blood smear showed grossly reduced platelets, anemia, a high WBC count, and blast on peripheral smear. So these, of course, are the differentials that you have in mind. And so when you work up a case of bicytopenia or pancytopenia with organomegaly, you do a bone marrow aspiration, a blast, you send for IPT, cytogenetics. This boy turned out to be a B cell acute lymphoblastic leukemia. This is the last case, and this girl, she presented with bleeding PV, and for the last 1 week she had severe pallor, she had an axillary lymphadenopathy, spleen was just palpable, all the parameters were sent for. The peripheral smear showed a few atypical cells, and there was severe thrombocytopenia. So we transfused her and then did a bone marrow and sent for IPT. The bone marrow showed abnormal promyelocytes. The RT-PCR for P. rara was sent for, and she came back as positive. So the acute promyelocytic leukemia, as was already demonstrated, is a medical emergency, and she was started on ATRA and given supportive medications. This we have already covered, how to approach, just and whether it's standalone anemia, whether it's biopancytopenia, whether it's retic, low, high, whether presence of organomegaly or not. This we have already done. So to summarize, the childhood anemia is a common pediatric health problem with a sizable global burden. Anemia per se is not a disease, but it is a very important sign of an underlying disease. And there are very important clues or a pattern which either in the history, in the examination, which helps to narrow down the differentials. And very, very important, a careful examination of the CBC, RBC indices, the retic, and the peripheral smear will help you which way to evaluate. And the peripheral smear is, as we all know, it's a window to the bone marrow and is the single most important test that we need to do. And of course, bone marrows may be needed in few selective unsolved conditions. So thank you so much.
Thank you, Dr. Sazia, for your beautiful presentation. You have tried to cover all the causes of anemia in this short time. So that was remarkable. And we should also not forget some physiological causes like physiological anemia of infancy and physiological anemia of prematurity that you talked about, that happens earlier, and for which routine iron supplementation is given to premature babies up to the age of 1 year. And also there is another condition called transient erythroblastopenia of childhood. Exactly. So for these you don't need treatment, not aggressive treatment. Of course, if the child is very anemic, you may need blood transfusions. So you have to be aware of that. Anybody has any questions, they may ask.
Thank you.
You are getting hemoglobin of 18.6 and you are getting macrocytes in the blood picture. So as a pathologist, how you will sign out?
Usually at a newborn, the first week, first 2 weeks. Yes, that is expected. That is expected for that age group. If it is persistent, then you further need to explore, but not right at birth if the hemoglobin is high and the macrocytosis is there.
Macrocytes are there and you are getting hemoglobin of 16.8. So would you write that as macrocytic RBC picture, or will you write as normocytic normochromic RBC picture? What should you write?
You have to see whether those are macrocytes or there are polychromatic, their reticulocyte count is high in that age group, isn't it? So whether there are polychromatic macrocytes. So that has to be differentiated. You just mention peripheral smear, but otherwise, I think it's okay.
Sometimes, but it becomes too difficult to sign
I know.
How you will write? You can't write anemia. You can't write normochromic RBC picture. You are getting macrocytes, and most of the neonates during the initial period are having a physiological jaundice too. So it becomes tough to answer sometimes in the practical aspect. How you will sign out, whether it is anemia, whether it is macrocytic.
That is not anemia for that age group. It is not. It is
should-
not anemia.
so
You
should
have to
you
mention
write-
the macrocytes that you have seen.
Should you write macrocytic RBC picture or normocytic normochromic RBC picture?
You
It
just
is
have to
open
write
house. Anybody
presence of-
can answer.
Yes, sir is the best person to answer. Please give a mic to sir.
If it is a newborn and you're getting a hemoglobin of 18 with MCV of 100 plus, that is normal. That is normal for age. So when we report it out that way, that smear shows macrocytic, in brackets normal for age, that's it. 18.6 for a newborn, 1 to 5 days with MCV of more than 100 is absolutely normal for an age. 20 days old, 18 is difficult. Yes, it is normal up to 1 month of age. Yes, so if it is, yes. No, if you say normocytic, normochromic, you have to say for age. But the MCV is high, so it is macrocytosis, and that is normal for that
You have to
period
give the descriptive description that it is there. There is presence of
It is there
macrocytes,
and
but
that is
is
normal.
not a macrocytic anemia.
not
It's
a
normal
macrocytic
for the
anemia.
18.
Very true.
So we'll have to close this session because Dr.
Thank you.
Sazia has another session upstairs, I think. Thank you very much for your lovely presentation.
Can I have all the chairpersons and the speaker for photography? Thank you, ma'am. That was a very well-made presentation. Lot of flow charts and presented the topic with remarkable clarity. We'll move on to the next topic, which is update on mantle cell lymphoma management. And I'd like to invite the chairpersons on stage. Dr. Rajesh Singh sir, Professor-in-Chief, State Cancer State, IGIMS Patna. Dr. Alok Ranjan sir, Assistant Professor, Department of Medical Oncology, IGIMS Patna. Dr. Chinmay Biswal sir, Consultant, Department of Nuclear Medicine, Paras, Patna. And Dr. H.N. Tiwari sir, Consultant, Radiation Oncology, Paras, Patna. Kindly introduce the speaker on stage.
It's my pleasure to call on stage our next speaker, Dr. Kundan Mishra. Sir is DM in Hematology and currently he is the Professor of Medicine and HOD Clinical Hematology in BMT at Command Hospital, Lucknow. And sir will talk on the topic update on mantle cell lymphoma management. Over to you, sir.
Thank you, chairpersons. Good morning, everybody. At the outset, I'd like to thank Dr. Avinash, sir, for inviting me over here. It's a home turf for me, and I'd also like to congratulate all the organizers for this wonderful CME. It's going so very well. Well, my topic seems to be, I was just going through today's all the topics, and it seems to be out of syllabus, but anyway, I'll try to justify it in next 18 to 20 minutes, whatever time has been given to me. Coming back to the topic, just for your information, for basics, that mantle cell lymphoma is relatively a rare variety of non-Hodgkin lymphoma, constitutes around 6% of all NHL if you go for the Western data. And usually it is characterized by translocation 11-14 and usually presents in elderly male commonly. Elderly males are most commonly affected. Lots of extranodal involvement will be there, being lymphoma, not just lymph nodes, but there will be, if we talk about lymphoma, this will be one disease where maximum extranodal involvement will be there, any part of the body. And the presentation is very heterogeneous. Patient may be from asymptomatic to a very life-threatening condition kind of things. And mostly no matter what treatment you give, patient responds. It is true for most of the lymphoma, but the big thing in mantle cell is that it will make you mental. So the patient will start improving and anytime it will start deteriorating also. It may become absolutely all right, then again it will relapse. So no matter what you are treating with, the relapse is usually a rule. So be very careful while handling against a mantle cell lymphoma. Don't get too happy, don't get too sad. Just a line about pathogenesis. I basically, I am a clinician, so I'll go from clinical point of view. What I understand from this pathogenesis is that this is a that follicle You can see there is a germinal center in the middle, and the periphery is called mental cell, or mental zone. So that is the area from where this mental cell lymphoma originates. If I have to give basics to my students, say I believe that most of the people over here are non-oncologist kind of things, or students or general physician. So if I have to teach somebody like how to approach a case of mantle cell lymphoma, or for that matter non-Hodgkin's lymphoma, it will be something like this: that a patient will come to you with a mass, and you think that this is a lymphoma due to after due diligence, you have whatever clinical knowledge you have, you will put your level best, and you will think that this is nothing but lymphoma most likely. That will be the first DD in your case. So try to go for tissue. So you have to get tissue to confirm a case of lymphoma. So there is an issue whether FNAC or biopsy. So this is not an issue basically. There is a biopsy only. There is nothing like issue that whether you should go for FNAC or biopsy. You have to go for biopsy only. Issue will only come when you are unable to go for biopsy. If you cannot go for biopsy, you have to do something. You can go for FNAC. That is fair enough. Otherwise, always go for biopsy. It has n number of benefit. There is no comparison between FNAC and biopsy. Only case where I'll advocate you to think of FNAC is when you cannot go for biopsy. And biopsy has many benefits, like it is reproducible. You see, this is a malignancy. Once the patient gets it, patient may not, you as a physician also at times may not have full faith on your pathologist. Sometimes pathologist will give you a report, but will not himself or herself will be sure whether it is mantle cell lymphoma. Sometimes patient wants second opinion. If you have a good biopsy, it can be sent to for second opinion, and the entire journey of diagnosis can be revisited easily. So try to go for biopsy. There is no doubt at all about that. Then the second thing, or side by side, you also have to go for imaging when there is a mass over there and you're thinking lymphoma. So there is a little bit of doubt whether you should go for PET-CT or CCT. Well, if you have PET-CT easily available, cost is not an issue, and I'll go for PET-CT. That it is anytime better. But if there are cost constraints, availability constraints, many other things, you are in a government institutes where the appointment of PET is coming after 1 month and all, CCT at diagnosis is good enough for most of the cases. There is absolutely no doubt. So it is to a great extent it can be done. But yes, if given an option between these two, go for PET-CT, no harm in that. But a minority of patients of mantle cell lymphoma in particular will not present with mass, but they will present with cytopenias. And with your diligence, maybe on PBS or by any means, if you think that it is nothing but lymphoma, then one thing you must do is imagine. Imagine the body, look if there is a lymph node which is not clinically visible or which may not be clinically palpable, but there are areas in the body where lymph nodes can be there, and you can, or a mass can be there, which can be picked up on an imaging study. So go for that. Once you localize that, then go for FNAC or biopsy. Obviously biopsy, FNAC usually no, until unless you are compelled to do that. And here even cytopenia is there, you are not getting any mass and all, then that biopsy can be bone marrow biopsy also. And then comes the role of further evolution of that tissue, which is going to give you the diagnosis. Morphology is the supreme. This is what my understanding, teaching, learning, everything and practice is, that morphology is supreme in lymphoma. Morphology will give you the way that how to go about. If you have to go from say this lecture hall to suppose Miller High School, which is 200 meters away from this place, which is my alma mater, then if I put it in a Google, I'll reach easily, there's no problem. But suppose I go outside, I have no idea, I go towards Atal Path, then I go towards Marine Drive, maybe I'll reach, still I'll reach say Miller High School, but it will be too tortuous. So morphology is something in an experienced hand will give you lots of clue, and that will make sure that which direction you have to go, and the diagnosis will be much refined, much easier, much better. Well, once morphological things are there, then you have to confirm it by ISC or FCM. So this is not for pathologist or molecular pathologist. This is for a physician or a hematologist, clinical guy like me, that at least I will require these many things for me. If I am thinking about say mantle cell lymphoma, then on ISC I would definitely expect that CD523 should be there, SOX11 should be there, KI67 should be there. These reports I will request my pathologist to give me, because these are all not just having say diagnostic significance, but these are very important in deciding the prognosis of the patient. And when I am doing a clinical practice, then making a clear picture to the patient before I start therapy is very important, not just for private practice, but even in government setup. So few things will be required. Just if you have done bone marrow, then flow cytometry will be required. Then in present world, never to miss the molecular things. Molecular is the way, there are so many targeted therapies coming there, though there is as such not exactly a targeted therapy over here, but it will guide you the way you are going to treat, whether BTK is a must or not in your cases. In mantle cell lymphoma also can be decided based on the molecular. So at least 3 things in molecular I would definitely like to have: translocation 1114, which is pathognomic for mantle cell; TP53 sequencing, which has got perhaps maximum, I'll say that, implication while deciding the therapy or deciding the prognosis of the patient; and IGHB mutation, which is like TP53, is also a prognostic marker. Then some baseline test, you do all the CBC, biochemistry, TLS profile, liver function, kidney function, just to look for the patient's baseline functions. You also do the cardiac assessment. All the viral markers are important to be done. Blood sugar you must check in these patients, because you are going to treat these patients, any lymphoma for that matter, with lots of steroid. So baseline blood sugar should be there, otherwise you will be blamed that you are the one who has given the diabetes to the patient. If a young lady is there of childbearing age, irrespective of the history, must get UPT done. You should not commit mistake on that. If you, this is my experience, I'll tell to the physician or the trainees, you should not commit mistake on that. Must get UPT done, whether the history is there or not. Beta 2 microglobulin is another prognostic marker, we get it done, and in rare cases lumbar puncture is also required. Once we have got all these things done, then there is a time before treatment. These are relatively easier things to do: staging, IPI scoring, PS, and these are very important things. You must not miss it. This is what I am emphasizing. So staging is very simple, age-old Ann Arbor staging. All lymphoma we usually stage with Ann Arbor only 1 to 4. You can even add alphabet A or B depending upon those B symptoms. Then E can also be added. Then there are some modification also, that Cotswold modification, if you want, you can. This gives a very good, say, once you are making a summary, it does give lots of significance to your summary and value, scientific value to your summary, I'll say. So if you have these habits, it will be good. Once you have done the staging, then comes role of IPI, the International Prognostic Index. So IPI is different for different non-Hodgkin's lymphoma. There is one MIPI which is there for mantle cell, and it was little complicated, so there is a simplified version, what we call MIPI simplified, and there it is very simple. Means you have to take 4 different parameters, and you have to give points 1 to 3, and if total scores are 3 or below, it is low risk, and if it is 6 or above, it is high risk. So does it make a sense? So just see the next slides, you realize it makes immense sense. You should never miss this scoring these patients. You see over here a patient who is into low risk and a patient who is in high risk. The first one, this Kaplan-Meier, it is showing the 5-year overall survival expected in the patients of mantle cell lymphoma based on this score. This simple score hardly will take 2-3 minutes, and you see the difference. It is almost 3 times difference in the overall survival of the patient. So from 20% it jumps to 60% off, or from 60% it comes down to 20%, which makes a huge difference in the survival. So please do practice scoring. And if you want to go a step ahead, then there is MIPI-C, where apart from these 3 things, even Ki-67 is taken up, as Ki-67 is a very important prognostic tool. It shows the aggressiveness of the tumor. This is what I believe. And based on inclusion of Ki-67, there are 4 different subgroups, and here you can see even the difference is even more between low and high risk. So these are important things you must not miss on. And if you have done up to this, then the performance status, you have to see whether the patient is fit for further therapy or not. Usually we use ECOG, the Eastern Cooperative Oncology Group, this ECOG scale for say objectively assessing the performance state of the patient. 0 is what all of us are. Sometimes patient can also be in 0. 1 to 4 are usually what we are interested into seeing, and 5 is something where nothing needs to be done, just cool down and carry forward. So if you have done so much, then also one thing we should not miss is fertility. Any person, don't judge a person by his age. Okay, if there is a patient you are going to treat, at least discuss once that fertility is an issue. Until he is on deathbed, discuss before starting chemotherapy that there is something called a semen preservation, ovum preservation, embryo preservation. At least you mention and document it. Otherwise, the kind of era we are living into, we are inviting trouble for ourselves. So don't miss mentioning fertility, discussing fertility with the patients. And once all these things are done, now we are ready for take off. So we can now start treating the patients. There are few confusion in the treatment of the patient, so we'll try to discuss that, like how will we approach, how will we treat a case of newly diagnosed MCL, how will you treat a case of relapsed refractory MCL, and what are the role of immunotherapy over there. I'll rush through this because what I suppose that most of you are physician or many of you are in training, so I'll just rush across in next few minutes only. The important thing I would like you to understand is that you see these two photographs on the right side. The patients who are less than 65 years of age, cytarabine containing regimes are very important. Commonly, the commonest cytarabine containing regimes used in MCL is DHAP, R-DHAP most of the time. The DHAP has cytarabine. So that is very important, and it has stood the test of time. In last 1 decade data also, if you see all over the world, cytarabine containing for a young, healthy, transplant fit MCL patient, cytarabine containing regime is must. R-CHOP and all with DHAP you can give, with cytarabine containing you will give, otherwise individually not much of role. And BR is something whose importance is increasing with time, as it can be given even in younger patients who have lots of comorbidity or initially who are not found fit to be able to tolerate chemotherapy. Later on you can definitely change the patient, but initially you can even go for BR. But if you talk about people more than 65 years of old, the mainstay of therapy is only one, that is BR. And there are enough data for that. You can see over here, these were the two data where elderly individuals more than 65 or who were unfit were taken off for BR versus R-CHOP. You can see this Kaplan-Meier. Anybody can see, this is I think simplest Kaplan to read. You can see the difference between the blue and red lines. So it is proven that BR is significantly better than R-CHOP in elderly individuals or unfit individuals. So was in the other studies. So no doubt BR is one of the mainstay of chemotherapy as far as patients who are unfit for transplant is concerned in mantle cell lymphoma. This was another study which proved that there is a role of rituximab maintenance. In lymphoma and all, usually we give 6-month therapy and we forget about it, but here we can give up to 3 years of rituximab maintenance, and here there was enough data to support it. We can see here also the Kaplan-Meier curve, which is separating wide apart as the time is progressing. So rituximab did far better. You can see the p-value also less than 0.001. I think I have hardly a minute time, so I will not emphasize on these individual slides, but I will try to summarize it subsequently. And here comes the role of now immunotherapy, the BTK. So BTK is essential enzyme in BCR signaling, so B cell development and all this function and all. So BTKI are very important. I'll talk, there are 2-3 available in our markets right now. And this was a very pivotal trial, the triangle trial, where these 3 arms were used in the young fit individuals. Usually mantle cell lymphoma, traditionally or even today, we are treating with 3 cycle of R-CHOP and 3 cycle of R-DHAP, alternating 1, 3, 5, 2, 4, 6 kind of things. And then we take patients for transplant. So here the baseline was that only, but in one arm they added they added ibrutinib and no transplant, only ibrutinib maintenance. And in a third arm they did added ibrutinib, they did transplant, and then they again added ibrutinib as maintenance. And you can see over here that again addition of ibrutinib with or without transplant was better than without ibrutinib. And if you can add ibrutinib, take for transplant, give ibrutinib maintenance, it was the best. So ibrutinib has a role, very important role in managing mantle cell lymphoma. Just last 1 minute, there are few ibrutinib, there are few BTKIs in our market available. The ibrutinib is the latest entry. You can have a look. There are differences in adverse effects. Effectivity is almost more or less same. This was another data where Acala was added to BR. The notable change was that CR rate was better with adding acalabrutinib. So you can think about adding acalabrutinib in patients. Then there are ln R, this R square acalabrutinib has also been there. So I will not get into detail of this. I will just summarize. And there was this bovine trial where obinutuzumab with venetoclax was added. So there are many things which can be added. And also if you have to just summarize it for newly diagnosed mantle cell lymphoma, you see patients who are unfit, there you go for bendamustine rituximab, or you can even add acalabrutinib to that, or if nothing can be done, you can go for R square kind of thing, rituximab lenalidomide. Patients who are fit, the best, one of the best will be triangle kind of regimes, where you are taking the patient for R-CHOP, R-DHAP along with ibrutinib or any other BTK if you believe so, transplant and then maintenance. That will be the best outcome. I will not get into the philosophical mode now, because if you are talking about relapsed refractory MCL, more than medicine, it is philosophy which works over there. So there is no time over there for all this philosophy. So I will just go to summarize it. I will not go into details of all this data, though there was something like a CAR T cell therapy and all which is coming up in a very big way in even mantle cell lymphoma. I'll not get into the details of that, but if you look at that, there is not much clarity when you are treating a relapsed refractory mantle cell lymphoma. There are many options available. Perhaps the best one right now is CAR T cell therapy. So if it is available, your patient is affording, you can think about doing that. Otherwise, newer drugs like some bispecifics are coming up. They can also be the toast of the town, but maybe it will take some time before it reaches our market or our country. So there are many unmet needs in mantle cell lymphoma still. There is hardly any curative therapy, I'll say. Most of the patients have relapsed remitting kind of course. High risk subgroups with TP53 particularly, they are not doing that very well. They are even worse, even after adding venetoclax. The best drug which is considered to be the BTKI, they also develop resistance over a period of time, and we don't know how to overcome that. And optimal sequence, if you ask me also, I think if you ask 10 oncologists, there will be at least 2-3 different kinds of sequence people will tell you how they treat. Take home messages, it is a heterogeneous disease. At times you may just observe in mantle cell lymphoma, believe me, and patient can survive for years. And at times you can do everything and patient will not survive for years. But chemotherapy is something you should always keep in mind, that immunotherapy, particularly the BTKIs, have been considered to be the backbone, and then you can add whether chemotherapy, or you may not add chemotherapy, or you can think about transplant, but you should not miss out on BTKI when you're talking about mantle cell lymphoma, when you're talking about mantle cell. And in the time to come, CAR T cell therapy to bispecific, sky is the limit. That's all from my side. Thank you.
Nice presentation, sir. We have one query of one patient we have present with 30 years old, presented with osteomyelitis of the upper part of tibia. Repeated antibiotic is given and curettage is done. Finally, biopsy is done, and so mantle cell lymphoma. PET scan show only disease at upper part of tibia. LDH is high, and day one as osteomyelitis is present, WBC count is high. Our patient age is about 30 years old. Then how to proceed?
Yeah. Very good case. That's what is the beauty of the clinical settings, because the disease doesn't come after reading the books. Well, so what I understand in your patient case, that the major issue right now is that osteomyelitis, which is troubling the patient, which is the presenting things. And obviously all of us will be worried whether we should give chemotherapy or immunotherapy to the patient or not. So my take on this case will be that first we should get all the tests, whatever we had discussed initially, that the workup completed. There is a group of patients who comes into the indolent mantle cell lymphoma. There will be a group of patients who will come into the aggressive or blastoid variant or aggressive mantle cell lymphoma. If your patient is TP53 negative, IGHV hypermutated, if there is NRR stage is 1 kind of things, or 1 or 2 at the most, or 1E kind of things and all, and there is no major B symptoms and all in your patient, then you first treat the osteomyelitis in the patient. You may add say BTKI subsequently, maybe after 4 to 8 weeks or so. Wait, you can start treatment after 3 to 6 months. Because this is a young patient, we have to go for finally triangle kind of things only, all kinds of chemotherapy, bone marrow transplant, maintenance therapy, because lymphoma is never a localized disease and it is always a systemic disease. We have to go for the systemic therapy in the patient. But if as the mantle cell is a heterogeneous thing, not like DLBCL, here we can buy time. We can delay the things for a few months, particularly if it is a localized disease. This is what I feel.
Sir, any role of radiation in this patient?
Well, so as far as evidence is concerned, to the best of my knowledge, there is no evidence. Particularly in a young individual, there is no evidence at all. In an elderly, when you talk of palliation, you can give anything, you can treat it with anything, there is absolutely no problem. Make your own regime, radiotherapy, chemotherapy, surgery, everything can be done. If young 30-year-old individual is concerned, I am sure there is no role of radiotherapy. We try to avoid radiotherapy even in the most proven kind of lymphoma, that is Hodgkin's lymphoma. To a young 30-year-old individuals giving radiotherapy, we avoid in Hodgkin's also. So forget about mantle cell lymphoma. So no role at all. We will try to if patients fall into that indolent kind of lymphoma, we will have enough time to treat that osteomyelitis. So once it is better off, initially you can add BTKI and subsequently you can add even chemotherapy and go for the definitive therapy.
Thank you, sir. Any
Thank you, Chairperson.
Okay. Can we please have all the chairpersons and the speaker for
thank you.
photography? Moving on to the next session, breaking the bad news. May I
This is just to inform, due to the flight timings, we are shifting the panel discussion on emergencies in hematology to the Hall B. So the session will happen just now in the Hall B. So I request the speaker, Dr. Sanjeev sir, and the respected panelists, Dr. Amit Kumar sir, Dr. Kaushal Kumar, Dr. Santosh Kumar, Dr. Musharrat Sahin sir, Dr. Ashutosh Verma, and Dr. Divya Suman ma'am to shift to the Hall B for the panel discussion on emergencies in hematology.
Okay, resuming the session, breaking the bad news. Can I please have Dr. U.S. Prasad sir, Senior Consultant, Department of Medicine, Patna, on dais. Dr. Dinesh Kumar Sinha sir, Professor, Department of Radiation Oncology, SCI, IGIMS, Patna. Dr. R.N. Tagore sir, Senior Consultant, Medical Oncologist, Paras, HMRI, Patna. And Dr. Anand Kumar Gupta sir, Associate Professor, Department of Pediatrics, IGIMS, Patna.
Good afternoon, all. First of all, I thank the organizer for honoring us to chair this session. This is a very important session. The topic of this session is breaking the bad news. This is a common topic. This concerns all the department, all the clinician, all the hematologists, pathologists, gynecologists, physicians and surgeons. This is a very common topic and common problem in day-to-day practice. And to address this topic, we have a professor of hematology, clinical hematology, professor and head at Guwahati Medical College Hospital, Guwahati. She is none other than Dr. Jeena Bhattacharya. I welcome her and invite for her presentation on breaking the bad news. In my opinion, breaking the bad news or conveying the bad news to the patient or attendant, this is an art. And some of the healthcare workers, they have recommended that there should be a structured approach. There are few protocols also. So,
I think the topic should be breaking the hope by disclosing the bad news. So, the breaking the bad news.
Yes, that's right. I agree with you. Yes.
So, Dr. Jeena, please.
Thank you, Chairpersons. I thank the organizing committee for inviting me here. I really thank you for this honor given to me, and especially to Dr. Avinash, who has thought of this topic. And I think it's a very important topic. And when he, I got the mail requesting for this topic, I started thinking before saying yes, that what actually we are doing in our clinical practice. And therefore, finally, I said, no, I have to take this topic to know myself how much we are doing or how much we are not doing. And as Sir has said, it is to break the, to give the hope by breaking the bad news. So when we talk about bad news, what is the definition? By definition, that is, it is the news which is going to drastically change the patient's immediate lifestyle. So there are different terminology that is available, and it is in terms of cognitive, behavioral and emotional changes of the persons and their family. So we must know, when we talk about bad news, it can be, the disease can be different. Like suppose if I am told that I have diabetes today, that may be bad news for me, and that is definitely going to change my lifestyle. So this is how it is, the definition is there when we say the topic of, when we say this is bad news. So many centers are using different terminologies because patients do not accept bad as the word to be used. So based on patients' feedback, it has been, the terminology has been changed in some centers as serious news, and even the terminology like sharing life-altering informations has been used when we communicate a bad news to the patients. So as hematologists or hemato-oncologists, we have been doing it day in and day out at different time points during the treatment of the patient or workup of the patients. We know about it, but are you sure that do you have enough training for it? I'm not sure. So we all see patients of all age, because we hematologists, we have to see patients of all age group from day one, newborn to the very elderly, both benign and malignant. And this is the toughest and most important job that we must do in our day-to-day practice. And probably many of us in this hall are doing it every day. So I take you through two experiences that we had recently. On a holiday, I received a call from the head of the institute to urgently attend to a child. The mother was a doctor, and the child was having fever for 3 days. And then he came to, the parents brought the child to us. Meanwhile, the pediatrician who was taking care of the patient had called me and told me that he has seen blast in the peripheral blood, suggesting acute leukemia. So the child is 2 years old male, younger of 2 children. He was brought to in the lab by the mother. He was very irritable, hungry, and he was crying for food. I realized at that moment that this patient was probably not given food for a long time. Therefore, the child was crying that patricum. He could not even pronounce pastry in his this thing. So he was crying for patricum. So I arranged for that with water, and he was eating like, he had not eaten for many hours. While doing that, so we checked with the hematopathologist whether there are actually presence of blast. And then I came to know that already the peripheral blast has been seen by a couple of hematopathologists on several occasions, and all have confirmed there is presence of blast. And since the child was sick, and I thought I'll proceed further with the child immediately. Immediate action needs to be taken for the child. So we started discussing with the mother, because she was a doctor, her husband was also there, and they were like, she asked me whether we are not going to do the CBC again. I said, I definitely would be doing it, but we need to, since many have confirmed, so we must also face the reality and proceed further. Then her mood changed, and she told me that I came to listen to from you that these changes are not because of any acute leukemia. This is because of the fever, and there is no leukemia, cannot be any leukemia in my child. She refused to do any further tests, took the child away, and she never came back to us. So here, at this point of time, after getting this topic also, I started thinking where did I go wrong? Obviously, my breaking the news was not correct. I failed to connect to them, build a rapport, and gain confidence, and I failed to reassure them. So probably I was in a hurry, on a holiday probably I was in a hurry, I did not give enough time to them. Another case scenario opposite to the one that I had just described. This patient, I had received multiple messages from, I had received a message from an unknown number in the midnight, most after midnight, about 1:30 in the night, that her sister has been bleeding from nose and mouth, and she has been diagnosed. She has, along with that message, he has sent me a report of mentioning acute myeloid leukemia. The moment I saw this, even though it was very late, I immediately replied to him that you must attend the emergency. I alerted our residents and then slept off. The morning I received multiple calls from friends and family known to me, and the same report was being forwarded to us. Patient was immediately brought to our OPD, seen by our registrar, and patient got admitted. And this was a report, actually, if you can see, there is leukocytosis with bicytopenia, hemoglobin low, platelet low. There are 18% blasts in the peripheral blood, and bone marrow showed 25% blood. The diagnosis of acute myeloid leukemia from Apollo Hospital, Guwahati, which is a renowned hospital in Guwahati. Recently, Apollo has taken up. So, but by the time she was shifted to the ward, so we have checked the CBC, And we realized the CBC was normal. I thought it must be a mistake by our lab technician. They must have mixed up the samples. So when I went to see her, there were too many people because the news has spread, and then there are a lot of attendants were gathering in the room. And then suddenly, while going into the room, I realized, I thought that maybe we are dealing with something different. Then so immediately we examined her, and we did not see any evidence of bone marrow being done to her. We did not ask her anything. We started, we immediately knew that our lab tech our report was normal, correct. And so, so we immediately consulted our psychologist, psychiatrist, and then meanwhile the patient attendant were shouting at us that we are not doing anything, knowing that this patient has acute leukemia. Then we counseled them that our report is getting ready, so till that time we are taking some, because he is under a lot of stress, so we are taking some consultation from this thing. Then then later on we discussed with them about the CBC, and then the bone marrow was never discussed after that. I did not even discuss the bone marrow, where they have got it, how they have generated it, we do not know till date. But the psychiatry department has taken over, and they took pictures with the promise to attend the sessions with psychologists regularly. So two different situations, two different things, and the question is, are we doing it the right way? So is there any protocol to follow, or is there any guideline to to communicate the bad news to our patients? There are many modules actually which is there around, but this particular module, which is known as Spikes protocol, developed by Dr. Walter, it is a 6-step protocol. If you can see, one is you have to set up the settings, then you would take the perception of the patient and invite them for talks. Then you have to brace yourself with knowledge about the disease, diagnosis, treatment, and everything. Then you have to sit down with them and empathize with them, and then finally you summarize. These are the 6 steps of the protocol that needs to be done. I think we should be having it in our clinics, so that whenever we communicate the bad news, we should be braced with this protocol. There are other modules also, but I think this is the best. We have to create a conducive environment. The privacy has to be maintained. This is very important, that we should respect the privacy the patient or their attendants want. We cannot disclose this in front of many other people during our rounds in a corridor. This is not to be done, and it has to be without any disturbance. We must understand the gravity of this discussion, and we should be giving due respect to that, so that patients can access the information and take a decision. There should not be any distraction. We should not be using a mobile or laptop or any other thing. We have to sit down with the patient at the eye level, talk to them directly, openly, very clearly, with clear language, and we must take permission from the patients to allow in the attendant or any family members. Sometimes what happens in our scenarios, many a time the attendants will come in and tell us that please don't disclose anything to our patient. But we must understand, if the patient do not want to listen, then obviously we cannot. But otherwise, we have to take the permission of the patients to allow any attendant. In our rounds, you must have all experience that someone will come and ask you, what do you think about the disease and all that. So I think we should not be disclosing anything to anyone without the permission of the patient. So we have to first start with asking questions to the patient, whether about their understanding of the situation. This will make the patient at ease, and when you discuss in clear language, and very importantly, we should not be using any technical jargon, even if the patient or attendant is a medical professional. Before that, we have to brace ourselves with the knowledge about the disease, diagnosis, and so that we have to answer all the queries, and we have to know what we are going to do next. If we do not do that, then we will get the patient confused, increase their anxiety, and we are going to lose the trust of the patient. Most important in all this is the empathy. This is the word that we must remember. This is a central component of every protocol that we should follow while communicating bad news to our patients. And what do we mean by empathy? I looked up the dictionary. It is the ability to understand and share the feelings of another. It is not sympathy. We must remember that it is not sympathy. It is sympathy is just we know that the patient is in pain, but it is to feel a patient's pain as our own. That is what we should do when we communicate bad news to our patients. So when we look at the empathy, here you can see that you have to imagine yourself in the patient's shoes, be attentive, discover similarities, and share whatever experiences you have in your own thing, and that will validate the feelings, and then you have to be very genuinely curious about the patient's disease and problems. So these are the key of communicating any bad news to our patients. This will mitigate the patient's distress, and it will build trust, and thus we can, so that the patients can cope with the news better. It is very important to guess how much information to be given, and that will depend from patient to patient. And one important thing that we always have to have time, so that the patient needs time to absorb the bad news. So some point of time the patient may be silent for some few moments or few minutes. We have to allow that time to the patient, and patient has to be a part of the entire decision making. That will make them feel good, and also we should be encourage them to ask questions. Maybe sometimes a patient may need a second session, so we must emphasize that they can go back, discuss this patient with their family members, and then come back for discussion again, and we are ready to give the same time to them. So a second session can be organized later on. Once we finish that, we have to summarize everything to the patient, whatever we have discussed and whatever we have decided, so that everything is done as per, together with the patient, the attendants, and the doctor, and the team of doctors. So now, for this, all these years, are we doing it right way? I am not sure, because while preparing for this only, I came to know so many things. So do we need training? There is a study which shows that yes, we have to train ourselves about this. And does it affect us? Do you think it affects us? Yes, it is. It does. Because sometimes at the end of the day, you are emotionally drained. It affects our mental health. Your day may be bad for the entire time, and sometimes you may feel burnout. And for us, hematology is very much there, because we have been doing it every day in, day out for our patients, and because be it benign or be it malignant, we have been discussing diseases throughout the entire morning, but breaking this news to our patients is very important. How we do it is very important. We need to learn about it. So we must take out time. Time is most important. I have lost my patient first time because I did not have much time to listen to them and create a setting, not to be delivered in the corridor or during rounds. We prepare ourselves with details of the, we have to brace ourselves with, this is the last slide, can I continue? Yeah. So we have to build up a rapport, showing empathy with the patient and family. We must listen to them without distracting ourselves with anything like mobile messages, replying to messages. Nothing like that. We have to keep the mobile silent and must respect the patient's privacy. Someone will come in, ask you some questions, and then you are disturbed. No, that should not be done. So this has to be planned very well to break the news to the patients. So it is a skill that needs to be mastered. And it requires an individual approach combining clinical expertise with compassionate and comprehensive communication. That is very important. And obviously, we do not have anything written about this in our textbooks. And we know that expertise comes from experience. With the field of hematology evolving so fast, we senior hematologists must train our trainees for these skills, so that they also master in this skill, and therefore we should take them into the sessions that we do for breaking the news to our patients. With this I conclude. Thank you so much for your presence.
Thank you, Dr. Professor Jeena Bhattacharya, for your excellent and lucid presentation. You have very rightly said that we all should develop the skill and the art of conveying the bad news or the negative news. Thank you very much once again.
Excellent talk, ma'am. Actually, bad news is always bad news. जस्ट लाइक अगर रोड ट्रैफिक एक्सीडेंट होते हैं तो हम कहते हैं ना कि जस्ट वो एक्सीडेंट हुआ है लेकिन खरोच आई है, उससे अधिक बुरा हुआ तो फ्रैक्चर हुआ है, अगर बहुत अधिक बुरा हुआ एक्सीडेंट डेथ हो गई तो ये भी नहीं बोलते हैं अटेंडेंट और पेशेंट को, मैंने आई मीन रिलेटिव को कि हाँ दिन तो नहीं वो एडमिट हुए हैं हॉस्पिटल में, जस्ट डॉक्टर लोग ट्राई कर रहे हैं, तो सडन वी कैन नॉट ब्रेक द एंड। उसी तरह से कैंसर में भी है, कैंसर सुनते ही पेशेंट का अटेंडेंट दे फेंट पेशेंट भी और अटेंडेंट भी शॉक्ड हो जाते हैं, तो उसको ठीक है उसको कैंसर आई है लेकिन उसको हम लोग और इवेलुएट कर रहे हैं कि इट इज़ कौन सी स्टेज में है, किस ऑर्गेन की है, और उसके बाद और टेस्ट कराने के बाद में क्या हम लोग पॉसिबिलिटी दे सकते हैं, मैंने जस्ट पैलिएशन से लेकर क्यूर तक कर सकते थे स्लोली स्लोली। दिस इज नॉट वन मैन डिसीजन, डिसीजन विल बी ट्यूमर बोर्ड डिसीजन and that must be documented.
Correct sir.
Thank you
sir.
Any question from there? No. Thank you.
Can we please have all of you for the photographies? Upcoming, we have a panel discussion on basics of stem cell transplant and supportive care, for which I would like to invite Dr. Dharma Chaudhary sir on the dais. Sir has completed DM in clinical hematology from AIIMS New Delhi. He is currently the vice chairman, hemato-oncology and bone marrow transplant at BLK Max Super Speciality Hospital, New Delhi. Over to you, sir.
So, thanks Avinash for giving the opportunity and inviting here. And I'll first call upon the panelists on dais. So, though it will be a lecture come panel discussion, we'll take some question and we can take question from the house also. So, Dr. S.P. Verma, who is HOD of Department of Clinical Hematology, KGMU, Lucknow. Dr. Santosh Kumar, Pediatric Hemato-Oncology, Medanta, Patna. Dr. Shiv Shankar Mishra, Radiation Oncology, Paras, HMRI. Dr. Saurav Lahare, the Department of Transfusion Medicine, AIIMS Patna. And Dr. Avinash Kumar Singh, Nursing in Charge, Paras, HMRI. So, So Avinash had asked me to deliver a talk for a physician basically, and then we'll in between take the questions. So topic is supportive care of in the BMT and on the marrow transplant, and we as a physician we know bone marrow transplant is not a surgery. First thing is that it's not a surgery, it's a medical procedure done by physician, and historically how it started, people collected the bone marrow from the posterior superior iliac spine and infused intravenously, and they would notice that the donor bone marrow cell repopulating into recipient bone marrow. That's how the journey of the marrow transplant started, and the objective was primarily to deliver high dose of chemotherapy, which is lethal dose, chemo or radiotherapy to destroy the tumor cells. It provides a source of hematopoietic stem cells to salvage the ablated marrow. It stabilizes organ graft tolerance to prevent rejection of the donor cells, and it provides immune effector cell to mediate graft versus tumor activity. And this is if you believe in these four objectives, you will be a good transplanter, because I'm a poor man physician, not like we are treating the immunotherapy and CAR T cell. As I believe, India has almost 80 crore patients is getting food from the government scheme. So 60% are poor, 40% get from Ayushman. So we deal with the people who are really, really poor, and we have to deliver the treatment of masses, and cell therapy is one treatment for poor patients. This is not for now affluent patient in current era. So stem cell transplant, the word, it is autologous or allogenic, and allogenic could be, the nomenclature match sibling donor, match related donor, when 5% chances that you can have a family, have a match parents, match unrelated donor through the various international volunteer donor registry, and haploidentical donor transplant. And today's date we say everyone has the donor. And cord blood transplant was done historically. And this is the schema of autologous transplant. You collect stem cell from the same patient who is serving as a donor, who is in remission, give growth factor, collect stem cell, preserve, give conditioning chemotherapy, and allow you need to have a donor. So in the bone marrow transplant, you have typically 3 phases. The pre-BMT phase, the BMT day, which is basically intravenous infusion of stem cells, and the post-BMT phases, and the major supportive care will come in the post-BMT phases. So although the experience during these phases may be quite different for each patient, a general overview I will try to provide. And these, for all the physician and student, common step for transplant. Everyone has to get a venous access, which is the secure venous access, CVC, or typically Hickman catheter if you want to keep it for at least 3 months. A conditioning regime they get after admission. They get a graft versus host disease prophylaxis. They get bone marrow or stem cell infusion, which can be cryopreserved or non-cryopreserved. We wait for engraftment, monitoring, and long-term follow-up. So in this journey, you will see all the supportive care comes. So it's a first is like, stem cell collection. So you can collect from the marrow, you can collect from the blood. And today is the peripheral blood stem cell collection is almost done by more than 90% of the, other than some of the pediatric patient, benign hematology like thalassemia, sickle cell disease, aplastic, or where you collect the stem cell for the blood, and that is mainly also marrow. Otherwise, mainly PBSC, and in the haplo world, it has changed. Even the pediatric patient also they get the donor from the peripheral blood adult. So I'll just ask, what is the practice, Dr. Saurav here? How many people you prefer PBSC or you do marrow also? The stem cell collection will come to you. So what is practice at Patna?
So, sir, we haven't started so far in AIMS Patna right now. Yeah. Okay, it's primarily in certain private institutions only, but we'll be going for it in near future. So, I cannot comment much on what is our scenario.
Yeah.
Okay.
So in general, every the tertiary care hospital where the blood bank is there, they have cell separator which collect platelet. You just need to have a stem cell kit. So every center is self-sufficient. Whosoever you have a trained transplant medicine person, he can collect your stem cell using whatever you machine, Cove Spectra, Optia, or whatever the instrument you have. So you can collect. A marrow need the OT. So you have to collect under GA. You have to have team. We collect from the bilateral posterior superior iliac spine to reduce the time of collection. So donor should not get unnecessary prolonged anesthesia and the complications. So in the transplant, typically you see these few complications. So regime related toxicity, graft related toxicity, infections, which is a main killer for transplant in India, engraftment syndrome, graft versus host disease, immune dysfunction, and some of the long-term complication, and all the supportive care will be required for these. So when you choose, Dr. SP or Dr. Santosh can tell how you choose conditioning. Transplant can be myeloablative, reduced intensity, or non-myeloablative. So for your patient in your practice here, if you can give
So
any
conditioning is Susan based on two factors. One is the patient-related factors, and the other is disease-related factors. So patients' comorbidities, performance status, age also plays important role while choosing the conditioning regime, as well as the underlying disease, whether we are dealing with a malignant disorder where we are offering transplant, or a benign disorder like aplastic anemia or thalassemia like disorder. So these are the factors which make us decide the conditioning regimes.
Yeah. Any other comment? Yeah.
Sir, obviously, sir already told that if disease burden is more, if and patient is younger, in that condition we can choose the myoablative conditioning. And if age is more advanced, in that condition we can give the reduced conditioning. And some disease also like aplastic anemia and thalassemia, they are giving the reduced intensity conditioning.
So, Dr. Mishra, do you use radiation in your setting? No, TBI?
Sir, as TBI is well established for conditioning, but unfortunately at my current center, we are not able to do because of logistic and mechanical conditions. But at my previous center, we were doing TBI for almost all the patients for conditioning.
Yeah, I'm just asking, you know, where at least a student can take, these are modality. Yeah. Dr. Mr. Avinash. Okay, please have a seat. So, you know, these are modality for the, you know, conditioning which is required to ablate or, you know, immunoablate that the recipient's marrow. So myeloablative, typically it kills everything, reduce intensity, and non-myeloablative is primarily those who are unfit patient, elderly patient, septic patient, sick patient. And if you look at this, this is the cartoon you will see in each and every textbook. So the very low dose TBI, 200 or 400 gray, and you increase the intensity, it's from non-myeloablative to go myeloablative. So your toxicity goes high. Wherever you go up, you increase the intensity, whether you add the TBI 400 gray to 1200 gray, adding Bucy and TBI, which is typically practiced for unrelated donor transplant, and currently in the majority of people are they do with the reduced toxicity or reduced toxicity myeloablative, typically fludarabine and busulfan 4 days. So there is an increased toxicity when you increasing the intensity condition, and there is an increasing requirement of the graft versus tumor effect when you reduce your intensity conditioning. So you have to play where you want to have GVL effect or you have to have chemotherapy effect. So as I said, so I would say in the for physician, you know, radiation oncologists play most important role for me for transplanting. When I started transplant, I'm sure Avinash started here. So what is the role of radiation oncologist in the transplant?
Sir, as mentioned for conditioning, we prefer TBI in many forms, low dose TBI or high dose TBI or standard doses. It provides myeloablation with lesser side effect compared to high dose or high intensity chemotherapy in earlier era also. Currently with recent techniques like VMAT or Rapid Arc, it is very easy to do TBI without producing much side effects.
Yeah. So it's for student, I'll tell you, the most important when I started, first hand was given by Dr. Hokku, the irradiated blood product, where you don't have blood irradiation, so you have to have a irradiated blood product in your transplant program, and particularly not transplant, today's date, this fludarabine, cladribine, and so many, immunological drugs you are playing with them, the immune checkpoint inhibitor, you have to use irradiated blood product. And sir can tell you a little bit more about how to procure them, so you can reach to them whenever you need, not only for transplant, but patients who are getting the immunotherapy.
So the addition of TBI is basically helping in sanctuary sites, so that also we need to remember, because
absolutely. So in lymphoid malignancy, particularly when you're doing young lymphoblastic leukemia transplant, TBI should be backbone, because and those patients who have CNS disease, you have to use TBI, otherwise your outcome will be 5% less than chemotherapy, whatever graft versus leukemia effect you want to have. So TBI, radiation oncology should be part, and blood products should be irradiated. Though it's, I'm not talking about in the conditioning, but blood products should be irradiated, 25 gray radiation to given to the blood bag, each unit, each component, whatever you use, those are cellular, not FFP, but the platelet, red cell. And you can use up to 28 days after, once you irradiate a bag, should use as early as possible because of potential leak. So second thing, the second most important complication once you give the conditioning is mucositis. And every day you have to go to round and you have to look at the mouth. So a transplant physician has to carry the torch and has to look at the mouth. Then only they'll say this today was the grade 1 mucositis, tomorrow is grade 2, and it's going to grade 4. So what are the preventive strategy in Avinash in your unit? You are the nursing head of the paras, and everybody can, how you prevent mucositis in your patients.
So definitely, when we are taking care of the patients of the transplant, we are supposed to keep the patients hydrated, and sometimes our doctors advise for the laser treatment, that is laser therapy of the patient, through which we can prevent this oral mucositis.
Dr. Verma?
A very good oral hygiene is the cornerstone of prevention. That is one thing. So we must promote the patients to brush with soft brush at least 2 to 3 times a day, and mostly after having food. So that is very important. The second thing is that in some of the drugs like melphalan, we know that the recommendation is that ice chips can be kept while giving the drug so that they have less oral mucositis. And a routine, screening, as you mentioned, that daily, going for that. And then there are some supportive measures like, rinses with the saline or soda bicarb or calcium containing compounds.
Dr. Saurabh, you want to add, or Dr. Santosh, you want to add something? The most horrendous is the mucositis, probably Dr. Saurabh managed. Those who give head and neck cancer, radiation, people do get a lot of the problem. So, Santosh.
Sir, obviously exceeding mouthwash, mucoral gargles like that, which has the local anesthetics gargles to reduce mucositis, and also if soft food should be given in case of the mucositis. If there is the grade 4 mucositis, we should avoid the patient oral food and give on parental supplementation also.
Dr. Saurav, any comment? Or anyone else want to comment?
Sir, we particularly deal with not allowing this mucositis to develop by transfusing the appropriate units. So we are particularly dealing with that aspect of it. So particularly patient care we are not doing. Okay. We are doing.
Okay. So see, probably there is no drugs which can completely say no mucositis. Only there is physical therapy in the form of the melphalan, the cryotherapy. So it can reduce the oral mucositis. It won't reduce the mucositis in the intestine, gut. So you can have a little less pain. And the most important part comes with the mucositis from the supportive care for nutrition. So what is your practice, Avinash and Santosh, in your unit for audience? How you support the nutrition, and do you call your dietitian or gastroenterologist to decide whether this patient need a TPN, grade 4, NPO, just IV fluid, because mucositis, one plug fall, you will die, versus grade 1 or grade 2 mucositis, because in the supportive care point of view, you will require to have a good nutrition, which is, I think, marrow transplant is the highest number of catabolic state in the body. What
oral feeding as early as possible, because recovery is faster when the patient takes the enteral food.
Absolutely. Any comment? So we always encourage oral feed, because the infection rate, the gut complication, even they say GVHD all goes down, and poor people, as I said, I'm a doctor of poor, so we put NG tube for most of the children, and people, those who are not eating, even at the stage of the grade 2 or grade 3 mucositis, if the food intake, water intake goes down, you start at least relative feeding. So you can have a good effect, and you can avoid TP and which have their own complication of sugar, infection, electrolyte problems. So this is where, and then comes in the transplant, the graft versus host disease. So what is graft versus host disease? For student, there is a transplant immune cells and the host cell. So they think that you are not familiar, and they start fighting. So transplanted grafted cell attack and kill the host cell. And typically every transplant in the allograft, they get graft versus host disease prophylaxis, which start before transplant and it's continued after transplant. So typically the drugs which are commonly used, either cyclosporine tacrolimus, mycophenolate, or ATG, or those who have PTCY platform, the post-transplant cyclophosphamide on day 3 and day 4, and cyclosporine methotrexate for majority of matched sibling donor transplant. And since cyclosporine and tacrolimus both have very narrow therapeutic range, you have to monitor their level into therapeutic range, because otherwise higher level can cause toxicity, particularly hypertension, renal toxicity, and one more complication is a press, the anti-TP. So you have to be very careful about the managing your tacrolimus and cyclosporine level. So, and for physician, the GVHD is not a killer. GVHD does provide graft versus leukemia effect, because that is the purpose of doing transplant. As I said, the immunological benefit. So transplant immune cells, they kill the residual cancer cell, and it can be graft rejection. And second, another complication, because of time, I'm going a little faster. Infection in transplant, and anybody can take and say how to prevent in your unit, and what is the preventive strategy which you follow. So infection could be in the neutropenic phase, immunodeficient phase, so various infection.
So the first preventive strategy is the setting itself under which the transplant is being done. So for allogenic transplant, HEPA filtered rooms with the 0.3 micron filters, that is very important. The setting is important, and then initial parts, most of the time it's the bacterial, fungal, or HSV. The viral infections, bacterial infections are common. So the most important strategy again is the hand hygiene. Hand hygiene has to be very strictly followed. And then we can use prophylactic antifungal. That is one thing, prophylactic antiviral. And once the patient engrafts, then maybe the Septran or Ceplin DS can be started for prevention of pneumocystis. So these are the usual preventive measures we take.
Because this is one of the most important supportive care required. One is start with the primarily those who works for 23.5 hour nurses. So line care, hand hygiene, line care, hand hygiene, oral care, perianal care. Because these are the most common causes of infection. Then comes HEPA filter and everything. So if you follow the restricted visitor, hand hygiene, and good line care, 90% of infection you can avoid in transplant.
Sir, I would like to add one thing. Like we can transfuse with granulocyte concentrate to such patient when the absolute neutrophil count decreases below 500 per microliter. So in this, what we do, we collect granulocyte from a healthy donor. Okay, and we collect about 1 into 10 to the power 10 count per bag, and we transfuse it, okay, within 24 hours, and that unit needs to be irradiated. That's what we do.
So as I was discussing, the supportive care to prevent. So that is when you have severe sepsis, not responding to your antimicrobial, antibiotic, antifungal. Then at the last hope, you can use granules till your graft recover. So granulocyte transfer is a treatment strategy for refractory sepsis, not responding to antibiotics and antimicrobial. So these are chronology of infection for PGs. Like pre-engraftment, there's typically neutropenia, like all AML induction. post-engraftment you have a T cell or B cell aplasia, and the late phase you will have the different kind of infection, so bacterial, viral or fungal. And these are the different way, and these are the factor affecting the risk of infection. So particularly type of transplant will be higher with high risk of allotransplant, or myeloablative conditioning, timing of the transplant, pre-transplant factor, graft versus host disease, HLA mismatch, donor type, immunosuppression, and if you have delayed neutrophil engraftment, your infection rate will be going high, particularly in the haplo and cord blood if somebody does, because your neutropenia will last longer. So a word about graft versus host disease. You can see acute graft versus host disease in the first 100 days is 30 to 40% in sibling donor transplant. It increases with the half match, and typically 3 organs get affected: skin, gut and liver. And chronic GVHD you see after 100 days, and it resembles like autoimmune disease like scleroderma. So all physician has to look patient every day, skin particularly in acute setting, monitor the liver function, and nurses should record amount of diarrhea after engraftment, and as per physician guidance that how to monitor. And you have to stage the GVHD because you have to see the patient. You have to check the area of the skin involvement. You have to see the amount of diarrhea and document carefully. And I'm sure Avinash, in your practice, will be having the stool volume measurement every day. If you're starting GVHD, you should volume stool, and a treatment can be depending on that. For physician, GVHD is not always a problem. If you look at the patient, those who get a sibling twin transplant, identical, the relapse rate is almost 70% in the leukemia setting. If you have a control acute and chronic GVHD, which is relapse rate will be less than 10%. So never get away with that, GVHD will kill, don't get transplant. So we have heard the people, say no to transplant. So that's not the, if you believe in cell therapy, those patients who have a controlled GVHD, if you look at this Mary Flowers chart, 80% who have chronic GVHD control, they never relapse. So some sort of graft versus host disease will keep patient alive for long term. So second, another complication which you typically see, endothelial dysfunction after transplant, and which typically manifest either VOD or hemorrhagic cystitis and TTP. So what is your preventive strategy in the VOD or SC? If anybody can tell.
So endothelial dysfunction is again a common complication of transplant, and it can be VOD or it can be TTP, it can be lung injury, acute pneumonia. So all sort of complication, all of these have endothelial dysfunction at the baseline. Yeah. And mostly this depends on the what type of conditioning we have used. So mostly for the myeloablative conditioning, these complications are much more compared to reduced intensity conditioning. So for VOD as a prophylaxis, those patients who are at high risk of VOD, ursodeoxycholic acid is one which has been used by most of the transplant physicians. And otherwise we have to be very observative and look for these complications and pick up as early as possible so that we can treat these conditions.
So endotheliopathy, particularly the VOD, hemorrhagic cystitis and TTP, if not picked up early, they're very, very bad. So for as nurses, they have to check the weight, particularly what is in the transplant is most important. Check weight 3 times a day, 4 times a day, and output. So if your weight is going up, you are worried. If you're developing ascites or tender hepatomegaly, you are worried, or laboratory evidence of jaundice. So you have to look at the VOD, pick up early, fluid restriction, Lasix, albumin. Otherwise, treatment is only defibrillator, which is not available in this country. We routinely follow the UDLIV prophylaxis from the starting of conditioning till day 100. Some people stop at day 30, depending on what conditioning. So one should use UDLIV. You should monitor nurses, the physician should every day look from the day 5 onward. The VOD can come, and particularly our population, thalassemias, multiply treated, or you have acute lung injury or idiopathic pneumonia, as you said, or late the bronchiolitis obliterans. So these are all the paradigm of the always look at the supporting care kidney dysfunction and pick up early, rise of creatinine and treat. Hemorrhagic cystitis, very good hydration, monitoring, looking urine dipstick test wherever you're suspecting, there is hematuria starting, and the treatment is only hyperhydration. So I'll just quickly go, and these are some of the complications need care, and comes again with the lastly, sorrow that the people, those who get ABO mismatch transplant, because you need HLA typing only, so there will be people, blood group mismatch. How you manage and how will you advise in the people?
Sir, ABO incompatible transplantation then can be further classified in 3 groups, like major incompatibility, minor incompatibility, and bidirectional, both. So I will give an example. Suppose if we are transfusing O group, O ABO group, hematopoietic stem cells to A, B or AB group recipient, then it is a minor incompatibility. And if it is a case of the vice versa, like O is the recipient and donor is A, B or AB, okay, then it is major incompatibility. And when we are transplanting A or B group to the same group, A or B group, then it is a bidirectional. So how do we manage? We manage by volume reduction for minor incompatibility. Okay, then we manage by red cell depletion in case of major incompatibility, and we perform both this case for bidirectional incompatibility.
Thank you. And remember that every person who is working in transplant, that you should transfuse the appropriate blood product in the cases of mismatch setting, pre-transplant phase, transplant phase, and post-transplant phase, and all blood products should be irradiated. And I'll just finish in 1 minute. So you have to monitor transplant patients forever, closely up to day 100, then 1 year, and then you have to follow for 5 years for looking at long-term complication. And these are the typical long-term complication: infection risk, particularly those who have the immunosuppression ongoing with GVHD, infertility, hypothyroidism, cataract, the AVN with the steroid, autoimmune dysfunction, dental issues, and second malignancies. And once you have completely immunosuppression is stopped at the 1 year, you have to vaccinate again. So all patient islet transplants should get a revaccination, and you can our ISCTR, we have different chart, so you can follow whatever the protocol you follow. But all the live vaccines should be given after 2 years. So I'll end here, and thank you so much. Thank you, panelists.
We don't intend to keep you all starving anymore. After this photography session, all of you can proceed to Hall B for lunch, and we would deeply appreciate it if you can be back here by 2:45 p.m. at max. Thank you. We will be resuming the session shortly, in another 5 to 10 minutes. Okay, we are ready with the post-lunch sessions. So the next topic that we have is update on pediatric ALL management in 2025. May I please invite the chairpersons to come on the dais. Dr. Anand Kumar Gupta, sir, Associate Professor, Department of Pediatrics, IGIMS, Patna. And Dr. Amit Kumar, sir, Associate Professor, Department of Pediatrics, IGIMS, Patna. So can you please invite the speaker on dais?
Very good afternoon to you, all of you. It's an honor to invite Dr. Sunil Bhatt on the stage. Sir is Director and Head of Pediatric Hematology at Mazumdar Shaw Medical Center, Narayan Health City, Bangalore. And Sir is interested in blood and marrow transplant and has done actually more than 2,000 transplants in children. The topic for today is update in pediatric ALL management. And Sir, it's over to you.
So very good afternoon, and first of all, thank you, Bihar Hematology Foundation and Dr. Avinash for having us all here today. So I have been asked to talk on what's new in acute leukemia in children, and what is the update in 2025. So before we go there, this is a very important slide, which just shows us that the pediatric ALL has been a success story. A disease which had maybe less than 10-15% cure rates 5 to 6 decades ago is almost now approaching 93% cure rates today with the current modality treatment. But we also know that pediatric ALL is kind of a genetic disease, and almost all the patients with pediatric ALL, you will have one or the other genetic lesion when you investigate them, and this is important because the treatment and the cure rates depends so much on what type of genetic changes these leukemia cells have, and you can have outcomes as low as 30-44% in, for example, in the high risk KMT mutations, and as high as 95% in the good risk ones, the hyperdiploidy, the TEL EMLs. So it's a heterogeneous disease, and that's very important because this helps us to not only to prognosticate but also offer the current treatment modalities to these patients. What's very important is that what has been shown is that the treatment response is the most important prognostic factor in ALL. And by treatment response, we mean that how well the patient has responded, and that response will depend on the host factors. Age plays an important role in pediatrics, pharmacogenomics, leukemic characteristics, microenvironment, which can lead sometimes to drug resistance. Also, very important is what therapy we're using and what dose interactions and drug interactions are there with the current therapy protocols. What's also been shown is that response to treatment, which I showed the previous slide, is very, very important, as I said earlier on. And it also depends on response of treatment, what the dynamics of response to treatment. If you see this at diagnosis, we kind of presume there's about 10 per 12 cells, and 10 per 10 cells will kind of be remission, which is a morphological remission. But that exactly is not what we want. We want the patient to be in deep remission and maybe have a disease burden less than this, which may not be seen by the naked eye, but can be done with MRD techniques. So, if there are 4 patients here, this patient has received a molecular morphological remission, but still there's a disease burden is quite high. This patient has gone at MRD negative, but then it takes lot time to go there. And these 2 patients have done this very, very short span of time. And we know that these are the patients who are going to do better with treatment. And this is another way of representing the same thing. So MRD negative patients, the risk of relapse is extremely low, and the patients who have MRD positive, maybe more than 1%, after induction, their relapse rates are almost 70 to 80%, and other ones are in between. So what has happened, with this background, what has happened in the recent era is that, for example, the adolescent and young adults, so the outcomes have improved because they are now treated on pediatric protocols, and that has been shown that it is superior to treating them on the adult protocols. Ph positive ALL, which was once considered as a very, very poor prognosis, cure rates have now gone up from 20 to almost 80% with the use of TKIs, and no longer indication for transplant in CR1. Duration of TKI exposure post-transplant, patients who are Ph positive ALL, so we use for 12 months at least post-transplantation, and indefinitely in patients who are more than in CR2. Ph like ALL is another entity we know, and therapies like mTOR inhibitors, JAK inhibitors have changed the way we treat Ph like ALLs. In fact, ALL is a very poor prognostic disease group, and the prognosis still remains poor in the range of 30-40%. TLL improved outcomes, and outcomes are now almost similar to BLLs with MRD guided treatments, new treatments in nelarabine, also use of bortezomib in the lab settings, and experimental CAR T therapies, and early precursor T cell ALL, which is called as ETP, once considered as a poor prognostic group, but now with the current molecular with current treatments and the use of the treatments like ruxolitinib, MRD guided treatments, it has shown to be a similar outcome as the TALLs. So this is some of the advances which have happened in the recent years. Now, for the want of time, I don't have much time, I have only 10 minutes, I brush through immunotherapy role in pediatric ALL and how are the different immunotherapies which are employed in the treatment of ALLs. So examples of immunotherapy are various. It can be cell or humoral immunotherapy. Examples are monoclonal antibodies, for example, adopted T cell therapies like T cells or NK cells, or they're modified or unmodified, and cancer vaccines, although they're not very important in ALLs, but can be used as immunotherapy mode, and stem cell transplant itself is a immunotherapy which can be employed for patients with ALL. Now, this is a kind of timelines which the immunotherapy has advanced in the last few decades. Autologous BMT was the first immunotherapy kind of to be employed, and that's evolved into allogenic transplants, tumor-infiltrating lymphocytes used for treatment, and various monoclonal antibodies, as well as in the recent times CAR T therapy. This is how the landscape of immunotherapy has evolved, and in the context of ALL or the B cell malignancies, these are the potential targets which can be targeted on the surface of the cell on the B lymphocytes. 19, 20, 22 are very important targets, and also CD52 can be targeted with various treatment modalities. Now, first, looking at immunotherapy with antibodies. And antibodies, this is the cancer cell which has to be killed, and this can be killed by the antibodies by different mechanisms. It can be antibody-dependent cellular toxicity, it can be with complement-mediated cytotoxicity, and ultimate aim being apoptosis of the cancer cells and the cell death. And these antibodies can be enhanced by different methodologies. So one of the methodologies was humanization of these antibodies. For example, rituximab is a chimeric antibody, but epirotuzumab is a humanized antibody. We can increase the affinity of these antibodies. We can conjugate them with some conjugation with cytotoxic chemotherapies like toxins and radioisotopes. I'll show the example of this. And we can also use bispecific antibodies, which have led to enhancement of these antibodies and their mechanism of action. So one of the examples where there's conjugation has helped in the antibody and enhanced antibody is inotuzumab ozogomycin, which is a CD22 anti-CD2 antibody. It's a humanized antibody, and it's conjugated with this toxin called calciumycin, and when it enters the cell, leads to cell death and apoptosis. This is how it works. You've got a CD22 on the surface. This is antibody conjugated with calciumycin. When this binds this antibody here, gets internalized and then gets transported to the nucleus. When the nucleus, the calciumycin is released and activate in active form and leads to cell death and apoptosis. Another example is BiTE antibody. The example is blinatumomab. The blinatumomab has two binding moieties. One binds with the CD19 on the surface of the cells, and there's one end which binds to the T cell, which has got a CD binding moiety, and these when they bind the cells on the surface, it also engages the T cells, and that leads to the cell kill. And this is another way which can treat, and this is what's called as BiTE antibodies. So what's the pediatric experience of blinatumomab, which is the BiTE antibody? It has been used in phase 2 studies with relapsed or refractory ALLs. We use 5 mics per kg for first week and 15 mics per kg for the rest of 3 weeks. And almost 50% of patients will get MRD negative even with one cycle. And these are the patients who had a disease burden which is very, very high. But we know that when it's used in low disease burden, outcomes are almost in the range of 90% now. So this is used in patients who are MRD positive in spite of their salvage treatments. And it's always, most of the times, used as a bridge for transplant. And it's also used in patients who have got fungal bacterial infection where you cannot use conventional chemotherapy. Now with inotuzumab, which is the CD22 conjugate antibody, this experience there, 52 patients which are used, relapsed refractory ALLs, and almost quarter of the patients become MRD negative. But one thing of caution is that patients who proceed to transplant after inotuzumab have higher risk of VOD. And now you must have come through this article that in the Ph positive ALLs in adults, dasatinib and blinatumomab was used as an induction treatment, and this only led to almost 90% response rates in the adults. So things are changing. So we are moving from blanket toxic chemotherapy to more directed immunotherapies, and this is also kind of becoming a reality in ALL world. Now, as I said, transplant is one of the immunotherapies which can be used in ALLs. I don't have time to discuss that, but then this is something which is used in refractory settings. But very important is that we need to get MRD negative before transplant. This is our experience with haplotransplantation in ALLs, and you can see that with haplotransplant, these are all the patients CR2. You can still cure about 60-65% of the patients, either with PTCY or T-cell alpha beta. These are one of the two platforms which use in our center. 132 patients, almost half patients in both the groups, and you can see almost 60% by either of the two techniques can be cured. So it's not a death warrant. Even patient with CR2, if you don't have an acceptable donor, with alternative donor like haplotransplants, you can cure them. So in the last is the use of CAR T therapy. So we all know that CAR T therapy is a treatment of the century. It's a living drug. These are the cells which have been modified, and these modified cells will go attack the leukemia cells and kill them. So the essential steps of the CAR T therapy are isolation of the as the leukophoresis, collection of the white cells of the patient. These white cells, the T cells get separated. T cells get modified in the laboratory, and they on the surface express what we call as the binding moieties or the TCRs, and these bind when they're infused back to the patient, they bind the receptors on the surface, and they kill the cells. And this is it's an autologous living cell therapy which is used through T cell, modified T cells. Hematological malignancies like lymphomas, B-cell lymphomas, mantle cell lymphoma, as well as multiple myeloma. These are the ones where the T cells, the CAR T therapy is already approved and used, and it's also been experimented in some of the solid tumors, and glioblastoma and neuroblastoma are the two typical examples. And there's some role in autoimmune, in AIDS as well as autoimmune disease in adults, where it has been experimented as a treatment option. So this is how, as I said in the previous slide, how it works. So you need this T cell which has got on the surface a binding site, and this expression of this CAR, it goes and binds the tumor cells, and because these are T lymphocytes, these are self-proliferating cells, so the idea is that there should be a constant surveillance and constant proliferation of these cells and lead to a tumor kill. This is how the CAR receptor looks like. There's a binding site, there is a signaling domain. This is what was the first generation CAR. You have a binding site and a signaling domain, which is called a CD3 zeta. But the problem with these cells, the first generation CARs, these were not long lasting. They had a very short proliferation time, and the disease would lapse even after that. So the advent of what you call as co-stimulating molecule, which is introduced here, this CD28 or 41BB, that leads to persistence of the CAR T cells and gives you better outcomes. And now we have third, fourth, and fifth generation CARs, which have been even modified for better efficacy and more persistence. The CAR Ts have been, been used for almost a decade now. Various products available, and if you see, lentiviral is the most of the vectors which is used in most of the CAR T therapy products for B-cell malignancies. And this is the response rates. The response rates reach for almost 70 to 90%. So it's a very effective treatment, and we have to remember these are all relapsed and refractory cases where this is being used. 2017 saw the first approval for CAR T for Kymriah, and then we have a series of products which have been approved, and more than 35,000 patients have been treated already all over the world with CAR T therapy. This is our experience of using CAR T therapy in relapsed and refractory B-cell malignancies, and this is I'm showing the pediatric sub-analysis. This was done at our hospital at Majumdar Shah Medical Center in Bangalore, and Immunil being the manufacturing partner. This is the laboratories on our our hospital, which belongs to Immunil, and the manufacturing happens here. This was a phase 2, a non-randomized study for patients with relapsed refractory ALL, and the primary endpoint was to look at the safety of this product, and also look at the response rates at 1 month and 3 months post-transplant, post-CAR T therapy. So all the B-cell patients who were 3 to 45 years of age, more than one relapse, and had relapsed or refractory disease. B-NHL patients more than 18 years of age were involved in the study, and the patients who had active GVHD or CNS disease were not involved. They were excluded from this trial. So this is the schema of this trial, which we had, after consenting at leukapheresis, the cells would go for manufacturing. They will be admitted for lymphodepletion for 3 days, and we infuse the CAR T product in 3 different aliquots, day 0, day +1, day +2, and then follow them for 1 month in the hospital, and after discharge from the hospital they were followed up for 1 year, and then put on a long-term follow-up after that. So pediatric cohort was 9 patients. We had around, at day 28, 90% patients were responded, and they were MRD negative, and that persisted to day 30, that's day 90, that's 3 months. 8 of the 9 patients still remained MRD negative after 3 months. This is the smear plot for the same cohort. There have been 2 or 3 relapses, but all these relapses have been salvaged with a transplant after that. This is the median age of this pediatric cohort, 3 to 17 years of age, and most of the patients had already received more than 2 lines of treatment. And manufacturing happened in all the cases, and that took around 10 days for manufacturing. And this is the cartoon showing on the next slide I'll show you. This is the adult and the pediatric cohort together, 24 patients. At day 28, 91.7% were disease-free, and 83.3%, that's 20 out of 24, MRD negative and disease-free at 3 months post CAR T therapy. Swimmer plot for the whole cohort, and these are some of the images. So this is the of a PET scan before giving CAR T therapy, and these are the scans which are after the CAR T, and you can see very the results are amazing. Within 1 month time, the whole disease melts away, and nothing like that we have seen any other treatments which are there. This is the B-cell aplasia which sets in, and these are the proliferation of the CAR T therapy cells which happens post infusion. They start proliferating around 3 to 4 days, and 7 to 10 days the maximum proliferation before they start sometimes dipping down, and some of the B cells which are coming up, of course, then lead to B-cell relapse in some of these patients. This is the progression-free survival, overall survival of the whole cohort, which is the full cohort of CAR T therapy patients. This was the first patient which were treated who had relapsed refractory, failed 5 lines of treatment, and is now disease-free almost 24 months post CAR T therapy, and is a long-term survivor. And to summarize, in pediatric ALL, treatment outcomes have improved, and I showed you it's now more than 85% at good centers, especially St. Jude's shows outcomes of over 95%, and that's been possible with the new protocols and the multimodal treatment. This adaptive treatment is very important, and target drugs and better supportive care have really made the change. Immunotherapy is emerging, as I showed you, in a big way. Monoclonal antibodies, whether it's blinatumomab or inotuzumab, have showed promising results in refractory MRD positive disease and helping them patients to get to consolidation, which is transplant most of the times. And CAR T therapy can be employed in relapsed refractory diseases, and is now available in our country and can be used. And slowly, immunotherapy is finding its place in the upfront treatments, and I think we need to watch the space as we go along. So thank you very much. Sorry for this rapid fire, but time has been reduced from 20 to 50 minutes, so I had to squeeze in those 50 minutes. Thank you very much.
Thank you, sir, for your nice and crisp presentation. I have just one question. As we know, pediatric ALL is a condition which has a strong genetic predisposition. So what is the update about genetic therapy or gene therapy in ALL?
So, when I said it's a genetic disease, I didn't mean it's a germline genetic disease. So you find genetic, I would say, lesions in most of the pediatric ALL patients in the leukemic cells, but they're not germline. So germline mutations, which is genetic in origin, is less than 5% of the patients. You know, like patients with Bloom syndrome, Fanconi, patients with Klinefelter. So these are the syndromes where you have a Down syndrome, a higher risk of leukemias. These are the germline mutated ones. But the ones more than 95% are not. They are actually non-genetic. So hence, there's no role of gene therapy here. Because it's not a germline or a genetic disease. But yes, what I showed, for example, CAR T is a kind of gene therapy, but it's mostly autologous cells modified and used to kill leukemia cells. Yes, Dr. Dinesh?
Any question from the audience?
Long-term survivors. So first question is, whether looking for chemotherapy-free protocols. I think we are slowly approaching that. I showed you that data, which is although not pediatric, but that's adult paper, which was an NEJM publication where adults with Ph-positive ALL were just treated with dasatinib and blinatumomab. So I think slowly it's finding its place, and it won't be too long that we'll find these in more frontline protocols and try to get rid of chemotherapy. We're already doing that in our labs. For example, relapsed leukemia settings. Previously used to use R3 protocol, which is a very heavy duty chemotherapy protocol, and now we have moved to mini hypersevere inotuzumab as our preferred induction regimen in relapsed ALL. So it's already happening. CAR T therapy can cure maybe 40 to 50% of the patients by itself. Yeah, that's right. So CAR T therapy can cure 40 to 50% of the patients without any other treatment, and that's been experienced from elsewhere with a longer follow-up. In our experience, also is exactly the same. So out of the 10 children which I showed you, 4 have been disease-free just with CAR T therapy. Other 4 had 6 had relapsed. 1 died within the first month, which was with grade 4 CRS. Other 5 had relapsed. 4 were transplanted. They're also okay, but they had required a transplant, and 1 patient did not go for transplantation. He's on a palliative care. So we expect around 40-50% patients to be cured just with CAR T. Others may require a consolidation with transplant also after CAR T therapy.
So how it differentiate, any technology used to differentiate that this cell only attack the malignant B cell, not the physiological B cell?
Yeah.
And at the same time, what is the mechanism action of CAR T cell on solid carcinoma that not expressing usual B cell antigen?
So very good question. And first of all, the first question, to answer your first question, they do not distinguish. So they target everything which is called CD19 or CD, whatever CAR T you're using. I showed you CD19. Every CD19 cell will be killed by those T cells. Hence, B cell aplasia is one of the problems post CAR T therapy, and they will require IVIG replacements for some period of time post CAR T till their B cells start recovering. But fortunately, B cells do recover. B cells do recover eventually, and some of it may be, if it's happening within 6 months, it kind of is impending relapse. But if it's happening later on, it's usually the relapse is not associated. So yes, that's a problem, and you convert them into immunodeficiency kids actually post CAR-T. We have one patient who is now almost 2 years plus post CAR-T infusion. He's got B-cell aplasia, but other patients, their B-cells have improved and they do not require any more IVIG. Second, on the solid tumors, CAR-T therapy is still not been very successful. Neuroblastoma and glioblastoma is showing some promise. The problem with CAR-T therapy in neuroblastoma or in solid tumors for that sake is that the expression of the tumor associated antigen is not very, very homogeneous like in malignancies, liquid malignancies. Second, there's always this barrier of kind of reaching the spot because you're going through a very hostile tumor microenvironment, so cells do not reach actually the target organs. But yes, if you have a minimal residual disease, especially in some of these malignancies where the tumor bulk is very less, CAR-T cells are showing some promise in some of these diseases.
Yeah, Sunil, excellent talk. The thing is, you give CAR-T on 3 days, 3 consecutive days compared to 1 day. So what is the logic behind that, or what is the principle?
So CAR-T, as you know, it has got its own problems. So the two important side effects which are with CAR-T are cytokine release syndrome and ICANS, and neurological toxicity. What has been shown in, because we have adapted this from a Spanish protocol, and they had 2 cohorts. One was single infusion, and they had almost 4% or 5% ICANS and almost 30 to 40% cytokine release syndrome in their cohort. So when they fractionated the same dose, it's given in 3 different days, the incidence of ICANS became almost 0, and the cytokine release syndrome, which was grade 3, grade 4, also was less than 5 to 6%. So the rationale is to not give the whole kind of treatment in one go, divide them into 3 fractions with same efficacy, but coming down the risk of ICANS and cytokine release syndrome. Yeah.
So we close the session now.
Thank you.
Can we have all the chairpersons for the photograph? We'll advance to the next session. Approach to a child with suspected PID. I would like to invite the chairpersons for the talk. Dr. Amrita Rakesh ma'am, Consultant Radiation Oncologist, Savera Cancer Hospital, Patna, and Dr. Sudesh Kumar sir, Department of Pediatrics, MGM Medical College, Kishanganj. Ma'am, can you please invite the speaker?
Good afternoon. I would like to invite Dr. S. Yoga Lakshmi. She is DM in Clinical Hematology, Consultant in Clinical Hematology, Hemato-Oncology and Bone Marrow Transplant at GKNM Hospital, Coimbatore, Tamil Nadu. She will discuss on approach to a child with suspected PID. Ma'am, over to you.
Good afternoon, everyone. First of all, I would like to thank Dr. Avinash sir for giving me this opportunity. He was my mentor who constantly encouraged to take clinical hematology. So coming to primary immunodeficiency disorders, these are the inherited disorders in the innate or adaptive arms of the immune system. It leads to increased susceptibility to infections and or immune dysregulations in the form of malignancies and autoimmunity. So the estimated incidence is about 1 in 1,000 to 2,000 live births, which is not too rare to have. And thanks to the molecular diagnosis, we have more than 500 gene defects and 555 immunological diseases and increasing constantly. So the recurrent infections are usually common in children. It is because of the developing immune system, close contact in the daycare and schools, poor hygiene, nutritional deficiencies, and some anatomical defects. But when does the child need no further evaluation for PID? If the child is thriving well, infections are not unduly severe, and the child responds to the treatment appropriately and recovers completely, appears healthy between the infections, and repeated single-site infections where the anatomical defects are found, and there is secondary immune deficiencies. So when to evaluate for PID? So these are the 10 red flags signs given by the Jeffrey Model Foundation: a family history of immunodeficiency or unexpected early death, failure to thrive, need for intravenous antibiotics and or hospitalization for many infections, more than 2 or more pneumonias within a year, more than 2 or more serious sinus infections within 1 year, and more than 4 or more new ear infections within 1 year, 2 or more episodes of deep-seated infections like sepsis or meningitis, 2 or more months of antibiotics with little effect on the infection, recurrent or resistant oral or cutaneous candidiasis, and recurrent deep-seated abscesses like lung abscess or liver abscess. So in general, something is unusual, and the infection secondary to live vaccines, especially BCGs, and chronic diarrhea, non-healing wounds, extensive skin lesions, persistent lymphopenia, unexplained autoimmunity or fever, granulomas, HLH, lymphoma, and features typical of syndromic PIDs. So what are the clues to the diagnosis? A meticulous history taking, thorough physical examination with a high index of suspicion is required to approach the PID with a stepwise laboratory workup and genetic tests. Many a times, knowing the microorganisms often provides important clues to the type of immune deficiencies which we are dealing with. So in history, mainly concentrate about the infection history, what is the age of onset and type of the organism, site, frequency, duration, and what was the response to the treatment given. And birth and neonatal history, mainly ask for any neonatal admissions for sepsis and meningitis, and also was there any omphalitis or delayed fall in umbilical cord. So growth and development should be concentrated, as chronic illness can delay the development, and there may be progressive neurological deterioration in some syndromic PIDs. And immunization history is important. Have to ask what vaccines have been given, and was there any complications after the vaccines, and were there any failures of vaccines. So medication history is important to rule out the secondary causes, especially glucocorticoids, and the family history, whether a similar illness, any unexplained deaths, early deaths, especially in the family, and any illnesses like HIV, were there consanguineous marriage in the parents, to arrive at the inheritance pattern. So age of onset is very important. So early onset disease, usually less than 6 months, is seen in the T cell defects and combined immunodeficiencies, whereas the B cell defects can present later on, more than 6 months, when the maternal antibodies start weaning. There is granulocyte defects can present at any age, but there is early onset in many of the cases. Complement defect can present at any age. Usually the immunodeficiencies like CVID present after 5 years of age. So the signature organisms which occur in a specific type of immunodeficiencies can give a clue to the diagnosis. There is recurrent cyanopulmonary infections with encapsulated organisms in the human humoral immunodeficiencies, recurrent pneumococcal infections in A-gamma globulinemia or complement defect. Pneumocystis jirovecii and other opportunistic infections are common in the SCID and other primary or secondary T cell immunodeficiencies. Pseudomonas sepsis is most common in the phagocytic disorders. Enteroviral meningoencephalitis is seen in X-linked A-gamma globulinemia. Burkholderia capacious, Aracia marsans, Nocardia, Staphylococcus, and Aspergillus, especially the catalase positive organisms, are seen in chronic granulomatous disease. Neisseria meningitis is especially common in the terminal complement defects. And comes the infection pattern, where recurrent mucosal lesions involving the respiratory or gastrointestinal tract is seen in the humoral immunodeficiencies and opsonization defects. Skin deep abscess suppurative lymphadenopathy is common in phagocytic and antibody deficiencies, and recurrent gingivitis, oral ulcers in the phagocytic defects, and recurrent chronic mucocutaneous candidiasis, stomatitis seen in T cell defects and phagocytic defects. So recurrent pharyngitis and tonsillitis are usually not the classical symptoms of the PIDs, but can be seen in some autoinflammatory syndromes. So the physical examination, the main points to concentrate are in the skin, where we have vitiligo alopecia, especially the signs of autoimmunity and also oculocutaneous albinism, sparse and hypopigmented hair where we have the syndromic PIDs, and eczema, severe dermatitis and erythroderma in Omen's syndrome. Recurrent abscesses and recurrent abscess cellulitis can be seen in HIES. So oral cavity mainly concentrate whether there is candidiasis, periodontitis, and is there a tonsils. Extremities, mainly the clubbing to look for the bronchiectasis changes after the antibody defects, and arthritis seen with many of the syndromes like VAS and hyper IgM syndromes. Endocrinologically, we have to see hyperparathyroidism and growth hormone deficiencies to rule out Dijot syndrome and X-linked agammaglobulinemia. In hematological findings, autoimmune hemolytic anemia is seen in CVID and B and T cell defects and ALPS. Thrombocytopenia can be seen in Wiskott-Aldrich syndrome. Neutropenia, especially in hyper IgM syndrome, VAS, CGD and SCN. Lymphadenopathy in the ALPS. So in general, we should see either it is unusual, either unusual number of infections, site severity organism, or an unusual growth and weight loss. To identify, then next step will be to identify the clinical syndrome according to the classification of immunodeficiencies given by International Union of Immunological Societies. Here the T and B, they have classified into 10 different categories with subcategories. So I'm not going to the details. So features of the combined immunodeficiencies will be early in the child will present the early infancy, that is less than 6 months. Systemic illness after vaccination, especially the live vaccines like BCG will be seen. Unusual life-threatening complications after infections with benign viruses. Chronic mucocutaneous candidiasis. Transfusion-associated GVHD can be seen. Reduced lymphocyte counts for age. Low levels of immunoglobulins. Absence of lymph nodes and tonsils, especially absence of thymus. Chronic diarrhea, failure to thrive, and recurrent infections with opportunistic organisms. So this is a 6-month-old child who presented with fever and dyspnea. The child had BCG, there was an abnormal reaction at the site of the BCG, which is very unusual for a 6-month child to have this. And when we evaluated the case, there was, I don't know whether it's visible or not, there was AFB strain in the marrow showed many BCG bacilli. Unfortunately, we lost this child in a few days because of disseminated BCGiosis, and we couldn't proceed for transplant. This child was of severe combined immunodeficiency. So features of humoral immunodeficiency, usually it presents after 6 months of age when the maternal antibodies start waning, and recurrent bacterial infections of the upper and the lower respiratory tracts are present, and recurrent skin infections, meningitis, osteomyelitis, and secondary to encapsulated bacteria. Paralysis after vaccine, especially vaccine-derived poliomyelitis, gives a clue of humoral immunodeficiency. Reduced levels of immunoglobulins, autoimmunity, and lymphoreticular malignancies can be present. Features of phagocytic disorder, there is recurrent skin abscesses, cellulitis and osteomyelitis, oral gingivitis and mouth ulcers, fungal infections, especially with Candida and Aspergillus. Specific features in leukocyte adhesion defect is the omphalitis, delayed separation of the umbilical cord, poor wound healing, non-healing white skin ulcers, and labs showing neutrophilic leukocytosis even in the absence of the infection. So this was a 2-year-old child who presented with a wide gaping ulcer and infection of the ethmoid sinus and the frontal sinus. So this child was diagnosed with leukocyte adhesion defect type 1, and after treating with IV antibiotics and transplant, the child is better now. This is another child who was diagnosed with the chronic granulomatous disease, and he's also doing well after transplant now. So features of natural killer cells and cytotoxic T cell defects. Recurrent herpes virus infection seen in NK cell defects. HLH can be a clinical presentation of the patients with both NK cell and cytotoxic T cell defects, and X-linked lymphoproliferative disorders can be seen in cytotoxic T cell defects. So features of complement deficiency, late complement deficiencies lead to meningitis, especially with the Neisseria organisms, and arthritis, gonococcal arthritis, and pneumococci. Early complement component deficiencies can lead to SLE and autoimmune disorders. So features of immune dysregulation, persistent non-malignant lymphoproliferation along with hepatosplenomegaly and cytopenias, persistent diarrhea often starting in early infancy, eczema and early onset endocrinopathy, especially diabetes. So this was a child who 2 years male child who presented with fever, and on examination there was hypopigmented hair and lymphadenopathy and hepatosplenomegaly. There was cutaneous albinism, and on peripheral smear showed this kind of findings. And the hair, the microscopic examination of the hair showed this kind of findings. We diagnosed him as chronic granulomatous disease, and the child is doing now after transplant of 1 year now. So investigations for PID, the small things can give a big clues, like CBC can give a clue in case of absolute neutrophil count low in severe congenital neutropenia and cyclical neutropenia, autoimmune neutropenia. Absolute lymphocyte count less than 2000 in the cord blood and less than 1500 in infancy, suspect SCID, and absolute monocyte count is low in monomax syndromes. So evaluation for a B cell defect, the initial screening test will be to go for levels of the serum immunoglobulins. First of all, rule out steroids and protein losing enteropathy before that. Immunoglobulin should not be measured after the blood FFP or the IVIG. Coming to the classification of PIDs, mainly antibody dependent PIDs, it depends upon what kind of immunoglobulin is low. Then we can go for isohemagglutinin titers, that is the antibodies to the A and B red cell antigens. It may be absent physiologically before 2 years of age and always absent in AB blood group. So we have to take care of these findings before interpreting the results. Measure the antibody titers to the vaccines, especially for the protein antigens and polysaccharide antigens. For protein antigens, we measure diphtheria and tetanus and HEP. And for polysaccharide antigens, we measure the anti-pneumococcal antibody titers. So evaluation of the T cell defect. So any infant with lymphopenia, T cell enumeration by flow cytometry is required. Normally, CD3 positive T cells constitute more than 70% of the peripheral blood lymphocytes. In a normal infant, more than 95% of the T cells are naive T cells, whereas in a child with severe combined immunodeficiency, most of the T cells are the memory T cells, which are usually transplacentally acquired from the maternal side. So evaluation of the phagocytic cell defects. Recurrent infections with staphylococcus and gram-negative bacteria, catalase-positive organism, then suspect there is some phagocytic cell defect. Screen with neutrophil respiratory burst after stimulation with Forbol ester stimulation, that is dihydrorhodamine test. Usually the normal neutrophils will show the fluorescence, whereas the neutrophils affected with CGD will not show the fluorescence. Leukocyte adhesion defect, flow cytometry can help with this. When the antibodies are used against the CD18 and CD11 in leukocyte adhesion defect 1 and to CD15 in leukocyte adhesion defect 2, leukocytosis can persist in between infections, and this gives the clues to the lab. Flow cytometry, it can also, flow cytometry can be also used for lymphocyte subset analysis, and apart from that, many functional analysis like neutrophil oxidative burst, NK cell cytotoxicity, intracellular cytokine production, and cellular signaling pathways like phosphor and STAT analysis. Coming to the genetic testing, these genetic testing have made our job easy because many of the tests are not available rapidly in all the centers, but genetic testing has quite become easy. Whether we go for the targeted sequencing, NGS for PID, or the whole exome sequencing and whole genome sequencing in difficult cases where we do not get an answer and still there are high index of suspicion. And the Sanger sequencing, when a specific gene is already known in the family and we suspect the same immunodeficiency in the child. So treatment, mainly we have to treat the infections aggressively with the empirical antibiotics. Live vaccine should be avoided, not only in the child but also in the family members, especially the oral polio vaccine and the nasal influenza vaccine. Apart from that, MMR and varicella vaccine can be given in the family members. Irradiated and leukodepleted blood products should be used to avoid transfusion-associated GPHT. IVIG replacement for antibody deficiencies should be given. and allogenic stem cell transplant and gene therapy are way forward in many PIDs. So the take-home message is we require a high index of suspicion. So history and relevant clinical findings and appropriate screening tests and further investigations can be crucial in the diagnosis of PIDs. Early diagnosis and prompt treatment can save many lives. And genetic counseling should be given to all the children who are, for all the family to further take forward the family. Thank you.
Thank you, ma'am. I think you have covered each and everything in primary immunodeficiency. So any question from house?
We have a patient admitted with us at present. This child presented at 6 months of age with autoimmune hemolytic anemia. With hemolytic anemia, later on diagnosed as AIHA. This was a little bit refractory to treatment from 6 months. So NGS was done, that showed a homozygous PNP deficiency. PNP mutation is there. But there's no history of recurrent infection, growth is normal. So my question is that when a child will present with an autoimmune manifestation, basically when to suspect if there is, this was a chance detection. If there is no history of recurrent infection, growth failure, should we suspect for growth deficiency? Second is how this child should be managed, a transplant is an option or not?
Madam, especially in children who have, even children who have ITP, who are usually we see chronicity mainly in the adults, not in the pediatric age group. But when there is a constantly refractory ITP, we have to rule out immunodeficiencies, especially when the child is a male child, the younger the age group. We have to rule out immunodeficiencies. In these kind of settings, directly going for an NGS for PIDs can help. And in any PIDs where we get a mutation which will be detrimental and where the child can get recurrent infections, those kind of PIDs we should not wait for the manifestations to occur. It is always better to go for the transplant early when we suspect that this child may get a life-threatening infection in the future.
Yeah, just wanted to say that current terminology now tells us that it is no longer PID. We use the word inborn errors.
Inborn errors of infections.
And the reason for that is many of these genetic basis is being implicated in autoimmune diseases.
Yes.
So the presentation is like an autoimmune disease in children, not necessarily as an immunodeficiency. It's an error of immunological thing. That is what the current concept
yes, sir, sure.
has happened.
The IUS classification itself says it is IEI, not a PID.
Not just an immunodeficiency. It's an error, so that this autoimmunity and immunodeficiency come hand in hand.
Yes, sir. Because that was the given topic. I spoke as PID.
So that's why, madam, autoimmune conditions are also getting increasingly a part of this spectrum.
Yes, sir.
Thank you. Now session can be ended.
Thank you so much, ma'am, for covering up such an extensive topic with a couple of case scenarios as well. I request the chairperson to join the speaker for a photograph. Thank you, ma'am and sir. Let's move on to the next session for the evening.
Yes, yes. One last question to her. What is what is the current status of dinitro blue tetrazolium test?
It's being done in some centers. But I'm not sure where it's available in this part of the country. As a resident in Sir Gangaram Hospital, New Delhi, we were doing DHR in our lab. Right now where I'm working, DHR is not available, but still we go directly with NGS in those kind of cases. I think any pathologist can answer this better.
I think for the diagnosis of CGD, this is a wonderful test. Very little, like hardly costs anything, but lot of information you can get. NGS is far away. NGS is not in the realm of many centers. But here, if you have a clinical suspicion of CGD, this test is extremely informative.
Yeah, any centers where flow is in-house, it is easy to do this DHR test. Okay, sir. Thank you.
Thank you once again, ma'am, for answering the questions gracefully. Without further ado, let's move on to the next session, which is a panel discussion, for which may I call upon Dr. Dinesh Burani, sir, DM in Hematology from Christian Medical College and Hospital, Vellore, currently Director of Hemato-Oncology and Bone Marrow Transplant at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Round of applause for sir, please.
This is a panel discussion, so I'll invite my panelist, Dr. Dinesh Kumar Sinha, Professor, Department of Radiation Oncology, IGIMS, Patna. Dr. Rishu Vidyarthi, Assistant Professor, Department of Hematology, AIMS, Patna. Dr. Dev Malya Bhattacharya, Senior Consultant, Department of Hematology, Apollo Hospital, Kolkata. Dr. Avinash Upadhyay, Senior Consultant, Department of Medical Oncology, Mahavir Cancer Sansthan, Patna. Dr. Ketan Nathani, Clinical Hematologist, Paras HMRI, Patna. पारस वाला ही एब्सेंट है, ये कैसे? ऑर्गेनाइजर ही गायब है, फिर कैसे काम चलेगा? Okay. So I wasn't sure with the whole Hodgkin's lymphoma what panel discussions we do. So I decided to restrict to the treatment part, and I thought we will review the recent guidelines. The advantage of NCCN guidelines is that they are updated every year. You get one or two versions of every year. So I thought we at least should go through, at least I can go through them and I can memorize them. So that's the advantage. So the Hodgkin's is divided into, say, the early stage. Early stage is divided, is a stage 1A, stage 2A, and 1B. That's the early stage into the favorable and unfavorable. 2B and 3 and 4 are the advanced stage. And above 60 is the elderly age group. So the elderly group should be treated differently irrespective of the stage. And we have a NLPHL. So I thought, and then there is a relapse. So few things we should be discussing. So we'll have a Hodgkin's lymphoma discussion. But before that, who will be the next Chief Minister of Bihar? Panel's opinion. Avinash.
I believe this time RJD might come, sir.
Tejasvi Yadav. What's your opinion?
Mamata Banerjee.
Mamata Banerjee. You're not giving your opinion in spite of not being into Paschim Bengal, huh? Huh? No. The next Chief Minister, you're saying? No, I'm asking the panelists. They are the experts on that. Huh?
I'm not sure, sir. Maybe Nitish Kumar. I'm not sure. Sir, welcome.
I think I always say
no,
that.
Not your opinion. Not your what you want to have.
Yeah.
What's the opinion of the state?
Yes, so I always say that this time in election, this is the hottest topic. Who will be the next Chief Minister? So maybe Sri Nitish Kumar or maybe Samrat Chaudhary.
Maybe?
Maybe Samrat Chaudhary.
Okay. So I think there's the three, two and one. One is the out of the range. Anyway, so Dr. Dinesh, can I say, if you can explain it, if you can take it through us. It is a learning exercise we are treating. So there are a few regimens. The ABVD is the most common regimen. Now things are changing. The brentuximab is available, nivolumab is available. So I thought the stage 1A and 2A, the favorable, Early stage is divided into favorable and unfavorable. I'll request you to take us through the favorable and unfavorable.
Yeah, of course. So in favorable 1A or 2A, we start with that is classical Hodgkin's tumor. Start with AVBD into 2 cycle and restage with PET-CT. If they in PET-CT it's complete dual 1-2, so that is they are offered the radiation therapy of 20 gray at 1.5 to 2 gray per fraction. And if there is dual is not complete response, then again we go for the AVBD to up to 2 cycle and then again restage with PET-CT. If complete response, then we go up to the 30 gray of radiation. So this is in favorable group, and in
unfavorable group.
So unfavorable also the same 2 stage and 2 cycle, then restage with PET-CT, and so in unfavorable we can go up to the 4 cycle to complete AVD. That is AVD after 2 cycles there is no bleomycin, so we can go up to the 4 cycle of
we
AVD.
have to go through the NCCN.
Yeah, of course. So
yeah, so if you're cutting down the bleomycin, then it's a 4 cycles.
Yeah.
And so either 4 cycles of ABVD followed by radiation, or 2 cycles followed by 4 cycles of ABD. Yeah. And if it is a 4 and 5, then you have to investigate and escalate it. Then depends on that. There's one more is there, I think. This is the newer drugs which have not been. If you see the NCCN guidelines, wherever is a category 1, that's the best evidence available. And wherever nothing is written, that's a 2A. So is not that strong evidence. So these are the new trials, which was a nivolumab AVD 4 cycles followed by 30 gray radiation. Favorable doesn't have the newer drug trials so far, which is a Nivahal trial, and with the brentuximab, the same 4 cycles followed by 30 gray of radiation is a breach trial. And then there are a BRICAD trial, which is you can give 2 more cycles of BRICAD. So I mean the recommendation is 2 cycles followed by radiation of 20 gray in favorable, probably 4 cycles of ABVD followed by 30 gray of radiation in the or you can give 2 in the unfavorable, or give 2 cycles if you have adequate response, 4 cycles of AVD to total 6 cycle. And then there are some if you are a 4-5, then you have to be investigating. And the newer drugs are making the way. I think there will be more trials with the newer drugs. Still in the early stage favorable and unfavorable, the practice of using the newer drugs have not come, and the newer there are no large trials to change. There is no randomized trial to change the practice so far. But I expect, like in the higher stage, you will have the sooner in the early stage also. This is stage 3-4. Can I say someone to Dr. Ishu, advanced stage, can you take us through the, so if you see a category 1, there's a good evidence, that's probably the best evidence, and if there is no category 1 written, that's a 2A recommendation, not that strong. So please take us through the advanced stage treatment.
So for advanced stage Hodgkin's lymphoma, stage 3, stage 4, as per the NCC in 2025, the category 1 recommendation are nivolumab with ABVD or PET-adapted BRICAD therapy. Now the evidence comes from the recent trial that nivolumab and AVD is superior to brentuximab in terms of PFS and also safer than brentuximab. We have enough data from the SOC trial. And the second option is
this was a Nivo AVD versus brentuximab AVD. Yes.
And second is PET-adapted BRICAD therapy. Again, it was discussed in detail yesterday. The trial was HD21. BRICAD is safer than escalated BACOP, and the PFS is also better than BACOP. Now, if we don't have access to nivolumab or nivolumab is contraindicated, then there are 2 options, brentuximab with ABVD or ABVD. Now, we have data from Echelon 1 trial that BV-AVD is superior to ABVD in terms of PFS and OS, with little bit of toxicity, neuropathy and myelosuppression that can be managed by GCSF prophylaxis. And when nothing is option, the best option is ABVD. We go for 2 cycles of ABVD followed by an interim PET. If it is negative, we omit bleomycin and go for 4 cycles of AVD. And if after interim PET, if the PET dual score is still 4-5, then we try to escalate. If we have brentuximab, then maybe brentuximab-based therapy.
So I think that I mean, what you're saying is right. The practice is changing. If the finances permits, now both the drugs are available. Nivolumab and brentuximab are available. Even the ABVD is a category 1, so it has not changed. I mean, if you don't have availability of these 2 drugs, and these are the 2 new trials, which was a SWAG trial and the German trial, which came in the last year. They both are in the upfront. One is a German approach, Bricad versus a BICOP. The other one is brentuximab AVD versus Nivo AVD. So I think
I just wanted to ask you, what is your practice, sir, in this category, stage 3-4? Like there are 3 category 1 recommendation: Nivo AVD, BRE CAT plus GC7, and then brentuximab AVD. What are you practicing? I
think the Nivo AVD is the best. If you don't have any contraindications. So if you have a contraindications or the cost is a prohibitive, then we are still using ABVDs. I think that because of the financial reason, most of the people are still using ABVD. But wherever it is available, Nivo ABVD has changed the practice.
Sir, what dose of Nivo you use? Is it low dose?
It's the same as trial. Is a 240. Is a fixed dose 240 trial every 2 weeks.
There are some centers who are using low dose Nivo. That's why I'm asking.
That's not the part of the. We don't have a big publication. So either you use a full ABVD or use a full dose of Nivo. The Hodgkin's is a curable disease. Should not relapse. If you relapse, you have to go through the transplant and other things. So you should maximize the chances of first CR. So rather than compromising on this one, which is not category 1 recommendation, I will not. My recommendation will be not to compromise on the dose. Rather, you use the ABVD. Do a PAT2. If it is a CR, then you are on the right track. If you are not PAT negative, then you should escalate. Next slide is there. So you want to say about this is the same thing, which I think there's if you are on the dual score 4 and 5, and BV AVD is for the certain options. Dr. Deb Malia, this is a nodular lymphocyte predominant Hodgkin's lymphoma. Can you just take us through this whole thing?
Yeah, this is different from classical Hodgkin's lymphoma. It behaves most like a non-NHL, low grade or indolent variety. So the treatment depends on the symptoms also. If there is no symptoms, so we can observe like follicular lymphoma. And if there is any stage 1 disease or only single lymph node, you can operate this also, or a localized radiotherapy ISRT to that place. And if there is symptoms and stage 3 or stage 4 disease, we can proceed for chemoimmunotherapy like rituximab based protocol, R-CHOP, RCPP, even B plus R has also some regimens. And another thing is, because of the name of Hodgkin's, it can be given RAVVD with alternative rituximab. So
the name is likely to change in the next classification. There's going to be more of a non-Hodgkin's rather than Hodgkin's. So the behavior is like non-Hodgkin's. It is combined till now with the Hodgkin's, but with the next classification, there are some suggestions it will be moving towards a non-Hodgkin's. The treatment is similar to the non-Hodgkin's. RABVD also is one of the options. So rituximab is required. In the localized treatment, observation, radiation, or rituximab alone. If there is high stage disease, observation, or treating with the RABVD or R-CHOP. These will be the 2 common therapies for the treatment if the treatment is required. Any questions or any suggestions, anything which we want to discuss about? Early stage, favorable, unfavorable, NLPHL. We'll move to this is the recommendations for the after the completion up to the 5 years. So you need to follow it up every 3 to 6, preferably 3 months, every 3 monthly for 2 years, then 6 monthly for the 1 year, and then annually. And you need to vaccinate, especially the elderly population. You need to do all these tests. And I think the reproduction counseling should come before because many of this is a bimodal, so the fertility should be discussed before you start the treatment. And you don't have to do imaging. If you have done an end of treatment, usually you don't have to do it. If you think necessary, says every 6 monthly for first 2 years has been recommended. But majority of the patients we are not doing surveillance scans into the relapse. I'll request Dr. Avinash to take us through the relapsed Hodgkin's.
So once relapse of Hodgkin lymphoma has been confirmed, we do biopsy to confirm the diagnosis. So rebiopsy has to be done whenever there is a suspected relapse.
Important is you just don't do them in doing a PET scan and starting the treatment. So the biopsies, we would like to re-emphasize as a group that we need to biopsy it. We need to prove it as a
Hodgkin
disease.
Yes. So if it is positive, then if we have done already a PET scan, it's fine. We have re-staged, we have done biopsy. The important thing is if we have not used immune checkpoint inhibitors upfront, then better we can go ahead and we can give immune checkpoint inhibitors along with the salvage.
It becomes very important to have a checkpoint inhibitor at the first relapse if you have not used it earlier.
Yes. So we can either combine immune checkpoint inhibitors with salvage chemotherapy, which we were using like ICE or GDP. So we can combine, or we can, in our setting, we are just giving salvage chemotherapy followed by autologous stem cell transplant. If it is available, we can use immunotherapy like nivolumab, or we can use brentuximab also along with chemotherapy, or nivo-brentuxi also we can combine and we can salvage, because these combination will increase the chance of getting CRs and overall response rate will be higher, and post-transplant the outcome might be better. So we can use the newer molecules.
So the transplant is must. If you don't use a transplant, the 5-year survival is less than 10%. That we should keep in mind. If you have not used the checkpoint inhibitors earlier, the checkpoint inhibitors with chemotherapy is a salvage chemotherapy salvage regimen followed by transplant. Previously, the results, the long-term outcomes were around 50%. With the use of checkpoint inhibitors plus chemotherapy or plus brentuximab has led to the overall the long-term survival up to 80%. So even the person who is relapsed post therapy has or refractory disease has a very good chance of cure with the newer drugs.
I wanted to ask you, sir, just this brentuximab post-transplant maintenance, sir.
So there is a high-risk population where you have an extranodal relapse. You have a relapse within 12 months. And there is one more criteria is there. So if you have in that category, then brentuximab maintenance every 3 weeks, starting around 45 to 60 days, for up to 16 doses. The average doses used was 8 to 9. If you have a complication, you have to stop it. And that Athens trial has shown the risk. So if you are a high risk, then we should consider for the post-transplant maintenance. So someone who has relapsed, checkpoint inhibitor or the brentuximab becomes very important, has to be tagged with the chemotherapy and then followed by transplant. Definitely it has changed the outcome. We are using it. We have one person had a thesis and we have shown a good data. We are going to publish about that. Next, you are the latecomer, Ketan. So how do you treat elderly? So the most important, the difficult part of Hodgkin's lymphoma is above 60. You have a bimodal this thing, and the people who are above 40, 55 or 60, ABVD is not an answer. We many times compromise with the efficacy. It's a highly curable disease, toxic regimen for this age. How would you go?
So sorry I came late.
Not only cover this, you need to cover as a whole the treatment of.
Sir, traditionally Hodgkin's lymphoma has a bimodal age distribution, but because of the comorbidity status, we have very few limited options for the elderly. We cannot give anthracyclines because they have the cardiac issues. They will not be able to tolerate. In my practice, we have used COP regimen, and patients have shown some response.
Anthracycline may not be someone who has a cardiac disease, you don't, but CHOP you are giving anthracycline. So it's
so
not
COP.
No. So you're not giving CHOP?
Yes, sir, not giving CHOP. I'm giving COP. Yeah. So.
These are curable diseases. You have, we should, people who can't use anthracycline, then you have etoposide, gemcitabine or lipodox. But you need to supplement with something.
Yes,
you cannot. Then your the efficacy of the regimen goes down. Okay.
And so now, if there is no financial constraints, there are options we have for the elderly patients. That is the Nivo AVD. Nivo AVD, it has shown a good response. 2-year progression-free survival and overall survival has shown good response compared to BV AVD. But in my personal practice, I have not used Nivo AVD, sir.
How are we treating the elderly? I'll ask everyone. If you got a 65 years Hodgkin's lymphoma, Avinash.
Sir, I am using actually Nivo, like low dose 40 milligram ABD. I have treated like almost 4 or 5 patients. All are doing very good. So I agree with you. Like we should not compromise on dose, but since there was,
you
fine,
should
so
not.
I like
Yeah, I mean, elderly, because you are compromising. If you're
Yes,
not giving Nivo AVD, say, like he's saying, we cannot bleomycin. You cannot complete the full dose. So most of the older patients we are compromising. Ideally, we should not. So I mean, that's why there is a struggle in the treating the older patients in the Hodgkin's lymphoma. So rather than giving ABVD, giving a low dose Nivo AVD might be a okay thing in the elderly age group.
Same Nivo AVD.
But we don't have a data. I mean, we don't have a published data on the.
We're trying with Nivo AVD only.
Nivo AVD.
And very poor people only AVD.
Say it again?
Those who have many financial constraints only AVD.
From the beginning, only AVD.
Because they cannot afford nivolumab, those group of people.
Issue?
So same low dose nivolumab. If patient is not affordable, then AVD or maybe single agent brentuximab if available. We can try few cycle of single agent brentuximab as well.
Some people can be treated with the ABVD also, provided you do a lung function test and then keep doing it in between. So bleomycin or giving a 2 cycles of ABVD and then going to the AVD also will be more rational. But the risk is there.
That's I was telling that if the pulmonary function test and cardiac function is okay, then start with ABVD and then followed by ABD.
So 2 cycles of ABVD, someone who is fit enough and no lung comorbidities with the lung function test, you can do a 2 cycles followed by AVD.
Yeah,
that's also one option if Nivo AVD is not available.
Yeah, of course.
Even a brentuximab AVD also can be a one option if the finances permit. So I think it's very difficult to treat it without compromising the efficacy. The Nivo AVD becomes a good option. Still here you have to be considering about the adriamycin. So you may have to change it to something else if the cardiac issues are there. Otherwise, Nivo AVD or brentuximab AVD or even a ABVD 2 cycles followed by AVD. Any questions or any? I'm scared of the bell, which is the. Yes.
There are studies that AVD has comparable result with ABVD in elder population.
I'm not aware of
As
that. You can put a light on that. I mean, you can show the light on. There's no fix before this Nivo AVD. There was no. I think the majority of the patients will now be on the Nivo AVD if there are no financial. That's it. Thank you.
Which is what is your suggestions regarding nivolumab maintenance following therapy? Is there any role of nivolumab maintenance in Hodgkin's?
There is a trial with the Pembro, 8 doses of Nivo or Pembro post the high risk group. There is a similar kind of efficacy. It's a small phase 2 trial, but I mean, like now if you get a Pembro, if you pay for 5, you get a 10. You can get a whole thing. So we are using Pembro AVD. I mean, someone who relapses, we give a Pembro GVD and then followed by Pembro maintenance. We have done that too. So I think the maintenance, if you have a possibility, you should give it. Brentuximab is recommended. There is a trial with the Pembro. We are using some patients.
Sir, couple of questions. So regarding CPI, so checkpoint inhibitors.
Make sure I finish before this bell.
Is PET scan and interpretation.
If you are using, see the Nivo AVD, good part is you are not changing the therapy at PET 2. The PET will be positive. Even the end of therapy, you need to prove it by the biopsy. So Nivo AVD, if you are give it up to the 6 cycles irrespective of the interim PET. Because you will have a false positivity. If you are suspecting a progression, then you need to prove with the biopsy. So you do a PET scan, disregard if you think the patient is responding. If you think the patient is not responding, then do a biopsy.
And for NLPHL or NLBCL, what do you do? How do you approach at relapse?
NLPHL?
Relapse.
RIs followed by transplant if it is early relapse. So if you are asymptomatic, observation. If you are planning to treat it, then probably the R salvage therapy followed by autolog. If it is early relapse, if it is a late relapse, you can use the same therapy.
Same kind of therapy. So ABVD, RCHOP, those kind of things can be used.
If you have done a RCHOP, do a RABVD. If you have done a RABVD, do a RCHOP. So change it from one to another.
So salvage, ice, DAP, they are not
no. If you have early relapse within a year, I would suggest to go for salvage rather than, if it is a late relapse, then you can switch. Not for the, because the majority of the drugs are the similar. So there's no point in going for the similar kind of drug.
Yeah, is there any role of radiotherapy still in Hodgkin? Suppose a bulky disease.
Very much role for early stage disease.
Okay, so a bulky disease, the confusion arises, then PET-CT CMR. Then whether there is any need of giving radiotherapy in the bulky disease
Advanced
patient.
stage, no role. So this Nivo AVD, very few patients had required radiation.
Even in early disease, the relapse is if we give the radiation, then we halve the recurrence. So recurrence-free survival is more if we give radiotherapy in early disease.
Early stage, there is a proof that 10 years data of the H17 or trial is there. So people who have escaped the radiation had an inferior outcome.
7% versus 3%.
Very important for the early stage
in
disease.
Meta-analysis.
If it is in the chest or somewhere, the young age, you want to skip it, then there are the recommendations are there to do without radiation. But the chemo with the radiation is more effective than the chemotherapy alone. So there is a slight difference into the PFS. The overall survival is the same.
And OAR is there, so if we achieve the OARs in immune medicinal disease, we can give the radiation.
Yes. That's it. Thank you. I thank panelists. I thank Avinash for giving me the opportunity. And we finished before time. Thank you.
Thank you so much, sir, and the esteemed panelists for this discussion on whatever drugs to use for Hodgkin's lymphoma. Next up, we have the talk on update on aplastic anemia. For that, we have for the chairperson, sir, Dr. Sudhir Kumar, sir, Professor, Department of Medicine, IGIMS Patna. Sir, can we please have you on stage? And Dr. S.C. Jha, sir, Senior Consultant and Clinical Hematologist, Mithila Hematology, Patna.
So the next topic is about aplastic anemia, and we all know how important this disease is. And recent years, the prevalence and the incidence of this disease is also increased due to various causes. So I invite Dr. Rajiv De, who is a well-known speaker from Kolkata, to deliver his talk on aplastic anemia.
Good afternoon, everybody. I express my regards to especially Dr. Avinash to give me the opportunity for talking on update on aplastic anemia, especially in front of him, because Avinash is an stalwart in aplastic anemia. And I am not expert on aplastic anemia, but as he has given me this topic, so I will try my best to give you some updated on aplastic anemia. We know the definition of aplastic anemia, which is characterized by the peripheral blood pancytopenia and bone marrow hypoplasia, and for residents, they always do the clinical examination. There shouldn't be splenomegaly. The bone marrow biopsy is important, so there shouldn't be any abnormal infiltrates or marrow fibrosis. And residual hematopoietic cells should be normal in morphology. That is the diagnostic criteria. And these CAMITA criteria, all residents as well as consultants should know, because there should be less than 25% cellularity, and ANC should be less than 500, platelet count less than 20,000, that is a manual platelet count. By automated platelet count, by the recent classification, it has been less than 60,000. And it is severe aplastic anemia. If ANC is less than 200, it is very severe aplastic anemia. As far as epidemiology is concerned, we know that in Asian population, we have around 2 to 3 times more aplastic anemia. The reasons may be different, use of pesticides, our genetic structures, those things. There is very little organized registry for aplastic anemia in India. One is on the way of preparation. So we may have a clear-cut idea of our aplastic anemia burden. If we consider the pathophysiology, then there may be a lot of reasons, maybe cytotoxic drug, radiation, those things, pesticides. There can be autoimmune, idiopathic, and there can be a telomere disease or inherited bone marrow failure syndromes. But today I will focus mainly on the autoimmune aplastic anemia, that is a T-cell mediated destruction of the stem cells. So this is the pathophysiology, where the T cells mediated destructions of stem cells are there, basically CD8 directed cytotoxic T cells, leading to production of the pro-inflammatory cytokines, which ultimately causes the apoptosis of the stem cells. And this is the most recent comprehensive guideline, that is BJH guideline for the aplastic anemia diagnosis and management. All of us who treat aplastic anemia should read it. Now, as part of that guideline, there are these diagnostic tests, which you all know: blood count, reticulocyte count, blood film examination, vitamin B12 deficiency, so to rule out, and chest X-ray, ultrasonography, all these things are there. Bone marrow biopsy, aspiration, obviously. But in addition, there are 2 more investigations, which is updated in this version. That is a genetic test on peripheral blood or bone marrow. And NGS plays a very significant role, because often we see, especially in our population, the outcome of IST is not that good. So maybe some germline mutations are there which can be picked up by next generation sequencing. And other is, that is the telomeropathy, because many of our aplastic anemia actually are because of telomeropathy, which is not identified. We treat them as an immune-mediated aplastic anemia, so that can be diagnosed by the special test. So that we need to keep in mind. Then once it is diagnosed, how to manage? One, we can repair the bone marrow, we can change the bone marrow. We can repair the immune system, we can try to change the immune system, can replace by new immune system. So these are the 2 major treatment options. One is stem cell transplant and one is IST, immune suppressive therapy. And immunosuppressive therapy, whom to treat? Non-severe aplastic anemia, if it is asymptomatic, no need to treat, follow-up. If it is symptomatic, transfusion dependent, then we need to treat, and there lies the guideline, that is the indication of treating aplastic anemia, that is ATG with cyclosporine along with L-trombopag as a first-line therapy for severe and very severe aplastic anemia in absence of a MSD or matched sibling donor. So matched sibling donor transplant is the first. If it is not there, then. Now we, later on we'll discuss that now this IST is being marginalized by the efficient execution of haplotransplant and alternate transplant. So this is the algorithm which we all know: less than 40 donor available, do transplant. If donor is not available, we can do IST. But now we are doing transplants up to 50 years, maybe more than 50 years also. If the performance status is good and matched sibling donor is available, we can do transplant. Now, in absence of matched sibling donor less than 40, what we will be doing? We can do IST. At the same time, we can look for haplo, because our haplo data is improving day by day. So this is, although this is the BJH guideline, now there is a significant role of haplo here also. This is our Indian guideline for aplastic anemia published in 2023. There is no mention of the alternative donor transplants. So, but nowadays we need to consider that. Immunosuppressive therapy, we know that it is an ISTS, that is ATG, cyclosporin, and L-Trombopag. The reason being we have to prevent the cytotoxic T lymphocytes, and we also need to boost the stem cell function, because sometimes IST doesn't work because of reduced amount of stem cells. So that stem cells can be stimulated by use of L-Trombopag, and nowadays romiplostim also has a role. So that is the combination which are producing excellent result. This is the first trial in NEJM 2017, L-Trombopag added to standard IST, and it showed as 6 months outcome overall response as high as 94%. And it has been seen that with time the performance improves, and data who was censored at transplant, the outcome is unimaginable, 99%. So then there is a prospective trial, race trial, published in NEJM only in 2022, and it again showed as early as 3 months median time, the IST showed a response. And complete response, the complete response is as high as 52%. So it is a significant changes in the field of IST. These are long-term outcome published in Blood. Again, the repetition of the same outcome, that is near 90% response rate. Romiplostim also has got a role, and although it is not came into recommendation, but there are studies which is showing significant improvement, especially the hematological improvement, both hemoglobin, ANC, as well as the platelet count. It also works in pediatric population. At 24 weeks, the outcome of complete hematological response 70%. There are some Indian data also which showed reasonable improvement with romiplostim, single agent romiplostim. But the problem of IST is they can cause a clonal evolution, which is mostly we overlook. And the percentage of clonal evolution may be as high as 15%. Although high-risk clonal evaluation leading to MDS or AML is usually around 5%, but the overall clonal evaluation may be 15%. So in this Blood article, it has been shown that 5.7% of all treated patients with IST plus L-Trombopag, they develop clonal evaluation, and surprisingly, the relapse remained a concern. As high as 39% patient relapsed. The overall survival is fine because all the relapse cases ultimately salvaged by transplants. But the thing is, if we only rely on immune suppressive therapy, there is only around 60% chance to get a long-term cure. And this is an Indian study done in Vellore, and which showed, again, there is high risk of clonal evaluation. 4.3% clonal evaluation was there, and relapse rate was 22%. So the IST, if we consider only overall survival, the picture is very bright. But if we consider the this relapse-free survival or event-free survival, it is not that bright. So still we have a role of transplant. So risk and complications of IST, which I already mentioned. So there lies the importance of stem cell transplant. And over the years, with gaining experience, the outcome improved. Now it is near more than 90% patients are responding. This is a comparison of upfront IST versus matched sibling donor transplants, and this is the real world data and retrospective data, and it showed that around 71% response to IST and around 90% response to transplants. And the outcome is also, this is an Indian study in the pediatric population, it is the cumulative data, and it showed the 2-year overall survival of the entire cohort after transplant was 93%. And this is the protocol commonly used, flu-cy ATG. This is the recently, not published, unpublished data. So I express my regards to Dr. Biju George for that, sharing this data. So 401 patients, and their outcome was 85% patient engrafted, and graft failure was around 4%, and acute GVHD 23%, chronic GVHD 38%. And 5-year overall data was 66.7%, which is reasonable and realistic. So with transplant, the response rate as per the 5-year long-term response rate around 67%. And now they have shown that the ATG is actually associated with more infections and more clonal abnormalities. So the Velour group now just omitted ATG from the Flu-Cy protocol. So now they're using Flu-Cy, and their outcome is better compared to Flu-Cy ATG. So 5-year overall survival was 75% and 73.4% actually. And depending on the risk status, these are risk status, more than 20 transfusions. So we need to do transplant as early as possible, more than 3 months after diagnosis, major organ bleed, previous ATG. So in absence of these risk factors, the outcome is near 90%. If those are there, the outcome is around 50%. So age plays a very important role, because if we do transplants even in the earlier age, less than 40, 64% response rate. Less than 15, around 80%, but more than 40%, the result is around 50%. So, again, age plays a very important role as far as the outcome of IST as well as transplant is concerned. So it is the same thing. So I mentioned all these things. So impact of chronic GVHD, it is not associated with the overall survival. So this is all the studies in aplastic anemia, both IST and transplant. So outcome is ranging between, that is 60% to 100%, not going into detail. Then comes the haplotransplants. So haplo is a necessary because we don't have sibling right now. So we need to find a match in our own family, and haplo is the only solution for that. With haplotransplants, different groups have shown outcome nearly 80%. So the 1-year overall survival was 81% with haplo. Not going to detail for each and everything. So, and there are studies all over the world that is haplo is having a very good outcome, especially with the PTCY platform, post-transplant cyclophosphamide. Overall survival significantly around 80% with haplotransplant. And this is our Indian data. It is an Indian collective data led by Dr. Gaurav Kharia. And it showed that nearly 76% patients with haplo have a good response. And this is a PTCY-based haplotransplants, the cumulative data. And we can clearly see that conditioning was Flu-Cy ATG plus minus TBI. But I think for haplo, TBI should be added. It can prevent the rejections. 9 patients were there. And there was an appreciable amount of response over the overall survival, and event-free survival was up to follow-up of 48 months. 4 years overall survival of haplo was 61%, and 58% was event-free survival. This is an Indian data of haplo. So this is the upfront PTCY haplo in children. The international data 75.6%. But again, in the abatacept group, which is practiced by a single group only, their outcome is 92% with haplo. It is unimaginable, but it is a reality. So by changing the conditioning regimen, by choosing the proper donor, haplotransplants can be a solution of unavailability of matched sibling donor. And Dr. Kishore in MIOT has performed this study. There's transplant haplo in aplastic anemia. They are excellent survival, 83% early survival. So how to optimize haplo? I have already mentioned, by manipulating the conditioning regimen, by augmenting the TBI, 2 gray to 4 gray, by choosing the base donor, father is a better donor, we can just use haplo optimally. And GVHD prophylaxis in place of PTCY plus ATG may be a good prophylaxis, GVHD prophylaxis for haplotransplant. So I can skip these slides. So comparison of matched sibling haplo and IST, it showed that haplo has a comparable results, best results in matched sibling donor. If we reduce the cyclophosphamide dose from 50 to 25, the complications are less. Dr. Kishore is practicing this. So this is published last year in Blood. So it is showing that matched sibling donor haplo as well as the MUD has a comparable results. So this is the alternate donor transplants having a very good result. So this is the historical algorithm. that is aplastic anemia. If we don't get match, then go for IST. But this is the most recent algorithm. That is, if you don't get a match sibling, if you get match sibling, do transplant. If you don't get, either you counsel for IST or do the alternate donor transplants. The reason are the outcome is reasonable. In India, problem is delayed diagnosis, cost, finance, high risk disease. We know that. This is our Indian guideline. All these data accumulated. This is a very good article. In India, at present, we are 17% of all transplants are for aplastic anemia transplants. So really, we are doing a significant number of aplastic anemia transplants nowadays. For relapsed refractory aplastic anemia, I think algorithm is there, but options are very, very clear cut. So relapse, we need to opt for transplant if it is possible, either match sibling or alternative donor transplants. If it is not available, then we can go for IST, and a second IST can be given. But there is significant chances of clonal evolution, especially if we use L-Trombopag. Aplastic anemia in pregnancy, so it has been seen that if we transplant the patients, there is little chance of relapse during pregnancy. But if we treat the aplastic anemia patient with IST, there is a reasonable risk of aplastic anemia relapse during pregnancy. So this is the NEGM algorithm we can go follow. Cost, IST versus match sibling donor, cost is comparable. If we just do the every cost analysis, there is no significant difference in the cost between these two. So patient has one chance. We have to cure the patients as early as possible, need to best optimize the resources, and with our gaining experience, I think transplant is the first option. And this is some data on our eastern region activity on BMT. Now we have 22 centers in the eastern region, which covers 12 states of eastern and northeastern region. These are the BMT centers of all the states who are performing BMT. Starting from 2009 in NRS Medical College till 2024, the number of BMT centers are increasing in the eastern region. We have done nearly 2,500 transplants in the eastern region as a whole. And out of that, 34% is allogenic transplants. This is the performance starting from TMC Kolkata, who have done nearly 1,000 transplants, to the center who has done only one transplant. All the centers were included in this group. In Bihar, there are 3 important centers who are doing transplants, Dr. Parash and Medanta, as well as the Mahavir Cancer Sansthan. They are doing transplants in Bihar. And our number of centers are increasing, our number of transplants are increasing year by year. Last year, we have performed nearly 400 transplants. So we are experienced with bone marrow transplant even in the eastern region. So we need to give the best chance for cure to all aplastic anemia. We also have started doing haplotransplants in aplastic anemia done in NRS Medical College, day 200, 100% donor. So thank you.
Dr. Rajiv Dey, it was a very wonderful presentation. Aplastic anemia treated in 2 different centers. One center that is doing bone marrow transplantation, other not doing the bone marrow transplantation. So I would have questions from the center doing the bone marrow transplant, those are not doing the bone marrow transplant, still treating the aplastic anemia.
Sir, I wanted to ask, are you using rabbit ATG or horse ATG in flu-cy ATG protocol? What's your experience?
In flu-cy, I use rabbit ATG. In flu-cy for transplant.
Have you used horse ATG also, or mainly rabbit?
Yeah, a few people are using, but it is not a standard. We need to gain experience on that. So.
And what's the dose of horse ATG that is recommended?
Horse ATG for transplants or?
Yes, sir. Yeah, for transplant in flu-cy ATG protocol.
For flu-cy ATG, I need to inquire because I haven't used horse ATG for.
Okay.
In rabbit ATG, we use a lower dose, 4.5,
yeah.
0.522.
Yeah.
But for horse, Mugul, do you have any idea of using horse ATG in transplant?
Yes, we use 15 mg per kg.
You are using. So what is your experience about the horse ATG
no,
outcome?
we use only horse ATG. So we have not compared. So rabbit ATG we have used only when suppose first time horse ATG has failed. Say,
No, that is in transplant.
Non-transplant.
All transplant.
We are using horse ATG and the response is very good. Recently we have shifted to, because it was not available, rabbit ATG last
I
2-3
think
cases.
as an AI BMCT we can just accumulate the data
You know,
on the horse ATG in transplant.
In India we can consider horse ATG also. It's very good response with horse ATG.
Good.
Thank you. Thank you.
Okay.
So one more question I have. Sir, severe aplastic with high PNH clone, and we are going for transplant. How much is the dose of ATG? Same dose or less dose we should use?
See, for transplant, I think with
high PNH clone.
High
PNH clone.
PNH clone. For transplants,
Yes, sir. Yes, sir.
we can use the same dose. You can use the.
So, Dr. Rajiv, you will agree that there are many combination therapy that you use for aplastic anemia. You can use cyclosporin with ATG, and recently Eltromova cyclosporin with ATG. Even we are using cyclosporin with dinazole, especially elderly person, telomyopathy, so much prevalence. It is working wonderfully. And so there are so many other options. Even if you are getting 40% chance of remission or transfusion independent life with all these drugs who are not doing bone marrow transplants. So there is so many things to do, even in those are not doing the bone marrow transplants in aplastic anemia. But one thing that every time shown that in aplastic cellularity should be less than 25. I usually see cellularity less than 10%. Cellularity less than 20%.
That is the diagnostic criteria.
Rarely seen the cellularity 20%, 25 is only less than 10%. Thank you. I am closing the session.
Yeah, basically we need to optimize the treatment. So we need to optimize means the best available therapy in the best available situation. So that we need to combine. So if transplant is available, we need to counsel for transplant. Yeah, thank you.
Thank you, sir, for this session. Really, it was a race against time to repair or change the bone marrow in aplastic anemia. For the next session, it is an update on ITP management. The chairperson for the next session is Dr. Anita Kumari ma'am, Professor and Head of Department of Radiation Oncology at NMCH Patna, and Dr. Anand Kumar Gupta sir, Assistant Professor, Department of Pediatrics, IGMS Patna.
I express my thanks to Dr. Avinash for giving me opportunity to chair this session and for this consecutive RAKTAVIGYAN 7. Now moving to our next topic, and that is the update on immune thrombocytopenic purpura management. And for this we have a renowned speaker, Professor Maitreya Bhattacharya, Professor and Director, Institute of Hematology and Transfusion Medicine, Kolkata. Now I hand over our mic to Dr. Maitreya.
Good evening. My topic is update on ITP management. If you ask me, are there a lot of updates in ITP? I'll say yes. If you ask me, are there a lot of changes in ITP management? I'll say only few, not many changes in the management. So there is a discrepancy between the updates and between the changes in the management. So all of us know, I'll not go into the detail, the incidence is more in children compared to the adult. And in children, it's reversible in 80% cases, not in adult. 80% cases of ITPs are primary ITP, 20% secondary. Problem with ITP is that problem with ITP is that there is no definitive diagnostic marker. As we can diagnose AIHA by that, here there is no marker, it's a diagnosis by exclusion only. So what is new in the pathophysiology? Previously we know that it's antibody mediated destruction only. Now you know there is decreased production from the megakaryocyte, destruction by the T cell, destruction by the complement also, and increased formation of the antibody by the plasma cell. So these are all targets for newer therapies in the management of ITPs. So this is known to everybody, International Working Group definition of ITP, newly diagnosed, persistent and chronic. And what investigations we'll do when we suspect a case as ITP. There are 3 guidelines. The common guideline, this is ASH guideline. This is very simple: CBC, blood film, HIV, HCV, and if you are planning for rituximab, then only hepatitis B virus. Other 2 diagnosed guidelines is lot of investigation should be done, but ideally you can diagnose ITP by these only. Clinically there should not be anything other than bleeding manifestation, no lymphadenopathy, no organomegaly, and in the lab investigations only thrombocytopenia should be there. This is a diagnosis by exclusion of other parts. So these are 2 guidelines. So there are certain differences in these 2 guidelines. In the guidelines, serological test, HIV, HCV and H. pylori. So H. pylori, as per ASH guideline, it's not required for the regional steroid and IVIG. You can use prednisolone or you can use dexamethasone also. So this was discussed with the patient. Patient cannot afford IVIG, so patient was given steroid, patient responded, platelet count improved and steroid tapered off. So the first line therapeutic options are prednisolone, dexamethasone and IVIG. Prednisolone is given to maximum of 8 weeks and dexamethasone 3 cycles of 4 days. IVIG, it may be given for 1 to 4 days or 2 days also. Durable response with steroid is 30 to 40% cases, and durable response with the cases of the IVIG was 80%, but IVIG response is very short lasting. It lasts for only 3 weeks. After that, count will again come down. The common side effects of steroids all of us know, but for IVIG, one important side effect is aseptic meningitis. Many patients complaints of headache, and even there may be convulsion also after giving IVIG. So we should be very careful when we are giving IVIG to our ITP patient. So frontline therapy, combination therapies has come up now. This is one article which has combined MMF with steroid, and they have shown the response rate is better with MMF plus steroid, and it's lasted also. Duration of response also is very good. Second article which is combined all trans-retinoic acid with dexamethasone. You can see the response rate with the combination is 68% compared to only 48% with a single agent dexamethasone. They have combined dexamethasone with low dose rituximab also, and you can see this upper one is the combination therapy and the lower one is the only dexamethasone. So response rate with dexa plus rituximab is better than only dexa monotherapy. So they have even combined Eltromovac with steroid. Here also the response was better. But till now, combination therapy is not recommended as a front line of therapy in a newly diagnosed cases of ITP, though it has shown that the response rate is better and the response is often there is a durable response. 12 months later, this lady came to us again with a platelet count of 5,000. There was bleeding manifestation. We gave IVIG this time because patient was having bleeding manifestation. There is transient increase in platelet count. 1 week later, again she came back with epistaxis and platelet count was only 8,000. This time we need to increase the platelet count, but not only increase the platelet count, we need to have a durable response, not only an increase in the count. So the criteria of response will be different for a newly diagnosed ITP and when the patient has come to view with a persistent ITP or chronic ITP. Here we need a durable response. So this is the second line option. First line option I have already told you. 4 things are there. One is 5 microgram per kg per week, because 50 microgram is, suppose a patient is weight is 50 kg, 50 microgram is very low dose, and expected results are not very good. For Eltrombopag, the starting dose is 50 milligram. You can increase it to 75 milligram. For Romiplastin, you can increase it to 10 microgram per kg. Target platelet count, you know. Initially, you need to check the platelet count every week, and after that, every 4 weeks when you are giving TPOR, you can switch to alternate TPORA when there is no response, when there is relapse, or when there is adverse effects after giving one TPORA. As per guideline, the recommended TPORA, second line TPORA, is Avatrombopag. It's not available in India. So if you use TPORA, it has been found that you need to taper it gradually. In that case, you can have a durable response. They have shown that sustained response of therapy will be around 30% even after 3 to 4 years if you taper it gradually. So this is another study which has shown that there is sustained response of therapy that was 31%, and that was complete response was 31%, and sustained response was 56%. This was up 24 weeks also, and even after that also it was persistent. The response was there. So they said TPO tapering should be done gradually, and after a patient is on a stable response, minimal 2 months, maximum 12 months. So once you have achieved the response, should not start tapering. Patients should be on that dose of TPO receptor for minimum of 2 months before tapering. This next drug which is recommended for second line of drug is rituximab. 2 doses are used. One is 375 milligram per meter square weekly for 4 weeks, this 1 gram for 2 days, and you can see there is no significant difference between 2 doses. So how will you choose which patient will respond to TPO receptor, which patient will respond to rituximab? This study showed that the only criteria which will help you to suggest which patient will respond to rituximab is the previous response to steroid. So if the patient has responded to steroid previously, then that patient is expected to respond to rituximab. Third drug which is not available in India is fostamatinib. This is Syk inhibitor. Syk is one receptor which helps is activation of the cells and further phagocytosis. So this Syk inhibitor causes a very rapid response. Within 2 weeks there will be a response, but the response is around 30 to 40%, not in all the cases. So they have also tried a combination in case of persistent or chronic ITPs, this Atra plus danazol. You know, danazol is a drug which is used in ITP as monotherapy. Atra plus danazol has been found to be better than only danazol. Atra plus rituximab people has used, that has also been found to be better than only rituximab. So after discussion with this patient, the patient said she will take rituximab only because she wants to have a child. So we started rituximab, persistent platelet count improved slightly, and again it dropped down. Then again we started avatrombopag. The patient was on avatrombopag plus prednisolone, but patient's platelet count dropped when prednisolone was tapered. So patient was on avatrombopag only and was having a severe headache. So the count was coming down with avatrombopag, then fostamatinib was added to this patient. So finally the patient was on 2 drugs, avatrombopag and fostamatinib. So this is in a case of persistent ITP. What about splenectomy? It's not out, but it's down. Splenectomy gets a persistent response around 50 to 60% cases, but there is a chance of relapse after 3 to 5 years after the splenectomy. So if the patient is refractory of all the drugs, then you can opt a option of splenectomy is there. But 10% patient will be refractory even after the second line treatment of TPORA, rituximab, fostamatinib and splenectomy also. So what is to be done for this group of patients who are basically called a refractory ITP? So this is the third line of drugs. Third line splenectomy, again if it's not done as a second line, it can be considered as a third line of treatment. And third line of treatment basically is a combination of treatment with TPO receptor analog and other drugs like MMA, fostamatinib, cyclosporine, even Decitabine has been used as a drug for increasing the platelet count in refractory ITPs. This is one study which has shown that in multi-refractory ITP patient, they have combined TPO receptor with any of these drugs. It may be MMA, azathioprine, cyclophosphamide, cyclosporine, everolimus, anything. And out of 39 patients, 30 patients responded, 20 patients were CR, and 6 patients have only response. It was not in CR. So in multi-refractory patient, you can combine TPO receptor analog with any of these drugs, and you will get response in some of the cases. So this patient was dependent on a combination of our patient with which we started. The patient was dependent on a combination of fostamatinib and avatrombopag and continued all that only with a slight amount of headache in that patient. So this is the current therapeutic approach of adult ITP. First line is steroid and IVIG. Second line TPO-RA, rituximab, fostamatinib, splenectomy. Third line is basically a combination of therapy. But even out of this, some patient will not respond. What is to be done for those patients? So many new drugs are coming up. Let's see what are the drugs. This is a complicated diagram or figure. This basically showed that depending on the etiology of ITP, what are the sites which can be targeted by newer drugs. These drugs we know, TPO receptor analog. This is sirolimus, we know this is immunosuppression, which will suppress the T cell. There are complement inhibitor. This drug is a complement inhibitor, so complement mediated destruction will be reduced by this. Even BTK inhibitors, this BTK inhibitor is used in case of ITP, rituximab already, and plasma cells are nowadays also targeted for treatment of ITP. So even maybe in near future, bortezomib or daratumumab also come up as a drug for treatment of ITP. Other drugs are neonatal FC receptor blockers. So these drugs maybe in future these will come, but at present none of these drugs are recommended for treatment of ITP because these drugs have not undergone significant adequate amount of randomized controlled trials. So to conclude, the therapeutic landscape of ITP has changed a lot. Combination therapy, as the literature showed, that gives us a durable response in many cases and it's effective, but till now it's not recommended because it needs further studies whether combination therapies can be used or not. Several new drugs are under development, but what is most important and what is under addressed is the lack of understanding of the determinants of bleeding phenotype, because at the same platelet count of 20 or 30,000, 2 or 3 patients will not have the same bleeding manifestation. So bleeding manifestation differs even at the same platelet count. That point has not been addressed. What are the determinants of bleeding? That in near future should be addressed and looked for. So after even all this, if you ask me, the Maha Mantra or Mool Mantra of treatment of ITP is that treat the patient, not the platelet count. And that was there in a guideline in 2012, and still today I follow that, treat the patient, not the platelet count in case of ITP. Thank you.
Thank you, ma'am, for your nice presentation. Any questions from audience?
It is a very nice presentation, but what I do in my patient, even if failure after first line steroid therapy, if there is a relapse, I give second steroid therapy, not going to other second line therapy. I just change solumedrol, methylprednisolone to dexa, or dexa to solumedrol, if the oral, then the injectable. Or in second time, I use romiplostim along with the steroid upfront. If the platelet count is less than 10,000, I prefer to give the SDP in first therapy. So, but as per the tapering is concerned, I take the risk. I keep the phone number of the patient. I taper 5 mg prednisolone every 11th day. To have a better result, is in my experience, I am getting perhaps very good result. I am satisfied this type of protocol.
You know, ITP patient you will be able to identify in your clinic and OPD because all of them will come to you with a Cushingoid features because most of them are on steroid for long time, years after years, and sometimes 10 milligram platelet is coming down to increase it to 40 milligram, again lower it. So this thing goes on, but this is not recommended. Nowadays it's said that you should not use platelet after 8 weeks, after 2 months. That's the maximum time you should use. So once there is a relapse after steroid, you should try the second line or third line of drug, not steroid again. This is the I agree with you. All of us are doing that only on steroid, increasing and decreasing the dose of steroid. That should not be, that may be the one update. We should not depend on steroid only because other drugs are there.
Yeah, and really an excellent talk. I'm really at present struggling with one of my patients for last 2 months. So he, a 25-year-old male patient, presented with thrombocytopenia and typical ITP, no abnormality, morphological abnormality. Initially started with IVIG plus methylprednisolone, responded to IVIG, but when shifted to oral prednisolone, the count dropped. And then I tried all sort of things with permutation combination. At present, he is getting L-thrombopag, weekly romiplastin plus azathioprine. Platelet count is 5,000, but he is bleeding. So
that's what I'm saying. This is the issue which has not been addressed. Like what are the determinants of bleeding in ITP?
Yeah.
That we have not addressed.
Yeah. So at this point of time, any suggestion from your side whether I need to send an NGS or need to add something?
No, and what I believe, and I'll repeat that, treat the patient, not the platelet count. Even if the patient is not having any bleeding manifestation at 10,000, then we can keep the patient at 10,000. But if bleeding, then you will have to combine with the other drugs. TPO receptor with MMA, cyclosporine, anything you
I have one patient also splenectomized. Post-splenectomy less than 10,000 but not bleeding. So just under follow-up only.
You can keep on that only. But if there is bleeding, you go to the third line, a combination of TPO-RA with other drugs.
Now, TPO-RA with other drugs. So at this point of time, whether splenectomy has got a role at this point of time?
Yes, splenectomy is recommended as a second line, and even if it's not done as a second line, at third line. Problem with splenectomy is that 20 to 30% patient will not respond. It will make your patient immunocompromised with a low platelet count.
Yeah,
so that's
and I'm skeptic because only 2 months from diagnosis. So that's why it is very difficult to
ideally, you should not go for splenectomy at this moment. You can try.
Ma'am, as you have said that we should treat the patients and not the platelet count. How much platelets should we be comfortable in case of chronic ITP?
How much platelet?
Should we be comfortable and not treat in case of chronic ITP?
If you go by the guideline, if it's less than 30,000, then you treat the patient. That the guideline said. So more than 30,000, you don't need to treat the patient unless there is bleeding. But again, I'm saying in case of what Dr. Rajiv said, he has given everything, patient is not responding. So if it occurs, many of the chronic ITP patient, they survive with a low platelet count of 20,000, 25,000 without any bleeding manifestation.
Yes.
So they don't need anything.
They don't need anything, right? Thank you, ma'am.
Thank you, Dr. Maitre, for nice presentation. There is a marked shift from the long course steroid to a short course, as Dr. Maitre said, and so many options are there. One question is, do you have any experience of splenectomy? And what is your experience? How many patients you have sent for splenectomy?
Splenectomy, because the older patients are there, like who are now having ITP for 20 years, 15 years, and that time splenectomy was maybe the second line of treatment. Now it's very down. It's not out, but it's down. So many patients are there with splenectomy, and out of this splenectomy, 60% patient relapse again. They are requiring therapy. So splenectomy is not a curative option. That also should be discussed to the patient prior to taking the patient for splenectomy. They will think that this is a curative option.
So that is, it should be patient individualized. Yeah. And as you said, it should be patient to be treated, not the platelet. Yeah. So thank you. With this, close this session. One question is there. Excuse me.
I have just one comment.
Mike?
You mentioned about the international guideline. You mentioned about the international guideline not recommending for the bone marrow examination. I think in India, you know that 80% of the pediatric ITPs are being treated by pediatricians, and almost half of them will receive steroids empirically without doing a bone marrow. So I think that international guideline probably may not be relevant to India because you have to look after the patient.
One thing I want to mention here is that for diagnosis of ITP, only thrombocytopenia will be there. WBC should be absolutely normal total count and differential count, and you should have a very good look at the peripheral blood, not only on the counter report. Second is that if your hemoglobin is low, it should be accounted by the blood loss. If it's not there, then you are not dealing with ITP. Then what Dr. Dr. Mishra is saying, then you will have to go for a bone marrow. Even then lymphoneutro is altered. Any abnormality in the hemoglobin and the WBC series, you need to do. I fully agree with you, but the incidence of MDS presenting, you will probably agree with me that the incidence of MDS presenting with isolated thrombocytopenia is less than 5%.
No,
and that will be able to pick up also from the peripheral blood.
I'm not going to MDS. I'm just talking about pediatric patients.
Pediatric patient 80% recover spontaneously. Pediatrician is
they
there.
will, but there will be patients who will be treated with steroids because the count
pediatric
may be
patient,
normal.
this is adult guideline. Pediatric patient first line drug is IVIG, not steroid.
No,
Pediatric patients are going to have a spontaneous remission in most of the cases.
No, you will wait for spontaneous remission, but before putting steroids, will you do a marrow or not?
No, no, that's also not recommended. Some of the persons are there who say, my students are saying, ma'am, this is a relapse ITP, relapse many times, we should do a bone marrow. But guideline doesn't say that if it's a relapse, you will have to go for a bone marrow. Guideline doesn't say that you will have to do a bone marrow before splenectomy. So guideline only says if it's more than 60 years, that is only in ASH, IWG guideline. ASH guideline says even in more than 60 years also you may not do a bone marrow.
No, all the patients.
No, if you are confirmed, if you are sure that you are
many times in leukemias also the counts are normal.
So my question is to Dr. Mishra, how many cases you found that the diagnosis is altered after doing a bone marrow?
No, there are many patients who have been treated with steroids with a diagnosis of ITP and come back with relapse.
No, only cases I'll tell you where diagnosis is missed off. In case of pediatric ITP, I diagnosed 3-4 patients who were diagnosed as ITP. Basically, these were cases of Barnard-Schulia, BSS. So they presented with isolated thrombocytopenia, bleeding manifestation, and the treating doctor thought this is ITP, started steroid. These I have found in my practice till this age, but I haven't found any other disease presenting as ITP. If you are a good physician, if you are a good hematologist, pediatrician, then you will not expected to diagnose other thing as ITP. You should not mix up. But bone marrow should not be done. Bone marrow is not going to give you anything. The pathologist will report megakaryocytic thrombocytopenia. And where do you land by megakaryocytic thrombocytopenia? Have you, because many cases you have seen the report of bone marrow. Have you seen the report? It's mentioned as megakaryocytic thrombocytopenia. Is that going to help you as a case of ITP? It's not.
Thank you, Dr. Maitri. With this, we are closing this session.
With this, we'll advance to the final session, update on fungal infection and hematology. And may I request all the chairpersons to please kindly come on the dais. Dr. Dinesh Kumar Sinha, sir, Professor, Department of Radiation Oncology, SCI, IGI, MS, Patna. Dr. S.C. Jha, sir,
Senior Consultant Hematologist, Gardner Road Hospital, Patna, and Dr. Ketan Nathani, sir, Clinical Hematologist, Paras HMRI, Patna.
So the final talk, may I request Dr. Dev Mala Bhattacharya to come on the dais, and please, he's giving presentation on the topic of update on fungal infection in hematology. Dr. Dev Mala is a DM in clinical hematology from Institute of Hematology at Transfusion Medicine Medical College and Hospital, Kolkata, and special interest in and expert in thalassemia, hemophilia, and other bleeding disorder. Please, Dr. Dev Mala.
Yeah, thank you all. I will not make you bored for this last session, and it's very difficult to deliver your talk after my guide, Professor Moitri Madam. So I will just scan through my slides because it's just for an schematic presentations of recent scenarios of, because many times we are confused with the fungal infections, how to treat, what to treat, and when to treat. But this is always, even after this, we are not sure that what are the things. But just say why hematology patients are at high risk because of fungal infections. Because there are many pathways for invasive fungal infection in hematological patients. One is chemotherapy induced neutropenia, another one is immunosuppressive agent treatments, mucosal barrier damage because of the morbidities, and invasive procedures like PICC line, frequent transfusions, frequent IV channels like that, Riles tube, many things, bone marrow procedures. So these are the all points which gives rise to infections, specifically in neutropenic patients. And understanding fungal infection severity in hematology patients, there is some less severe infections like candidiasis, then comes aspergillosis and mucormycosis. Mucormycosis is a very dreadful scenario. Even if immunocompetent individuals like diabetic patients, mucormycosis is very dreadful and fatal. Now, how to diagnose fungal infections effectively? So, imaging technique, this is the first easiest thing available in our hand, that CT scan are more sensitive than X-rays and obvious other things. So, a good CT scan and radiology opinions, but many times even if CT scans, it may be missed. So, there are subtle findings in CT scan. Those who are veteran radiologists, they can pick up some findings in the CT scan for giving you a hint of fungal infections. Histopathology, it is difficult to get histopathology samples, specifically hematology patients, because they are already sick. Somebody may be in the BMT, somebody may be in the isolation room. So doing this histopathological procedure is also difficult, and limitations of doing a fungal cultures coming out to be positive after the patient is dead is very is not practical. And overlapping symptoms like with bacterial infections and coexisting bacterial infections makes the diagnosis more challenging. And so there are many things and special considerations for MRI, specifically you are when suspecting in the central nervous system fungal infections, eye involvement, orbits or paranasal sinuses. So these are the places where MRI give you more info than CT scans. Now, these are the diagnostic approaches: culture, microscopic, imaging. And when the imaging is not satisfactory, then we can go to biomarker tests like galactomannan, beta-D-glucan. But any times it may be negative or false positive. So this is not supportive. But if the report comes out to be positive, then you can specifically escalate your antifungal therapies. And nowadays this PCR-based fungal DNA detection increases the diagnostic speed and accuracy at complementing traditional methods, but there are some drawbacks of becoming false positive tests. So these are not, there is no any definite definite test to find out any infections. Now, what are the antifungal therapy strategies should be implemented? One is empirical therapy. Most of the hematologists or hemato-oncologists and medical oncologists, they go by this empirical therapy because prevention is better than cure. We always start some empirical antifungal in a possible neutropenic patients. So it is initiated in the high-risk patients with persistent fever despite antibiotics, and if there is a chance of fall in WBC count in next 3 days to 7 days, then we always start an antifungals. Then targeted therapy based on the microbiological confirmation of precise antifungal use. This is very uncommon, but even in some patients are treated who have recovered from neutropenia and we could establish a diagnosis, this group of patients get this targeted therapy of 6 weeks or 2 months of therapy. Preemptive therapies guided by the biomarkers or imaging to reduce the unnecessary antifungal exposures. If the beta-glucan is high, then we can give some anti-mold therapy. And therapeutic drug monitoring, it ensures the therapeutic levels of antifungals, specifically azoles, and minimizes the normal levels, and minimizes the toxicity. But this is difficult to do in our setting, that therapeutic drug monitoring of the antifungals. Now, biomarker and molecular methods are already I told. Galactomannan antigens for invasive aspergillosis, beta-2-glucan test for most pathogenic fungi, cryptococcal antigen test, specifically when you are handling with the CSF, you are suspecting any intracranial or CNS infections by the fungus, and combined Mannan anti-Mannan testing. These are difficult things. Microbiologists may be better to guide us. Molecular methods of PCR-based assays and clinical value. With all these things, your clinical judgment and clinicians' suggestions or judgment is very much important. And serial monitoring of these markers can also be done to assess the treatment response. Now, already I told that there are some conventional methods and some advanced technologies. Conventional method is histopathology and proving under the microscope, and culture. Culture remains the gold standard for any microbial infections, fungal infections, and T2 magnetic resonance, that is PCS, lateral flow device. Even I don't know about these things in details. And NGS testing, matrix assisted laser dispersion or ionization. These are very advanced techniques for detecting minor or minute fungal infections. Now, coming to the antifungal drugs. So, antifungal drugs which are ranked by their spectrum of activity. The broadest one, these are pictures like broad to narrower. Broad is obviously the king of all antifungals, that is liposomal amphotericin B. Then isovuconazole, now the newcomer and the hot drug of antifungal clutter. Now then posaconazole, caspofungin, voriconazole, itraconazole, and fluconazole. Itraconazole has a notorious effects of drug-drug interactions and various draft levels. So itraconazole is not commonly used by the hematologist or oncologist. The rest all drugs we all use, and among these most important or broad drug is liposomal amphotericin B. Now, common antifungal drugs used in India are azoles and voriconazole, posaconazole, fluconazole, itraconazole, and isobuconazoles. And these are the mostly concerned when you are using against the candidas. Echinocandins, caspofungin, anidulafungins, and micafungins. But all three drugs are given IV. There is no oral formulation of echinocandins. Polyenes like liposomal amphotericin B, it is also IV, and this is a very important drug for all fungal infections. Now, what are the key considerations for treatment of antifungals? One is antifungal resistance, because we often misuse the fluconazole. Fluconazole had been a good drug, but nowadays because of overuse by the local practitioners, skin dermatologists, and many other people, that fluconazole has become resistant. Many infections are becoming resistant to the fluconazoles. Therapeutic local guidelines, because of some fungal infections are more common in specific places like North India. Mucormycosis is very much common than in Eastern India. And environmental controls like the rooms where the patient was there, like HEPA filter room was there or not. So these all things add to the treatment of fungal infections. And supportive measures, when you are getting a good neutropenic counts, good neutrophil counts, then you can stop or reduce or de-escalate the antifungal therapy. So these are the many things which play into the decision of antifungal therapy. Now, antifungals in renal and hepatic impairment, because most of the patients are in ICU, they have many issues with hepatic, specifically hepatic derangements, having shock, to going through the AKI phases. So in these patients, this is a very difficult, at times it is difficult to decide which antifungal will help. So this is a chart that conventional amphotericin B, it is a nephrotoxic agent. So in AKI, we avoid using this. Liposomal amphotericin B, though it is less nephrotoxic, but still it can damage, and it requires good monitoring of the electrolytes, specifically potassium, and also it decreases the platelet count. And most of the patients are thrombocytopenic. Using antifungal, using lipoampho further decreases the platelet count. It directly destroys the platelets. Now, azoles, fluconazoles, its dose reduction is needed in renal impairment, minimal hepatotoxicity. Voriconazole, it is hepatic metabolism, so requires dose adjustment in liver impairment, but we don't give. And posaconazole, so it's generally safe in renal impairment, but it is you should monitor LFT. Isobuconazole, it is an hepatic metabolism, but relatively well tolerated. No dose adjustment required in renal impairment. So apart from severe hepatic disease, isobuconazole can be used in both the cases. Now, echinocangins, caspo, mica, and anidula, renal impairment is safe, no adjustment needed. For hepatic disease, caspofungin is difficult to use, and mica and anidula can be used in hepatic impairment. So this is very important for echinocandins. Now, for renal impairment, just for summarizing, this is very important slide for me, that for renal impairment, avoid liposomal amphotericin B, specifically conventional one. Prefer liposomal ampho, echinocandins or azole, and adjust fluconazole if it is on fluconazole. Hepatic impairment, you should not use voriconazole, caspofungin, and prefer echinocandins, mica and anidula, or isobuconazole if there is severe hepatic disease. So isobuconazole is a champ. It can be used in both the cases. So this is just a repetition of these slides. So anidula fungin, mica fungin, and isobuconazole. These three are the three musketeers which can be used in both impairments. Now, risk group for these invasive fungal infections, obviously very high groups are the AML patients, transplant patients, and having this HLA mismatch or complicated transplant patient. Intermediate risk groups, there is neutropenia of 7 to 14 days, that is ALL patients, MDS patients, matched allo SCTs, and low group are the chemotherapy patients, autologous SCT patients. These are the low group. But often we trigger the best because we do not take any risk of in this particularly sick or serious patients. Now, most important risk factors for the invasive fungal infections in patients with hematological malignancies. What are the risk factors? Age, previous history of invasive fungal infection. This is very important. A patient who had a invasive fungal infection before have a chance of recurrence. Presence of diabetes, serious grade 2, 3 more than grade 2 mucositis, coexistence CMV infections, recurrent candidiasis, prior COPD, prior tuberculosis, and prolonged neutropenia before hypoalbuminemia. These are the all factors which play into role, which makes more prone for the fungal infections. Now, one point is of always remained a debate for last 15 years, as I am in hematology, is that hematology stream, that is comparison of the antifungal prophylaxis which should be used as prophylactic agent in hematology patients. So there are many trials. So overall, posaconazole remains to be the champion of this. The posaconazole was a treatment of choice for antifungal prophylaxis as well. General consensus, they are using either posaconazole or voriconazole, but there are many doubts also, but mostly in our day-to-day practice we use either posa or voriconazole for our antifungal prophylaxis. So there are many factors for deciding. Most important is regional variations, presence of breakthrough infections in the before, availability of the antifungal therapeutic drug monitoring level, and resistance in the microbacterial regimen in that particular hospital or institutions. So this is a chart that it was published that whether in different hospitals across the world which drugs are used for as per the institutional protocol, or whether any institutional protocol exists or not. So this is, I am not going in details of these slides. Now just transplant patients, allogenic transplant patients, where the chance of fungal infections is very high, and the diagnosis is a determinant of the chance of more chance of fungal infections. The AML remains the pioneer, that AML patients had a more propensity to get fungal infections. Next is ALL, then lymphoma, aplastic anemia, and others. So AML is a notorious disease in all way. Even in transplant patients and fungal infections, AML patients are more prone. So I am not going in these busy slides, that there are some guidelines of diagnosis of invasive fungal infections, and it is from the infectious disease working party in hematology and oncology. This is a nice guideline to read, but I am not going in details. So what are the diagnostic procedures or schema of doubting any fungal infections? Before developing granulocytopenia, you should take a good history, whether there is a past history of infections, past history of mucormycosis, diabetes, any orbital or sinus problem before. And during granulocytomia, presence of fever despite giving broad spectrum antibiotics or blood culture negative, still having fevers, and specifically pulmonary findings, pulmonary nodules. Take opinion from your radiologist friends to guide you regarding for the CT scan report. You may review the CT scan report also of CT chest report to find out any detail, any hint of fungal infections. And persistent fever for mandatory. If there is persistent fever despite antibiotics, 72 hours fever, then you should do all the things. And recommended things are bronchoalveolar lavage with pulmonary infiltrations, and optionals are these antifungal, this galactomannan testing and other things. But we often do the optional thing first. We do test the galactomannan and beta-2-glucan testing. Then we go to the BAL, because BAL is a procedure which may give rise to other complications. So these are the main things we follow during our day-to-day practice. And also, last but not the least, in the present era of targeted therapy, CAR T-cell therapy, and these all cellular therapy, these are also drugs which makes the patients prone for fungal infections, specifically ibrutinib, acalabrutinib, idelalisib, venetoclax. These all drugs make the patients prone for fungal infections. So on take-home message is, persistent threat is fungal infection, obviously. Treatment evolution, we have many drugs in our armamentarium, and future directions that we may get any clue, rapid clue for detecting fungal infections. But continued vigilance, early intervention, specifically most important is early interventions for any suspicion, when you are suspicious of fungal infections. So this is very important that you start as early as possible. Thank you. So handle with antimicrobial, handle with care, but still miles to go for antifungal management on our aspect. Thank you.
So it was very nice presentation. Session is open for discussion. Any question, please? So earlier it was a very nice presentation. So what is your policy in your hospital? You use upfront empirical antibiotics, gram-positive, negative, or antifungal, or you wait for 3 days?
No, we actually most of the AML patients, we do according to as per the disease. If it is AML MDS patient, we start with antifungal prophylaxis. ALL patients, we start with fluconazole prophylaxis. If there is any doubt of having fever or infections, then we escalate the antibiotics. Rest others, if the patient is on steroids, of long-term steroids, then we can add fluconazole, like lymphoma patients who are on high-dose steroid in the initial, and presence of diabetes in the patient, and elderly patient, those group we use antifungals. But young fit patients, lymphoma patients or myeloma patient, we don't use antifungals.
No, AML patient.
AML patient always
anemia patient presenting first time ICU with fever. You are using empirical antifungal upfront, or wait for 3 days?
No, we start in AML patient. We start, if there is fever, we start with antifungals. Don't wait.
I just wanted to ask, have you encountered, like you are giving AML induction chemotherapy and you are giving posaconazole as a prophylaxis. So have you encountered any fungal infection after posaconazole prophylaxis?
Yes, yes.
And how you treat that?
Then we change the azole group. We go to echinocangins. Yes, we do. But if the report is negative, still also we continue with antifungals.
And single value is not of use, so we have.
Exactly, we may do serial testings.
Yes. Thank you.
Thank you.
Thank you very much.
Thank you, sir. Now, to conclude the session and for the prize distribution, may I please invite Dr. Avinash, sir, to delegate the process.
Thank you and good evening everyone. So now it's time of prize distribution. So prize distribution, then after that there is GBM, and then vote of thanks. So I know the results. So the institute who will won most of the awards, we will send the bill of this RAKTAVIGYAN 7. If they agree, then only we will announce. हाँ? Ready? हाँ ठीक है चलो देख लो भाई रिकॉर्ड कर लो CCTV रिकॉर्डिंग है चलो ओरल पोस्टर ओरल पेपर प्रेजेंटेशन फर्स्ट प्राइज गोज टू डॉक्टर संध्या S from AIMS Patna. Very good. Congratulations. I would request Professor Dr. Devdatta Basu sir to distribute the prize. You can go there. चले जाओ. Yes. So. Thank you, thank you. You please stay, sir. Huh? So the second prize, we had only 2 prizes in oral. Second prize goes to Dr. Ritav Rakshit from AIMS Department of Pathology. Congratulations. Thank you. So, yes. Thank you, sir. Thank you. Thank you. Thank you. Now it's turn of posters. So for first prize in poster, Dr. Bhavya Beniwal, AIMS Transfusion Medicine. I would like to request Dr. Sudhir Kumar. Dr. Sudhir sir is there to distribute the prize. You can go there, huh? दीपक मिश्रा सर प्लीज यू कम आप अभी निकले नहीं आ जाइए आई वुड रिक्वेस्ट डॉक्टर दीपक मिश्रा सर टू ज्वाइन just wait sir is coming so. Yes, sir. Just stay, sir. Huh? Second prize goes to, you can go, Dr. Prachi Vatsa from Department of Medicine, IGIMS. Thank you, sir. Thank you. Thank you. Thank you. Now I would like to request Dr. Sanjeet Kumar Singh and Dr. Dinesh Sinha for third prize distribution in the poster, and the prize goes to Dr. Elmondson Kharwalong from IGIMS Department of Pathology. Congratulations. Thank you, sir. Now I would like to request Dr. Suchismita, and in the poster there were one technician and he had presented the poster very well, so we decided that we will share some prize to them. So he is Mr. Deepak Kumar from AIMS Department of Pathology. Yes, please. So 1, 2, 3, 4, 5. So out of 6 prizes, 4 goes to AIMS Patna. So out of no. So out of total expenditure, कितना देना होगा तुम लोग को? हाँ? सारे चेक वगैरह पे साइन करा लो, ठीक है? Congratulations. So thank you. 70% you will have to pay. AIMS Patna, 30% IGIMS. Huh? And now I think oral paper poster ho gaya na. Now it's turn of quiz. So I would like to request Dr. Yoga Lakshmi. So I had first interaction with Dr. Yoga Lakshmi in hematology quiz in Darbhanga Medical College when she was doing MD pediatrics, and after that she did DNB in clinical hematology from BL Kapoor. She is consultant clinical hematologist at Coimbatore. So the winner of quiz is AIMS Patna, and the teams are Dr. Soumya, Dr. Utkarsh and Dr. Neha Raj. So congratulations to them. They will go to zonal and they should work hard that this time they should win the national. Okay, you go there. Thank you, thank you. So now we have come to an end. Now this is the time for GBM. So, kya? Photograph. So we can have one group photograph. We can have one group photograph. Yes. लेकिन पहले ऐसे डिस्कस कर लेते हैं थोड़ा, वोट ऑफ थैंक्स ये सब कर लेते हैं, ठीक है? So any suggestion or feedback if you want to share regarding future activities, you can suggest. So it's always the support of core members and all the organizing committee members. We are able to organize such activities, and I always thank them for giving me opportunity to do. So I am not leading this society, but I am in front. Someone has to stand in front, and my seniors, colleague, they have full support. That whatever I do, they just support. Okay, go ahead. And the society is such that even the president of the society is absent, but we have conducted the whole conference. So this is the faith on you, faith on us that is there. So I think any suggestions you want to share, Sudhir sir? Whatever you feel you want to add. Because every time what happens, the maximum anxiety time is the night before. Night before of the conference, you don't know how it will start. And the just before start of conference, you have the maximum anxiety. Because 70% of the delegates, they are unpredictable. They are first year, second year MD path. We don't know whether they will come or not, what is their, how much their involvement will be. So we don't know. And in metro cities or in cities where hematology is very well established, so the delegates are fixed. They are consultant hematologists. So they will come regularly. You keep myeloma, they will come. Medical oncologist, hemato-oncologist, hematopathologist, they will come. In our conferences, around more than 50% of them are postgraduate residents in Department of Pathology, Medicine, Pediatrics. So they are first year. So last year they have not seen RAKTAVIGYAN. First year, how they will come, we don't know. So there is some unpredictability, but somehow things go well. But we need feedback. And every time I feel that there should be someone whom I can transfer the things and they should move forward. So I think people should come forward from institutes, young people, they should come that, okay, we will do whatever we have, we are ready to support them. Whatever finances we have, whatever support we have. So, yes, sir, Sudhir sir, you want to add anything?
Actually, I'm very happy that the legacy is being carried out like every year. And unfortunately, I missed the program yesterday. And you know, hematology is one of the specialty where newer diagnostic and newer classification system always being changed, and new treatment modalities are updated every month or every year. So it's a very good platform to learn, and I request all residents who are from various medical colleges of Bihar to get the opportunity to learn hematology in this session. Thank you.
Thank you, sir. Thank you. Yes, Dr. Sanjeev.
First of all, I would like to thank Dr.
एक मिनट जस्ट कभी बोल 2 मिनट पहले हम बोल लेते हैं थोड़ा तो नहीं तो फिर क्या होता है sometimes things come ना and then you forget. So sometimes what happens, it comes in mind कि जैसे लगता है कि कुछ चीज़ शुरू हुआ, you have started something in 1 year, 2 year, 3 year. After that, sometimes it appears that it is compulsion to do. When you have started something and it has become a platform where people come, so it becomes your like responsibility. First time when you do, you have so much enthusiasm that I am going to start this first transplant, first acute leukemia treatment. It's different. But when things mature, there is a added responsibility that you should perform well, then you have to continue it. So the support of young colleagues are very important. It's very important. So they should come forward. Yes, sir. Please share.
I wanted to thank Dr. Avinash for conducting the 7th RAKTAVIGYAN, and he has handled it single-handedly. We बोल देते हैं कि हाँ, the core committee members are there to help, but we are just behind the curtains, helping only this much, but he is exaggerating it to this much. ये सच्चाई है. But yes, few things have changed in the past 2-3 years. Now there is participation from AIMS Patna along with IGMS to conduct the workshops. पिछले 2-3 साल से मैं देख रहा हूँ कि they have come forward to help you to conduct the workshops. मुझे लगता है कि ये तो legacy चलनी चाहिए. Definitely we like both the institutes to be very active. Not only that, I would request representatives from NMCH, PMCH, even ESI Beta and NMCH Beta. They should also come forward to help this society to grow further, to give more inputs, to be more active. अभी तक जैसे workshop में तो definitely AIMS Patna and IGMS is doing, but more of participation I would like कि हाँ वहाँ से जो भी young faculties हैं, they should come forward more, taking the help of the senior residents, because they are the main workforce to perform a more academic environment. और बाकी PG और residents तो खैर हैं ही, PGs should be over enthusiastic, and I would also request the PGs or the residents over here, if they have got some more beautiful ideas कि हाँ ये जो program हुआ उसमें और we can add something more, so it would be very helpful for the committee members so that they can incorporate in the future programs. That's all from my side.
Thank you, sir. Thank you. Dr. Dinesh, sir.
एटलीस्ट जो विनर है मुझे लगता है कि उनके तरफ से कुछ फीडबैक आना चाहिए.
विनर नहीं, किसी की तरफ से.
हाँ, किसी भी एटलीस्ट मतलब वो थोड़ा सा उन्होंने स्टेज भी किया तो एटलीस्ट मैं बोल रहा हूँ. एनीवे, हाँ, नहीं मतलब कैसे इसको इम्प्रूव कर सकते हैं, क्या कर सकते हैं. सो
आइडियाज, एनीवन कैन हैव आइडियाज, सो यू कैन शेयर व्हाट यू फील.
उसके पहले मैं बोल लेता हूँ. मैं ठीक है. तो आई एम ए रेडिएशन oncologist at IGMS State Cancer Institute. So we are unfortunate that we have so many radiation oncologists at Patna. So we started after coming. So we also started very late. I organized as organizing secretary in 2017. I am still not getting the second chance to organize. I am fortunate. So 2017 में मैंने पहला किया था. Like नेशनल कॉन्फ्रेंस हमने किया था RI कॉन बिहार चैप्टर, एसोसिएशन ऑफ रेडिएशन ऑफ ऑन्कोलॉजिस्ट ऑफ इंडिया का. तो उसके बाद हमने ये पास ऑन किया. वी जस्ट पास ऑन दैट ऑर्गेनाइजेशन ऑल शुड कम अप, ऑल सेंटर्स. सो उसके बाद महावीर कैंसर संस्थान में ने लास्ट ईयर किया, पारस कर रहा है, एम्स पटना कर रहा है, सभी लोग कर रहे हैं. हमारे यहाँ चीफ है, राजेश सर भी हैं. So we all are doing in next year. So we are I am again fighting for the next year, but we are fortunate that everybody is doing. So here in hematology the scenario is different. I think Dr. Avinash was the only first and foremost clinical hematologist.
Don't say first and last.
In Bihar and Jharkhand, I think. So he pioneer. So torch bearer. So this and now, but Dr. Rishu Vidyarthi and Dr. Avinash at AIMS Patna, Dr. Ketan is come. So I want to, and Dr. S.C. Jha is from Dr. S.C. Jha left. I was searching. Dr. S.C. Jha is also practicing hematology since long, and many pathologists are also there. So we in hematology also there are now so many. So they should come forward. I always say that as Dr. Avinash is saying, someone should come forward and organize such conference, because Dr. Avinash is always there. We are also among the founder member in Hematology Foundation of Bihar, because when Dr. Avinash just touched us, that time there was no one in hematology, and we were practicing oncology. We were also seeing the cases of hematology also. I still treating acute leukemia with the help of CML. So many patients, GPAP program with me. ID is there, GPAP program, that is Max Foundation program. So many hematology patients coming, thinking that government institution there will be less expense in, so they just retain at IGMS. So with the help of Dr. Avinash, I think since 2012, Dr. Avinash came in 2014, I came 2020 back in Patna at IGMS. So I think after 2014, almost daily I talk to Dr. Avinash for case, because he is also used to say that patients should be benefited. Wherever he should be benefited. Many patients I am referring, they just take the opinion from Dr. Avinash, and with the help of Anudan, I am writing the same prescription. So patients should be benefited, and likewise I think organizing the conference, so someone, I think my opinion is next year you just make a co-organizing secretary. First he should or she should organizing in such with you. So we will learn something, because all are, I think, very new one, so they are just
no,
reluctant.
We are there to support. Suppose one institute, IGIMS or AIMS Patna, decides to organize. So we
IGIMS, there is problem. IGIMS is there problem because
institute can decide organizing chairperson, secretary. No need to keep us. We are there.
So I think AIMS Patna will be a good choice. I think the AIMS Patna next year, AIMS Patna should organize. But if not, then co-organize secretary, and should I think half responsibility should pass on. We'll decide on next meeting before.
The words should come from the institute. That will be more better than pressurizing IGMS should do, or AIMS should do, or Paras should do, or Mahavir should do.
I'm also giving the opinion.
Is not important. Joint secretary, organizing chairperson.
It can be co-organization also. There can be 2 centers organizing this time. और mid-term के लिए भी कुछ सोच सकते हो कि mid-term में हम कर रहे हैं. In the annual we can think of collaborative. तो इस तरह से भी कर सकते हैं. I think representation from as a faculty बहुत कम लोग हैं from the institute, so we can circulate it as minutes of meeting.
This is the thing that we lack here. लोग कभी-कभी सोचते हैं कि ये particular डॉक्टर A है, उसका मीटिंग है, या डॉक्टर B का मीटिंग है. It should not be this one. There is no.
अच्छा, कोई आप लोगों से प्लीज आप कोई फीडबैक दीजिए कि क्या इसमें
नहीं, सारे लोग सपोर्ट करते हैं, सारे लोग सपोर्ट करते हैं.
नहीं, मतलब इसमें और क्या इम्प्रूव किया जा सकता है इस कॉन्फ्रेंस में?
फीडबैक लीजिए.
I would request the residents from different institutes to give some feedbacks. जो positive लगा, कुछ negative feedbacks भी अगर है तो that will be definitely taken care for the future.
वो लोग दुखी हैं, अभी पैसा देना होगा ना, वो लोग नहीं बोलेंगे.
तब तो खुशी से बोलना चाहिए.
अरे पैसा इंस्टीट्यूट को पैसा देना होगा भाई.
I am Dr. Pritika. I am senior resident from AIMS Patna. I think RAKTAVIGYAN for us is annually the most exciting conference to attend, क्योंकि सारे residents अपने cases, posters, papers पे लग जाते हैं. And we are also very well guided by Dr. Avinash sir from Paras Hospital, और हमारे अपने Dr. Avinash sir in pathology who gives us very good clear-cut instructions कि कैसे approach करना है इस conference को and how to conduct it. I think Avinash sir would be able to add more words.
So when I came back to Patna after my post-graduation, sir was the first person I met at Paras. And
इसी के लिए भाग गया पारस से. पहली बार हमसे मिला, भाग गया पारस से.
4 महीने के लिए सर के पास था, और हेमेटोलॉजी का केसेस जो सर का था वो मैं देखता था. मलिक सर थे. मलिक सर यूज्ड टू give the diagnosis, but I used not miss the cases which sir has sent. And sir used to come after rounds at 10 o'clock. He used to sit with us. बात करते थे, सर क्या लगा, कैसे लगा, कितना प्लाज्मा सेल मिला, तुमको कितना मिला, क्या है, क्या ट्रीटमेंट चला, क्या हिस्ट्री आया, अगर टीटीपी का केसेस है तो उसमें क्या सिस्टोसाइट दिख रहा था, कितना दिख रहा, ये सब केसेस डिस्कस करते करते जब वो क्या है हेमेटोलॉजी, आई केम टू नो विथ सर ओनली. That enlightenment came, then the interest developed, and I joined as senior resident AIMS Patna, and then there was Surbhi ma'am who taught me flow, and there was Ruchi ma'am and Poonam ma'am. Everyone, I got trained so much ki then it came a habit with Avinash sir to conduct the quiz. For last 2 years, 3 years, we have been conducting quiz in all over Bihar, and first sir used to do that. With sir, I joined, then Surbhi ma'am, then now Rushu ma'am has done this time. So it is growing group and emerging and evolving with every time there is a positive feedback and negative feedback, we take back, we go back, revise everything, and with every RAKTAVIGYAN there will be a better CME and conference.
Yes, thank you. And yes.
Some more residents would like to give some negative feedbacks also. सारे positive feedbacks अच्छा नहीं होता है. तो अगर positive feedbacks रहता है तो we feel elated only. There is no scope of improvement. जो कि शिकायत मिलती है तो देयर इज अ स्कोप ऑफ इम्प्रूवमेंट फ्रॉम दैट एस्पेक्ट।
सारा शिकायत सर को करना है।
बिल्कुल बिल्कुल, आई एम रेडी, और रहना भी चाहिए, तभी तो देयर विल बी ए स्कोप ऑफ इम्प्रूवमेंट इन दोज थिंग्स कि अच्छा ये नहीं हुआ था, इसको ऐसे करना चाहिए था। ठीक है, वी विल आल्सो ट्राई टू, मतलब मैं तो नहीं करूँगा, सर से ही करवाऊँगा।
अरे नहीं, सब
लेकिन हाँ, सब लोग मिल करके करेंगे तभी देयर विल बी इम्प्रूवमेंट फर्दर।
सर हम लोग मिल के कर रहे हैं और आगे भी सर के साथ में करेंगे, और आगे मौका मिला तो हम लोग फ्रंट में भी आगे करेंगे। और थोड़ा इंस्टीट्यूट की अपनी कुछ टेक्निकलिटी होती है जो सर आप लोग तो मतलब बेटर जानते हैं, वो उसको कोई फुलफिल नहीं कर सकता है।
नहीं ऐसा नहीं है। अब देखो, कोई एम्स नहीं दिल्ली यदि कुछ ऑर्गेनाइज कर रहा है, SGPI लखनऊ कर रहा है, PGI चंडीगढ़ कर रहा है, तो हम लोग भी कर सकते हैं। बस हम लोग सोचते हैं कि अच्छा वो कैपिटल सिटी है, हम लोग पेरीफेरी में।
नहीं, सही बात है कि अविनाश सर ने अगर टॉर्च बेयर नहीं किया होता पटना में, तो हैड देयर बीन एनी हिमेटोकॉन या जागरूकता बढ़ती नहीं बढ़ सकती थी ना। तो टॉर्च बियरर, मतलब एज ए टॉर्च बियरर जब सर ने किया था तो इट वाज ए स्मॉल लेवल, ग्रेजुअली इट इज़ इम्प्रूविंग। तो उसी तरह से अब टॉर्चेस ना, मतलब हर एक इंस्टीट्यूट और हर एक लोगों को भी थोड़ा सा अपने लेवल से, एस आई एम कमिंग अहेड टू कंडक्ट, जैसे कि अभी एम्स पटना ने कंडक्ट किया ऑल द क्विजेज ओवर द डिफरेंट सेंटर्स, इट इज़ डेफिनेटली अ वेरी वेलकमिंग स्टेप। तो इसी तरह से मैं चाहूँगा कि हाँ, देयर कैन बी ए स्मॉल CMEs या मिड टर्म जो पीछे भी हुआ था, तो उस तरह से
आप अपने इंस्टीट्यूट के लोगों को इन्वॉल्व कीजिए। आप कोई जरूरत नहीं कि
IGMS will organize mid term under
हाँ कर सकते हैं, हाँ करिए
Foundation
उसमें,
of
हाँ
Bihar
बैनर कैन बी दिस ओनली,
हाँ only banner will be same,
स्टेट चैप्टर्स भी
anyway
इसी तरह से
will
कैन बी जस्ट
हाँ
उसमें जो भी प्रोटोकॉल आपके इंस्टीट्यूट का है ना, वो फॉलो कीजिए। आपके डायरेक्टर चीफ गेस्ट होंगे, डीन होंगे, जो भी होते हैं। आप अपने डिपार्टमेंट से ऑर्गेनाइजिंग चेयरपर्सन, सेक्रेटरी, और ऑलवेज देखो क्या होता है ना कि जब कभी हम लोग एक डिपार्टमेंट स्टार्ट करता है तो कभी कभी उस डिपार्टमेंट का लुक रहता है वो गलत है। उस डिपार्टमेंट को, हिमेटोलॉजी किसी एक डिपार्टमेंट का नहीं है, मेडिसिन, पेडियाट्रिक्स, पैथोलॉजी का नहीं है। तो अब पैथोलॉजी लीड करेगा तो पता चला हर जगह पैथोलॉजी दिख रहा है, तो फिर मेडिसिन वाले उतने इन्वॉल्व नहीं होंगे, पेडियाट्रिक्स इन्वॉल्व नहीं होंगे। तो आपको ऐसा बनाना है एजेंडा कि तीनों डिपार्टमेंट का रिफ्लेक्शन हो, सारे फैकल्टी सोचे कि भाई हमारा भी इन्वॉल्वमेंट है, तभी वो स्टूडेंट भी आएगा और तब फायदा होगा। अदरवाइज फिर ऐसे हाफ हार्टेड करने से नहीं होगा। ठीक है, तो उसको प्लान करना है, उसको थोड़ा सा सोचना है, डिस्कस करना है। पेडियाट्रिक्स में मान लीजिए कि 15 फैकल्टी हैं, लेकिन उसमें 1-2 लोगों का ही इंटरेस्ट थोड़ा पेडियाट्रिक्स में हो सकता है। उनसे बात करना है, उनको इन्वॉल्व करना है, टॉक देना है, चेयरपर्सन है, सर लोग हैं, सर लोगों से बात करना है। सर के डिपार्टमेंट में भी जो HOD होंगे उनको इन्वॉल्व करना है, तब होगा। नहीं तो फिर होगा कि सर का ही प्रोग्राम है तो फिर उसमें दिक्कत होता है कि भाई कौन जाएगा कौन नहीं जाएगा, ये सब प्रॉब्लम होता है। तो उसको कैसे हम ओवरकम करें, अपने आप को पीछे रख के लोगों को आगे कर दीजिए तो फिर सारा काम हो जाता है। तो उसको सोचना होगा, जो कॉस्ट होगा वो सोसाइटी के पास रहेगा, फंड्स तो दे देगा, नहीं तो IGMS के पास बहुत फंड है, तो आप लोग कर लीजिएगा। ठीक है,
फंड के लिए ठीक है, फंड के लिए भी आई एम रेडी।
हाँ,
तो मैं तो बोलूँगा कि डॉक्टर सुष्मिता, अभी अगर जनवरी में हम लोग प्लान करें नेक्स्ट ईयर, है ना, मिड टर्म, हाफ डे, है ना,
हम लोग तीनों डिपार्टमेंट मिलके
आप लीड लीजिए, हम लोग हैं।
कर लीजिए। और उसमें जो आपको देखना है कि हम जैसे IGIMS में कर रहे हैं और हमारा टारगेट IGMS के PG स्टूडेंट्स हैं, तो अपने इंस्टीट्यूट के अनुसार या एम्स पटना, IGMS, PMCH, NMCH है, तो हम उस तरह के टॉपिक को रखें जिसमें हमारे PG स्टूडेंट्स को फ़ायदा हो। अब वहाँ हम MRD इन BALL करेंगे तो उसका फ़ायदा नहीं होगा, लोग आके बात करेंगे आपस में। तो उस तरह का टॉपिक रखिए, PG का इन्वॉल्वमेंट हो, ओरल पेपर वगैरह हो, तो उसमें ज़्यादा अच्छा होगा। जैसे लगे कि आधे दिन में, एक दिन में पूरा हीमेटोलॉजी डिस्कस हो गया। तो जनवरी में हम लोग कर सकते हैं। ठीक है, और कोई प्रेशर नहीं है, प्लान कीजिए, ऑर्गेनाइज कीजिए। इन केस आपके इंस्टीट्यूट में नहीं हो पाया तो उस डेट को हम लोग बाहर भी कर सकते हैं, कोई दिक्कत नहीं। ठीक है,
नहीं सर, आपके गाइडेंस में हम लोग करेंगे।
नहीं, ठीक है, सब लोग का रहेगा गाइडेंस। हाँ कर सकते हैं, लेकिन ज़्यादा अच्छा लगता है इंस्टीट्यूट में हो। हाँ हाँ हाँ, हो जाएगा हो जाएगा। डॉक्टर केतन इज न्यू एडिशन, रिसेंट एडिशन, तो इनके रहने से बहुत फ़ायदा होता है।
इंस्टीट्यूट में अगर करें तो केस प्रेजेंटेशन वगैरह भी, लाइव केस प्रेजेंटेशन हम लोग एक दो इंक्लूड कर सकते हैं तो ज़्यादा बेटर होगा।
नहीं, जैसे आप लोग का एपीआई वाला हुआ था ना, बहुत अच्छा हुआ था। पीजी स्टूडेंट प्रेजेंट कर रहे थे, 4 एक्सपर्ट 5 एक्सपर्ट चेयरपर्सन के तरह थे, तो सब लोग इन्वॉल्व भी हो गए और वो अच्छा था, रियल वर्ल्ड एक्सपीरियंस जैसा ना केस डिस्कशन हुआ, दैट वी कैन डिस्कस। डॉक्टर केतन, यस
सर, थैंक यू सो मच। जैसा जीना सर ने बोला कि पटना विल बी द सेंटर फॉर हेमाटोकॉन इन 2027, सो एंड दैट इज़ अ बिग कॉन्फ्रेंस, 4 days कॉन्फ्रेंस होता है पटना में, ऑल ओवर इंडिया से लोग आते हैं। सो अगर हम छोटे छोटे कॉन्फ्रेंसेस अरेंज करते रहेंगे at the level of Patna or at the level of Bihar, then we will be in a practice to arrange that big conference. So institution wise, I think हम हर महीना 2 महीना 3 महीने में एक कुछ शॉर्ट मीटिंग्स प्लान करते रहें, तब हमारे हैबिट हो जाएगी कैसे कॉन्फ्रेंस अरेंज करना है। स्मॉल मीटिंग्स अच्छे से हो जाएगी, देन वी विल बी एबल टू अरेंज अ बिग मीटिंग, एंड हेमाटोकॉन शुड बी आवर नेक्स्ट टारगेट, एंड दैट वी शुड प्रिपेयर फॉर दैट फ्रॉम नाउ।
थैंक यू
राइटली सेड डॉक्टर केतन, मतलब छोटे छोटे ही एडिशंस करके बड़ा हम कर सकते हैं।
हाँ,
तो आइडियाज़ इसी तरह से कोलैबोरेट होती है।
हाँ, है ही डिजीज स्पेसिफिक, हम लोग माइलोमा लिम्फोमा कुछ इस तरह से कर सकते हैं। डॉक्टर संगम शुक्ला हैं, ही हैज ऑलवेज सपोर्ट, तो बताइए कुछ आपसे।
और इट इज़ नॉट ओनली द इंस्टीट्यूशनल, सॉरी टू से, मतलब मैं मिस कर दिया कि हाँ देयर आर सेवरल इंडिविजुअलाइज्ड टीम ऑल्सो जो कि डेडिकेटेड होते हैं। प्राइवेट सेंटर्स आर ऑल्सो कंट्रीब्यूटिंग टू हेमाटोलॉजी, ऐसा नहीं है कि ओनली द इंस्टीट्यूट्स आर कंट्रीब्यूटिंग। तो द आइडिया शुड ऑल्सो बी फ्रॉम द प्रैक्टिसिंग पीपल ओवर बिहार, फ्रॉम ऑल द स्ट्रीम्स, मेडिसिन, पीडियाट्रिक्स, oncology, or from the pathologist also. So if you also have some ideas, you can definitely share. Dr. Sangam, would you like to say something?
ये 2017 से आई एम गेटिंग इन्वॉल्व एंड ही वाज माय इमीडिएट सीनियर इन पटना मेडिकल कॉलेज। तो वैसे तो आई एम प्रैक्टिसिंग हियर, पर्सनल लेवल पे अगर कोई फैकल्टीज़ को बुलाना कुछ करना हो, काफ़ी हमारे कलीग्स भी हैं नेशनल इंस्टीट्यूट्स में हैं, तो अगर उस तरह का कोई टॉपिक लगता है या इस टाइप का, तो आई एम ऑलवेज मैंने आई कैन हेल्प यू। कुछ लोग हैं जो एमपीएन में फादर फिगर हैं, कुछ लोग मैंने मॉर्फोलॉजिकली या क्लिनिकल हेमाटोलॉजिस्ट, तो वैसा होगा तो आई एम रेडी टू सपोर्ट एट ऑल लेवल्स। और प्लस डिस्ट्रिक्ट्स या मेडिकल कॉलेज में जो भी प्रैक्टिसिंग पैथोलॉजिस्ट हैं उन लोगों का भी इन्वॉल्वमेंट होना चाहिए। मेरे लेवल से जो भी होगा आई एम रेडी टू हेल्प। थैंक यू।
हाँ, नहीं जैसे आप रक्त विज्ञान देखते हैं तो यू शुड सेलेक्ट कि इस टॉपिक पे इनको बुला लीजिए। सुजिस्मिता का कॉल आया था कि कोई काम होगा तो बताइएगा तो हम उसको डांटे कि भाई ऐसे थोड़ी होता है कि कोई काम होगा तो बताइएगा, काम क्या है करो भाई, जो काम है उसमें कीजिए, चाहे कोऑर्डिनेशन है, चाहे एब्स्ट्रैक्ट जो है वो एडिट करना है या सॉवेनियर वगैरह ये करना, सारा काम उन लोगों ने ही किया है। तो आप सेलेक्ट कर लो कि भाई ये हैं और इस टॉपिक पे उनको बुलाइए, उनको बुलाएंगे, उनको मेल करेंगे, आप मेल कर दीजिए, वो कंफर्म करेंगे, आएंगे, ठीक है। और बहुत सारे फैकल्टी जो बाहर से आए, तो कुछ जो रेगुलर आते हैं, कुछ लोगों ने अपने इंटरेस्ट से, देखिए हम लोग बिहार में हेमाटोलॉजी नहीं है, बहुत मिनिमम लेवल पे काम अभी शुरू हुआ है, लेकिन इस कॉन्फ्रेंस को लोग जानते हैं। तो कितने लोगों ने व्हाट्सएप किया हमको कि हम आना चाहते हैं, वो पहली बार आए इस वजह से। और तो अच्छा लगता है कि भाई कुछ अच्छा हुआ तो लोगों ने इंटरेस्ट दिखाया, दैट इज आवर अचीवमेंट।
जैसे आपने बताया कि अनप्रेडिक्टेबल काफ़ी कि कितने लोग आएंगे, तो इसके लिए हम लोग जैसे दूसरी जगह कभी फिक्स रजिस्ट्रेशन होता है, तो रजिस्ट्रेशन इज आई थिंक मैंडेटरी कर दें अगर कैसे, मतलब क्या मतलब
हाँ, नहीं रजिस्ट्रेशन होता है और
हाँ,
रजिस्ट्रेशन तो होता ही है, लेकिन जैसे अब क्या होता है कि जैसे आप सोचते हैं ना कि आपको 23rd 24th अगस्त को कॉन्फ्रेंस करना है, तो मेरे साथ क्या होता है कि उस दिन से ही फिर हम जहाँ हैं एजेंडा बना, जो मेरा व्हाट्सएप ग्रुप है, चाहे मेरे बैच का होगा, चाहे मेरे हेमाटोलॉजी ग्रुप का होगा, चाहे किसी मेडिकल कॉलेज का है, उसमें हम शेयर करते हैं। एक बार नहीं 2 बार शेयर करते हैं, वीकली शेयर करते हैं। कोई हमारा दोस्त है जिसको इंटरेस्ट है, कभी कोई केस डिस्कस किया हो उसको व्हाट्सएप कर देते हैं। कभी किसी मीटिंग में हम जाते हैं, कोई आईआई में हमको इनवाइट करता है तो वहाँ हम लास्ट स्लाइड दिखाते हैं कि भाई ये होने वाला है, आप आइए। कभी किसी क्विज में गए तो वहाँ हम कहते हैं कि भाई आज जो कराएगा रजिस्ट्रेशन उसका फ्री हो जाएगा। तो मेडिसिन, पेडियाट्रिक्स, पैथोलॉजी वाले जो रेसिडेंट आए रहते हैं 40-50, उसमें ज़्यादा लोग करते हैं। जो फैकल्टी आते हैं उनको हम कहते हैं कि आपका कम्प्लीमेंट्री रजिस्ट्रेशन है। तो इस तरह से करने से लोगों को पता चलता है और तब हो सकता है कि इतने लोग आते हैं। ठीक है, रजिस्ट्रेशन तो रहता ही है, लेकिन सब लोग इतना बिजी है अपने रूटीन काम में ना कि सोचता है कि अरे यार ये 1000 को कॉन्फ्रेंस था उसमें एक ठो ये भी हो गया। तो और दूसरा है कि इनके इंटरेस्ट के अनुसार टॉपिक को बार बार देखना भी पड़ता है कि इनका इंटरेस्ट होगा कि नहीं, लोग आएंगे कि नहीं आएंगे, 2 हॉल में लोग रहेंगे कि नहीं रहेंगे।
तो जो लोग प्रेजेंट करते हैं उनका तो मैंडेटरी रजिस्ट्रेशन होता होगा ना?
प्रेजेंट माने
जैसे जो बच्चे प्रेजेंट कर रहे हैं ओरल या पोस्टर या फिर उनका मैंडेटरी
रजिस्ट्रेशन तो सबका है।
नहीं मतलब विद सम
नहीं, पैसा बहुत ज़्यादा मायने नहीं रखता है। पैसा हम लोग के लिए ये इम्पोर्टेंट हुआ दैट टेल्स अस अबाउट देयर मोटिवेशन कि वो रजिस्ट्रेशन करा रहे हैं तो आएंगे।
वही
नहीं तो कराने के लिए 1000 करा लेगा, पता चला आया नहीं तो योर रिसोर्सेज बिकॉज इट्स ए लो कॉस्ट।
एक आइडिया मिल जाएगा कि यस यू हैव टू
वही मोटिवेशन के लिए जैसे 1000 ही रखा कि
नहीं उसी तरह का 500 रुपया शुरू में था, बाद में 1000 हुआ।
क्योंकि हमारे सोसाइटी में ऐसे ही होता है, इफ यू वांट टू सबमिट द एब्स्ट्रैक्ट यू हैव टू रजिस्टर फर्स्ट। तो दिस इज मैंडेटरी।
नहीं ये हम लोग का जो कॉन्फ्रेंस है ये इट्स ए लो कॉस्ट कॉन्फ्रेंस, एकदम प्योर साइंटिफिक एकेडमिक। इवन समझो डिनर के समय कोई नाच गाना भी नहीं होता है, इंटरटेनमेंट भी नहीं होता है। पहले 1-2 बार हुआ, उसके बाद उसको भी बंद कर दिया कि भाई ज़रूरत महसूस नहीं होती है। तो लो कॉस्ट है और उसमें कोई भी हम भी आते हैं तो हम कॉन्फ्रेंस सोसाइटी की गाड़ी से नहीं आते हैं, अपने गाड़ी से आते हैं। किसी को भेजना भी है तो अपनी गाड़ी से। कोई इवेंट मैनेजमेंट इसमें इन्वॉल्व नहीं है, नहीं तो वो लोग एक्स्ट्रा 15-20 लाख रुपया लेते हैं इस काम के लिए। तो उन लोग को वोट ऑफ थैंक्स देंगे। उससे पहले कुछ सेशन कोऑर्डिनेटर्स हैं जो कि उनको अप्रिशिएट करना चाहिए और फेलिसिटेट करना है। तो इस बार के लिए ही नहीं, लास्ट 2-3 साल से उन्होंने बहुत हेल्प किया है। आई वुड रिक्वेस्ट डॉक्टर अविनाश, डॉक्टर सुचिस्मिता टू अनाउंस देयर नेम एंड वी विल गिव देम सर्टिफिकेट। प्राइज मनी कौन देगा, एम्स पटना की IGMS? फ्री ऑफ कॉस्ट नहीं, फ्री ऑफ कॉस्ट मत करो भाई।
So we had a team of 8 session coordinators, all postgraduates from IGMS and AIIMS Patna. From Department of Pathology, we have a senior resident who did session coordinating last year also, and she did this year too. She is Dr. Pritika. Pritika is about to finish her senior residency now at AIIMS Patna. But she has done a very wonderful job with coordinating the sessions. She was bang on with the time, everything was managed well. And the other 2 coordinators were the winner of oral paper presentation, Dr. Ritav. He was coordinating.
I will request Dr. Avinash. He is a consultant microbiologist at IQ City Hospital, Durgapur, and he happens to be my batchmate. We are from 96 batch PMCH. So,
and Dr. Sandhya.
I would request Dr. Sangam Shukla ji.
Junior resident, Department of Pathology. She was there for last 2 days and she coordinated well.
Dr. Sangam Shukla is Director, Shukla Pathology Lab. He has done MD Pathology from prestigious PGI Chandigarh.
Next list of session coordinators will be announced by Suchi ma'am.
Dr. Nivedita, JR1 of Pathology Department, IGIMS.
I would request Dr. Avinash to DJ. Thank you. Thank you.
Dr. Almanson, JR1, Department of Pathology, IGIMS.
I would request Dr. Ketan to felicitate.
Dr. Seema, JR1, Pathology Department, IGIMS. Rest of them are left, so we can.
You can collect. Okay. Thank you. Thank you.
Dr. Suman from IGIMS, Dr. Roshita from IGIMS.
So now time for vote of thanks. So I think जितने हैं बाहर उनको बुला लो. कोई है? And तो डॉक्टर अविनाश एंड डॉक्टर सुचिस्मिता, लेकिन कैसे फेलिसिटेट कीजिएगा? सर्टिफिकेट है? हाँ? आ जाओ सर्टिफिकेट लेके आ जाइए. आई वुड रिक्वेस्ट डॉक्टर सुधीर कुमार सर टू फेलिसिटेट डॉक्टर अविनाश कुमार सिंह. ही हैज सेम नेम, मेरा नाम ले लिया है. आ जाओ.
इसलिए थोड़ा लोग जान रहे हैं.
अरे नहीं, आपके कारण से हम जाने जा रहे हैं कि आप एम्स पटना ज्वाइन किए हैं क्या? Thank you. And to Dr. Suchismita. Yes. Thank you. So, हाँ, कोई है? बाहर नहीं है कोई? चलो, very good. So now it's time for vote of thanks. आप लोग रुक जाओ, मैडम रुक जाइए, लास्ट फोटोग्राफ होगा ना, रुक जाओ. So रक्त विज्ञान 2025 has come to an end and many people have helped. So many people have helped that I think I may miss some names. So first of all, thanks to all faculty who has come from outside, and these all faculties, they are very busy hematologists, hematopathologists, hemato-oncologists, bone marrow transplant experts in their place, and they are overburdened with scientific activities. So every week, अब तो इतना कॉन्फ्रेंस होने लगा कि वेडनेसडे को होता है, थर्सडे को होता है, फ्राइडे को होता है. So many webinars, physical meeting, na? So they all participate there, but they agreed to come. And first, when I sent mail to senior faculties, so first response was from, any guess? That, huh? Very good. MB Agarwal sir. Sir is around 75. So last year he came, and maybe I thought that last year he came just to encourage us कि भाई अच्छा काम कर रहे हो, हम आ गए. This time I thought that he will say, no, I am busy. His 6 month is busy. Next 6 month, what plans are there is fixed. So I thought he will write something like that, but his response was, no, I will come, and these are the two topics I want to speak. I will come on this one, Air India flight, this one, and I will buy my ticket myself. but you have to book only hotel and local transport. That is done. And 2-3 days back, he sent his PPTs. These are my PPT. Confirm that you have received. Everything is very this one. And his conferences, people who have attended, you can match your watch with his conference. If it is 9 a.m., his conference starts. Whoever are there, सिर्फ anchor है, moderator है, और speaker है, it will start. This time I thought that we can do something, but it was difficult because we have half an hour delay, 45 minutes delay. थोड़ा सा दिक्कत है, वो धीरे धीरे होगा. All faculty who has come from outside, from our state of Bihar and adjoining states, all delegates, students and faculty consultants from our state, adjoining states, students, all the core members, and these core members has many senior members who are senior in my batch, MBBS, AAs, but they have full-fledged support for this conference. A special thanks to Dr. Avinash Kumar Singh, Dr. Poonam Bhadani Madam, Dr. Ruchi Madam, and Team AIMS Patna for workshop on coagulation. It was well done. Dr. Satish, Dr. Kausal, Dr. Suchishmita, Dr. Vipin, Dr. VN Chaudhary sir, Team IGIMS for workshop on HPLC, and Dr. Santanu sir, who is in charge blood bank Paras HMRI Hospital, and Mr. Samsir, who is this one technician in charge at Paras HMRI, and Team Paras for workshop on SDP apheresis and stem cell apheresis. So these all three workshops were on 22nd. Then Dr. Pritika, Dr. Sandhya, Dr. Almond, and Dr. Ritav and others who had, I think I don't remember the name, but they all helped in moderating the sessions. They are very helpful. Dr. Ketan, then Dr. Rishu, Dr. Asija sir, Dr. Sangam Sukla, so everyone helped. And this time some in between I used to feel कि पहले जैसा नहीं हुआ फिर हमको लगा कि नहीं इस बार कुछ हेल्पिंग हैंड हो गए तो हमको थोड़ा उतना बिजी नहीं हुआ. ये तो पिछले बार होता था कि हर चीज़ हमसे पूछा जाता था कि कहाँ है क्या है इसके बाद क्या उसके बाद क्या, तो लगता था ज़्यादा काम है, तो लगता था कि बहुत ज़्यादा काम हो गया है. इस बार थोड़ा सा रिलैक्स हुए चूँकि लोग थे साथ में, तो हमको कभी कभी लगता था कि पिछले बार जैसा नहीं हुआ. लगता है कि अगले बार थोड़ा सा हम लोग को रेस्ट्रिक्ट करना पड़ेगा, टॉक कम करना होगा ना. लेकिन पिछले बार से हमको लगता है कि इट वाज सक्सेसफुल. नंबर चलते हैं, सीखना है, और उन लोगों का हृदय कितना बड़ा है कि भाई हम तो छोटे से आदमी हैं उनके लिए. स्टेट में एक हेमाटोलॉजी, तो दे हैव अनकंडीशनल लव फॉर देयर चिल्ड्रन, अपने जूनियर्स के लिए, अपने बच्चों के लिए. ऐसा आज लगता है जैसे कि थोड़ा कमज़ोर होता जा रहा है वो चीज़, थोड़ा ज़्यादा मैकेनिकल हो रहे हैं हम लोग. डिजिटल सोशल मीडिया पे रहते रहते सोसाइटी ख़त्म हो गया, जैसे लगता है कमज़ोर होता जा रहा है ना. वी नीड टू स्ट्रेंथन दैट, इट्स वेरी इंपॉर्टेंट. इवेंट टीम, इस बार इवेंट टीम में हम लोगों ने एक्सपेरिमेंट किया, कुछ चेंज हुआ तो अच्छा चेंज आया. एंड दिस वाज सम चेंज. लास्ट ईयर हम लोग करते थे तो रेड कलर रहता था, इस बार हम लोग सोचा ग्रीन कलर रहेगा. तो उससे क्या होगा कि आप सब लोग पेड़ लगाइएगा, ठीक है. इन्वायरमेंट को बचाना है और ध्यान करना है, इसलिए गौतम बुद्ध है वहाँ, ठीक है. तो देन फूड कैटरर्स, जो हमारे साथी लोग पीछे बैठे खड़े हैं, उन लोगों का बहुत सहयोग रहा. बीच बीच में थोड़ा सा वो आवाज़ करते थे बस इसलिए कि हम लोग ध्यान नहीं देते थे. हम लोग आपस में